Sir, good morning, sir.
Good morning, madam.
Thank you so much for coming, sir. You're kick-starting our CARE-PARE 2024. We are extremely happy, and you are our, the lucky mascot. So, thank you so much for all your efforts. And as always, we are obliged to you. Thank you so much. Thank you so much. Sir, please stay back for the inauguration. As soon as you finish your session, we have inauguration. So please stay back for the inauguration. We want a few words of your motivation to us to continue with our CARE-PARE next year as on-site, rather offline, not online. So we would like to invite you next year to Chettinad for the same session.
Sure.
Yes, sir.
My privilege.
Yes, sir. Now I'll allow Jane to start the conference. Thank you, sir.
Sure. Thank you.
Good morning, everyone. Respected HOD, faculties, our esteemed speakers, and dear delegates. Welcome to the third edition of CARE-PARE 2024, conducted by Chettinad Hospital Research Institute, Department of Pathology, under the aegis of Tamil Nadu Pondicherry chapter of IAPM. Thank you all for joining in. We will now start with our first session of the day. I request Dr. Blessy to introduce our first speaker, Rajendran sir.
A very good morning to all. It is my distinct honor and a privilege to introduce a renowned expert in the field of pathology, Dr. S. Rajendran. With an impressive career spanning nearly 4 decades, Dr. S. Rajendran has made a significant contribution to medical education, research, and healthcare delivery. Dr. Rajendran graduated his MBBS from the University of Madras in 1986, followed by an MD in pathology in 1990. He further honed his expertise with following qualifications from prestigious institutions, including the Royal College of Pathologists in the UK and the American Board of Pathology in the USA. Currently, Dr. S. Rajendran serves as a visiting professor of pathology at Sri Ramachandra Institute of Higher Education and Research, Deemed University, Chennai, where he previously held the position of professor and led numerous initiatives to enhance the quality of medical education and been instrumental in achieving international recognition, including JCI and NABH accreditation. Dr. Rajendran's dedication to teaching is evident through his engaging lectures, which simplify complex topics for students and professionals alike. He has delivered an impressive 228 invited lectures and has been actively involved in organizing and participating in numerous conferences. In addition to his teaching and administrative roles, Dr. Rajendran has authored 56 publications, presented 52 posters, and conducted 17 conferences, further underscoring his dedication to advancing the field of pathology. His contributions to medical education and quality improvement have not gone unnoticed, earning him several awards throughout his career. Beyond academia, Dr. Rajendran shares his insights through various YouTube videos, reaching a broader audience and fostering a love for pathology among aspiring healthcare professionals. So, ladies and gentlemen, please join me in welcoming Dr. Rajendran as he shares his knowledge and experience with us today. Over to you, sir.
Thank you very much for the short and sweet introduction. I will. And dear participants, whenever you have a question, you please put it in the chat. I think Gokul will be there and or the organizers will be there. They can stop me in between or we can keep it at the end, whatever you like. So I want this to be very informal. And I want to thank Chettinad Medical College and Research Institute for giving me this opportunity to share my thinking about pathology of pancreas. The pancreatic pathology, people think it is mystified or difficult to understand. Here we are in these 2 days, I will try to demystify and make it as possible. I kindly request all of you to mute your mics. So this will be our game plan for 2 hours, 1 hour today and 1 hour tomorrow. So let us start with the objectives. We will go through normal pancreas because knowing the anatomic location and the histology is very important to understand the pancreatic pathology. Then we will go through the WHO classification and more importantly, the practical classification and how to approach pancreatic lesions. We will see the IHCs used in pancreatic pathology, how to do frozen section, and briefly on grossing, what will be the points we have to include in the final report according to CAP protocol. I will just, can you all hear me and see the slide well?
Yes, sir.
Super. So I will just touch the cytology. I know cytology itself is a big topic, but I will tell you the very, very practical points in cytology. Then we will end it up with the molecular events, because nowadays you have to know the molecular events, and I will end up with a take-home message. Objectives should be, you must know how to do frozen section and grossing, recognize normal and pathology of pancreas. You must have a systematic approach. At the end of this discussion, you will be having that. You should know the essential IHC markers and the salient molecular changes in pancreatic pathology. Pancreas, how the name derived? Pancreas, pan means all, you know, pan-Indian movie. Even for Diwali, many movies are coming. I think Lucky Bhaskar, there is a movie by Mammootty's son, and it's they are telling it's a pan-Indian. So pan means all, and Krias means flesh. So this is an organ which is completely fleshy. That's why it is called pancreas. And it is located in the retroperitoneum. And this anatomic location is very, very important, because we all think pancreatic cancer is very bad. But most of the pancreatic cancers present with a higher stage. That's why they are bad. Stage by stage, skin cancer and pancreatic cancer are the same. But skin cancer, we can identify before it grows, whereas in pancreas is in the retroperitoneum, because of the anatomic location, it's hidden. By the time it compresses the adjacent structures or the bile duct and produce jaundice, we are not able to identify. That's why pancreatic cancer is very bad. And another thing, you see the stomach here. This helps us to pass the endoscopic ultrasound guided probe and biopsy the pancreatic lesions. So I will be talking about it in a couple of slides from here. I just want to highlight the anatomic proximity to stomach and pancreas. So grossly, it has 4 parts: head, neck, body, and tail. And tail is connected with the spleen and uncinate process. And the ducts of the main pancreas and the uncinate process, they drain into the ampulla in the duodenum. And morphologically or histologically, it has exocrine and endocrine. So I used to tell it's like a buy one, get one free. We have both exo and endocrine organs in pancreas, but exocrine constitutes 95%, whereas endocrine constitutes 2%, with the supportive stroma that constitutes 3%. This anatomy is just important to know the biliary system. So right and left hepatic ducts, they join with the cystic duct. So the common hepatic duct becomes the bile duct, and the bile duct comes in, either it opens by itself in the ampulla, or the pancreatic duct joins the bile duct and then they open up in the ampulla. And in Whipple's resection, they cut here the bile duct. And then if it is radical, they will give the whole pancreas. If it is modified radical, they will cut the at the level of the neck, and then they give. So the margins will be proximal duodenal margin, distal duodenal margin, pancreatic shave margin here, because the big blood vessels will be running here, and then the bile duct margin. So these are all the margins we are interested in the frozen sections and grossing. Sampling the pancreatic lesions in any organ, you should know what are all the tissues we may be getting from that organ. So it can be FNAC or endoscopic ultrasound guided. I told you in that previous slide, they pass the probe that has an ultrasound and core biopsy needle. So they can do ultrasound, identify the pancreatic lesion. and then they pass the core through the stomach, and then they sample the pancreatic lesion. But in that way, they get the mucosa and the adjacent pancreatic tissue also, that you have to keep it in mind. This is the CT-guided biopsy, core biopsy. It can be guided or non-guided, but most of the time it is CT-guided biopsy. Or they do partial pancreatectomy, distal pancreas along with the spleen. Or they go for Whipple's resection, where I mentioned the loop of the duodenum with the head of the pancreas and the bile duct. Or they may send tumor or samples from the pancreas for intraoperative frozen section. So these are all the 5 possible specimens from the pancreas we will be getting. And for FNAC and core biopsy, we have to have clinical, pathological, and radiological correlation. We used to talk about it in breast as triple test. It has to be applied in all the organs. And whenever I want you to take a snap of the screen, I will put this sign. Normal pancreas is arranged in lobules that are arranged like a zigzag puzzle. And salivary gland also looks like that. Many salivary gland and pancreatic histology are more or less the same, because salivary glands are also exocrine, but they won't have the endocrine. In the low power, you can identify the endocrineness, and you can see the septa in between the lobules. Lobules are the functional units. And in the lobules, you see the acini and the ducts, and the ducts will be running within the lobule or in the septa of the in between the lobules. So it will be intralobular or interlobular, and this is an example of intralobular, and this is an example of islets of Langerhans. This is the endocrine structure in the pancreas that constitutes 2% of the pancreas. And cartoonistically, you may be seeing the acini here continuing as ducts. And surprisingly, the myoepithelial cells are not there in the pancreas, at least to my knowledge, because we get the myoepithelial cells in all the secretory organs to compress the secretions into the duct system. I don't know why pancreas doesn't have myoepithelial cells. Some of you can take it up as a research project, how the secretions are coming out in the duct without compressing the acini. These ducts, there are mainly 4 types: intercalated duct, intralobular, interlobular, and main duct. And these are divided because of the anatomic locations and the size. And all the ducts will have a periductal collagen. That will be very less in intercalated duct, whereas in main duct it will be more. Why we have to know this? Lesions happening in the intercalated and intralobular ducts are non-palpable, and they are called as PANIN, pancreatic intraepithelial neoplasia. And the lesions arising in the larger ducts like interlobular and main pancreatic duct are known as IAPM, intraductal pancreatic mucinous neoplasm. So both PANIN and IPMN are connected with the duct. There is another cystic lesion known as mucinous cystic neoplasm that is not connected with the duct. That understanding is very, very important, because these are all the differential diagnoses. Whenever you get a mucinous cystic neoplasm, you have to see whether they are in communication with the duct. If they are in communication, they will be either PANIN or IPM. Super. So I hope you all understand this concept of intercalated intralobular duct giving rise to PANIN, and interlobular and main duct giving rise to IPM1, and the mucinous cystic neoplasm is not connected with the duct system. So this is the high power view to show the acini and mainly the endocrine structure, what we call as islet cells. And these are the acini, they will be more pink, whereas these endocrine cells They won't have ducts. As you know, these are endocrine. They have blood vessels that acts as ducts, and they are more uniform in appearance. And see the salt and pepper chromatin pattern. How it is a fine chromatin uniformly distributed throughout the nuclei. We call it salt and pepper. This is one of the features of neuroendocrine tumor, and some of these cells may look like plasmacytoid. So those two are features of neuroendocrine cell. And these islet cells can be alpha, beta, delta, PP, or vasoactive intestinal peptide secreting cells. 75% are beta cells that secrete insulin. You all know alpha secretes glucagon, delta is somatostatin, and pancreatic polypeptide cells and vasoactive intestinal peptide cells. These are all the components of functioning components of the islet cells of the pancreas. This picture shows you there's a lot of lymph nodes all around. Why I am putting this, when they are doing a resection, you have to submit these lymph nodes differently. Usually surgeons will send it as different jars. For example, mesenteric lymph node, posterior anterior pancreatico-duodenal lymph node, suprapancreatic lymph node, intrapancreatic lymph node, infrapancreatic lymph node. Like that, they will label it and they send it. And the prognosis depends. For example, if it's a head of the pancreas lesion, if the lymph node mesenteric nodes are positive, the prognosis may be worse when compared to the nodes positive in the pancreatico-duodenal area. And one more thing you have to know, the lymph node metastases which are not regional, it is considered as M1 disease. For example, if it is the middle colic lymph node, then it will become M1. It is not N3. It will become M1. That you have to know for all organs. Non-regional lymph node metastasis is considered as metastatic rather than nodal metastasis, systemic metastasis. There are some interesting clinical presentations for exocrine and endocrine neoplasms of the pancreas. For exocrine pancreas, when in the duct is obstructed, it produces jaundice. And those are all the patients who come in an earlier stage. Earlier stage means stage 2 or stage 3. Because of the jaundice, we identify them. But if the lesion is in the distal pancreas near the tail of the pancreas, we won't get it until stage 4. The mucinous lesions produce migratory thrombophlebitis, and the acinar tumors produce polyarthralgia and fat necrosis. The endocrine tumors, alpha cell tumors or glucagon producing tumors produce 4 Ds, dermatitis, diarrhea, diabetes mellitus, and DVT. And the insulin producing tumors, they produce Whipple's triad. Somatostatin produces diabetes mellitus, cholelithiasis, and steatoria. And the pancreatic PP cells, they produce Zollinger-Ellison syndrome-like picture because they mainly secrete gastrin. And vasoactive intestinal peptide produce WADA syndrome, okay, watery diarrhea, hypokalemia, and achlorhydria. So these are all the clinical presentation of exocrine and endocrine pancreas. Coming to WHO classification of pancreatic tumors, we are now having the 5th edition of the Blue Book, and that has come in 2019. According to that 2019 update, the pancreatic tumors are mainly divided into primary and secondary. This classification is very, these types are very important. Whenever you see tumor in any organ, you have to say whether it is primary or secondary because the treatment is totally different. When it is a primary tumor in the pancreas, the exocrine tumors produce 95% of the pancreatic lesions, whereas endocrine tumors are only 5%. That you have to understand. In the exocrine pancreas, it's epithelial that comes in benign, pre-malignant, and malignant lesions. In the endocrine, it is a neuroendocrine tumor, neuroendocrine carcinoma, mixed neuroendocrine, non-neuroendocrine carcinoma tumors. In the benign tumor, we have acinar cystic transformation and serous cystoadenoma. In the pre-malignant, we already talked about PANIN. PANIN grade 3 is considered as pre-malignant. Now it is reclassified as high-grade PANIN. IPMN with low and high-grade dysplasia. IOPN is, this is intraductal pancreatic mucinous neoplasm. Here intraductal oncocytic pancreatic neoplasm and intraductal tubulopapillary neoplasm. The IPMN itself, now it's divided into 3. The IPMN subtypes I will be talking in a minute. So remember, IPMN, IOPN, oncocytic, ITPN, tubulopapillary, intraductal tubulopapillary neoplasm. Then MCN. MCN is mucinous cystic neoplasm with low-grade and high-grade dysplasia. These are the pre-malignant conditions. And in the malignant conditions, it's a ductal adenocarcinoma, acinar cell carcinoma that can be solid and cystic, solid pseudopapillary neoplasm, and pancreatoblastoma. So these are all the epithelial tumors arising from the exocrine cells in the pancreas. The endocrine tumors have to be divided into non-functioning and functioning. And the functioning, depending upon the hormone they secrete, they are divided into insulinoma, gastrinoma, vipoma, glucagonoma, like that. And then the size is very, very important in neuroendocrine tumor. If you see a lesion less than 0.5 centimeter, then it is called microadenoma. These microadenomas are multiple usually, and they are seen in familial syndromes. When it is more than 0.5 centimeter, then only we can call it as neuroendocrine tumor. And we will talk about how to differentiate neuroendocrine tumor from neuroendocrine carcinoma and mixed tumors further down the discussion. So we talked about WHO classification, but how to do a practical approach. First, we have to divide the lesions arising from exocrine or endocrine. In the exocrine, they can be from the acini, from the ducts, or from the stroma. In the endocrine, it can be either from the islets or from the stroma. And previously, we used to say this as a classification of lesions, congenital traumatic inflammatory neoplastic. Now that system is gone, we are having a pattern analysis where you have to ask 4 questions whenever you see a lesion. Is it proliferative or not? Is it cytologically atypical features present or not? Is there invasion or not? Is there metastasis or not? So these are the 4 questions you have to ask: proliferation, atypia, invasion, and metastasis. And whatever answers you get, that gives a pattern of the tumor or lesions. So it can be non-proliferative lesion, proliferative lesion without atypia, non-invasive proliferative lesion with the atypia, invasive proliferative lesion with the atypia, invasive proliferative lesion with metastasis. That can be either regional or systemic. So this is the pattern analysis that is followed in almost all the organs now. So depending upon the pattern analysis, this is the flow chart given in the John Hopkins app. There are very nice apps. I will talking about them in the references in John Hopkins. And most of the gross pictures are from the atlas in that app. And you can see the beauty of the images further down the presentation. To make it simplified, first we have to see whether it is solid and cystic. And what are the differential diagnoses? It can be chronic pancreatitis, ductal carcinoma, pancreaticoblastoma, acinar cell carcinoma, neuroendocrine tumor, solid pseudopapillary neoplasm, serous cystadenoma, mucinous cystic neoplasm, and intraductal papillary mucinous neoplasm. These are all the possibilities. So first divide them into solid and cystic. When it is cystic, see is there any true lining epithelium or degenerative cyst. When it is true lining epithelium, if it is made up of serous cells, then it is serous cystadenoma or serous cystic neoplasm. When it is having mucinous epithelium, you have to see whether they are connected with the ductal system and what is the stroma around. If it is not connected with the duct and it is having ovarian type of stroma, then it is mucinous cystic neoplasm. If it is connected with the duct and the stroma is having more collagen, then it will become IPMN. And as I told you, it can be IOPN when you see oncocytic cells, or tubular papillary when you see the tubules. In the solid, you have to see whether they are arising from epithelium and stroma. When it is epithelial lesion, you have to see whether the glands are there, irregular glands, desmoplasia, and mucin secretion. If the glands are infiltrative with incomplete lumina, nuclei showing pleomorphism means variation more than 4 times. Take the smallest nucleus and the largest nucleus. If the difference is more than 4 times, then it is pleomorphism. And whether the tumor cells are seen next to the muscular vessels, perineural and venous invasion, and necrosis. You have to look for all these things. When these are not seen, then it is chronic pancreatitis. When these are present, it is ductal carcinoma. When you see solid cells with minimal or hyalinized stroma, you see whether they are acinar pattern with prominent nucleolus and trypsin and chymotrypsin positivity. And in addition to the above findings, are they showing squamousness? When you see acinar pattern with nucleolus, trypsin, chymotrypsin positivity, and squamousness, it's a pancreaticoblastoma. Otherwise, it is acinar carcinoma. When you see ribbons of tumor cells with the salt and pepper chromatin pattern that are positive for synaptophysin and chromogranin, it's a neuroendocrine tumor. When you have solid and pseudopapillary pattern with cells having nuclear grooves, and when CD10 and beta-catenin are positive, then it is solid pseudopapillary neoplasm. If it is a degenerative cyst, you have to look for all the tumors because cystic degeneration can happen in any of these tumors. Take a picture of this. I will just leave 30 seconds so that you can understand this flow chart. Any questions so far? Madam, any questions in the chat box?
No,
Not
sir.
yet.
Not yet. Okay, super. And this is the cartoon. I make very few cartoons, and this is my own cartoon. And most of the other pictures I take it from internet. I also have my pictures, but I want superlative quality pictures. That's why I take from the internet, because my pictures are not that good. And the cystic lesions, as I told you, are they connected with the ductal system or they are outside? When they are connected with the ductal system and they are palpable, then it can be IPMN, IOPN, and ITPN. If they are non-palpable and they are arising from smaller ducts, then that is PANIN. Two cystic lesions that are not connected with the ductal system, if it is mucin secreting with ovarian stroma, it is mucinous cystic neoplasm. If it's having a sieve-like pattern, then it is serous cystadenoma. And you have to remember, invasive carcinoma can be seen in any of the cysts. For example, MCN can be associated with the invasive carcinoma, PANIN can be associated with invasive carcinoma, IPMN can be associated with the invasive carcinoma. We will see the examples down the presentation. So I told you the PANIN is a non-palpable lesion and IPMN is a palpable lesion, and they have the criteria. The size is, for PANIN it is less than 0.5 centimeter, whereas IPMN is more than 1 centimeter. Nowadays the sizes, they take it in the radiology, because you know by the time we get the pancreas, we fix it, the size difference may be there from real to artifactual lesions. So they take the radiological size, and as I told you, PANIN is not visible. Microscopically, it shows only gastric foveolar type of epithelium, whereas IPMN can have 3 types of epithelium: gastric epithelium, intestinal epithelium, and pancreatico-biliary epithelium. Molecularly, GNAS is very, very important in the IPM. This is one of the questions they ask in the exam. What will you do when you aspirate a cyst, and how will you process? Number one, send it for cytology. Number two, send it for amylase level. Number three, send it for molecular change with GNAS. When GNAS is positive, it is IPM. And here you can see 0.5, less than 0.5 and 1 centimeter. So what will happen if the lesion is between 0.5 to 1 centimeter? Give you a descriptive diagnosis with both as differential diagnosis. But when you see finger-like papillae, then it is incipient IPM, and go for GNAS. When GNAS is positive, that confirms the diagnosis of IPM. Please have a very clear, crystal clear idea of PANIN and IPM, and it's very, very easy. PANIN, non-palpable, non-visible gastric foveolar epithelium in the minor ducts. IPM, palpable, visible, 3 types of epithelial lining, and GNAS positive. And they arise from the major ducts. That's why they are palpable and visible. So again, I may be repeating some of these again and again just to make sure it is embedded in the white matter. In pathology, you have to read 3-4 times, then only you will remember. We are not Yendran like in that movie, Rajini's movie, where you just pass the book in front of your eyes and remember everything. It is not a reality. So I will be repeating some things again and again just to make sure you understand and you got the concept. So PANIN again, microscopic ductal connection, non-invasive. The lining epithelium can be flat or papillary, and architectural and cytological ATPR may present, and they are mainly lined by gastric foveolar type of epithelium. Previously, PANIN is divided into 1A, 1B, 2, and 3, but now we follow the two-tier system. I will show you the two-tier system. Normal, PANIN 1A, 1B, PAN 2, PAN 3. 1A, 1B, and PAN 2, PANIN 2 are now low grade, and PANIN 3 is high grade. And this table gives the features, how you differentiate normal from low grade PANIN and high grade PANIN. Normal, the lining epithelium is flat, cuboidal in shape, no stratification, no ATPR. This cribriform and comedo, I will just leave it because it is seen only in the high grade PANIN. Okay, so normal, flat, cuboidal cells, no stratification, no ATPR. In the low grade, it can be flat or papillary. They are columnar. The cuboidal cells become columnar in PANIN. Stratification is present. ATPI is mild to moderate in low grade. Whereas in high grade, it is mainly papillary. The cells are again columnar. The cells are stratified. The ATPI is very severe. And as I told before, the cribriforming and comedo-necrosis is very characteristic of high-grade PANIN. So we will see the picture. So this is the two normal pancreatic ducts. This is more like intralobular duct, and this is interlobular. You can see flat lining epithelium, cuboidal cells without stratification or ATPR. So this is normal. Here they become columnar, okay? But there is no ATPR. It looks normal, and focally it is stratified, and so this is PANIN low grade, okay? So this is columnar cells, and look at these nuclei. They are mainly in the inner 1/3 or trying to go into middle 1/3. They are not in the upper 1/3. And all the nuclei are running in one direction. These 2 points are very, very important to differentiate low grade and high grade. In high grade dysplasia, the nuclei will reach the top of the cell, and there will be loss of polarity. I will show you in the pictures. And in addition to that, if you see cribriforming and comedo-necrosis, it is high grade. So this is low grade. This is again columnar cells slightly thrown into papillary folds, and the nuclei are again confined within the middle 1/3 of the stratification, and there is no comido or forming, and the polarity is maintained. Polarity means you draw a line all along the long axis of the cells, and all the nuclei will be traveling in one direction. That means the polarity is maintained. For example, take this cluster, and when you draw a line along the long axis, they will be parallel to each other. So that's what we call polarity is maintained. And to see the polarity, the nuclei has to be elongated. If the nuclei is round, we cannot assess the polarity. Unfortunately, many books are not mentioning that. They think it is understandable, because when it is round nuclei, you can draw a line along the long axis. There is no long axis for the round nucleus. So this is also low-grade columnar cells thrown into mild papillary folds. Stratification is there, and the nuclei are confined to the middle 1/3 of the cells. Here also the stratification, columnar cells, the nuclei are not touching. They are trying to come, but they are not touching the top of the cells, but the polarity is maintained. Look at here, all the nuclei are traveling in one direction. Look at here, all the nuclei are traveling in one direction. There is no cribriforming or comedonecrosis. Here you can see nice low grade. Probably this may be going into high grade, but it is still low grade because of maintenance of the polarity, and the nuclei are in the middle 1/3. You can see here cribriforming in the low power itself. So this is high grade. And look at the nuclei reaching the top, high grade. And look at the loss of polarity. I will show you the loss of polarity. See, this nuclei runs like this. This nucleus runs like this. This nucleus is running like this. All the nuclei are running in different directions. For simplicity, I used to tell the traffic in the national highway is polarity maintenance, whereas traffic in front of Chettinad Medical College or Ramchandra Medical College, polarity is lost because all the vehicles are running in different directions. Whereas in national highway, all the nuclei are running in the same direction. So this is high grade. And that's all about PANIN. Now we are moving to IPM1. If you have any questions, please type in. I will just give 30 seconds. Okay. Madam, if there are any questions, let me know, madam.
Yes, sir. Not yet, sir.
Super. So IPM1, as I told before, more than 1 centimeter. It can be anatomically, it can be from the main duct or branch duct. Histologically, it is gastric, intestinal, and pancreatico-biliary. Here, see the duct, and see the lesion is connected with the duct, and it is visible more than 1 centimeter. So this is IPM1. Again, dysplasia, what I mentioned is again mentioned in this table. So normal, low-grade dysplasia, high-grade dysplasia, single layer, nuclear basal, mucin present, no mitosis, no apoptosis. Low-grade dysplasia, stratified, polarity is maintained, no cribriforming, micropapillae or comedonecrosis, nuclei middle 1/3, mucin is absent. Normal mucin is present in low grade and high grade. Mucin can be absent, or in low grade, mucin can be present. Macronucleoli, again high grade. Polarity is lost, cribriforming, nucleus reaching the upper third and seen at the apex of the cells, and macronucleoli, mitosis and apoptosis. This is high grade. And this dysplasia, this table is good for any tubular organ. For example, stomach, small intestine, colon, bile duct. You can apply this criteria for all the tubular organs. It's a beautiful section from the duodenum. You can see the major duct filled with lesion more than 1 centimeter palpable. So this is from the low power itself, it is IPM. And when you see the lining epithelium, these are like gastric foveolar epithelium, and the nuclei are at the base, no cribriforming, no micropapillae, no comedonecrosis, and the polarity is maintained. So this is low grade gastric type of IPM. Here you can see a lot of goblet cells and they are arranged in villi. These are like intestinal type of IPM, again low grade. Here the lining epithelium is more like pancreaticobiliary, and there is micropapillae, there is cribriforming, and the nuclei are reaching the top, and loss of polarity. Look at here, this nucleus is running in this direction, this nucleus is running in this direction, this nucleus in this direction, this nucleus in this direction. So loss of polarity. So this is IPM and pancreaticobiliary type high grade. Again, low power view of IPM and high grade. Higher power view of IPM and higher grade. And remember, I told you any cystic benign lesion can have invasive carcinoma. This is a beautiful example. I have given the name of this beautiful pancreatic pathologist from University of Pittsburgh in the references. He takes very nice pictures. So this is a pancreatic distal pancreatectomy. You can see the cystic lesion along with the more solid lesion here. And microscopically, you can see invasive carcinoma, poorly defined glands, the growth near the muscular vessels, and apposar glands and glands infiltrating the fat. These are all the features of pancreatic carcinoma, NOS. So pancreatic cancer, and the associated cyst shows IPM with high grade dysplasia. So both IPMN, PANIN, MCN, serous cystadenoma can be associated with cancers. So you have to take adequate sections, and if there is an area of a doubtful lesion in the gross specimen, you alumbate that area, because we have to identify the tumors associated with the benign lesions. And we talk about perineural. This is a beautiful example of perineural and intraneural. And in the exam, there is one more mnemonic. Perineural invasion is seen in 3 Ps: parotid, pancreas, and prostate. Please remember, parotid, pancreas, and prostate adenocarcinomas can have perineural invasion. This is a cystic lesion. You can see here connected with the major duct, and this is having a ATP1B1 BRCA fusion. So this classic of intraductal oncocytic papillary neoplasm, but you cannot diagnose it grossly. You have to look at the microscope. You can see the high grade, the low grade dysplasia with oncocytic cells that can be appreciated very nicely in the higher power. This is again low grade because they are not that much stratified, and all the nuclei are running in one direction. No comedonecrosis or no severe ATP. This is another intraductal lesion called as intraductal tubulopapillary neoplasm. This is a new terminology in this current WHO classification. This is also intraductal, but morphologically it shows tubular and papillary structures, and it is of high grade dysplasia, and this totally lacks mucin. So when you see abundant mucin, low and high grade dysplasia, papillary, comedo without comedo type necrosis, it is IPM. Whereas ITPN can have minimal to none of mucin. Usually it is high grade dysplasia. You see a lot of tubular structures, and comedo-like necrosis is very common. So this is a classic picture of ITPM. Okay, here you can see a lot of tubules, solid, non-mucinous. You don't see mucin at all. This is again the highest power. See the tubules, high grade dysplasia. Here polarity you cannot assess because most of the nuclei are round. So this is ITPM. This is another cystic neoplasm and multiloculated filled with mucin. And another thing I forgot to mention, these are seen, the mucinous cystic neoplasm are seen only in females. Remember, I mentioned we see ovarian type of stroma, so it is seen only in females. And more importantly, no duct connection. See the ovarian type of stroma, mucinous epithelium. This will look like a mucinous cystadenoma of the ovary, but it is in the pancreas. And this is low grade. All cystic lesions, whatever we have seen, PANIN, IPMN or MCN, we have to see whether the dysplasia is there or not. And whenever there is dysplasia, we have to see whether it is low grade or high grade. When it is high grade, we have to see is there any adjacent carcinoma. Again, low grade MCN, you can see very nice ovarian type of stroma. And these ovarian type of stroma are nicely positive for progesterone receptors. And this is like a normal, and this is low grade dysplasia, and here it becomes high grade dysplasia. See the cribriforming. See the nuclei coming to the top. Okay. Look at the low grade. The nuclei are still in the middle 1/3. So this is a mucinous cystic neoplasm with the invasive carcinoma here. Look at the number of mitosis. This is another invasive carcinoma arising in a background of mucinous cystic neoplasm. So the main differential diagnosis is MCN and IPMN. This is very, very important because the prognosis is totally different. This is usually seen in females, common in the tail, multilocular, no duct connection. This is very, 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 very important. Since it is not connected with the duct, endoscopically you never see mucin at the ampulla, whereas in IPMN, they are connected with the duct system, so they will produce a lot of ampullary mucin. Ovarian type of stroma is a must, and it can be associated with carcinomas. And whenever I have a table like this, I will remember the features of one of the lesion. So the opposite is for the other lesion. If you try to remember both, you will get confused. So I will try to know the features of mucinous cystic neoplasm or IPM, not both. This is another characteristic lesion, and you can see there are two lesions here. And this is, if you have seen once in your lifetime, you won't forget. This is like a sponge-like pattern or sieve-like pattern, very, very classic of serous cystadenoma. And it can be, when it is multiple, you have to think of von Hippel-Lindau syndrome because it is associated with abnormality in the VHL gene. This is another lesion with a sieve-like pattern with a central scar. And this is how it will look microscopically. This is the adjacent pancreas, well circumscribed lesion, multiple cystic spaces lined by cuboidal cells with a clear to eosinophilic cytoplasm. And when you do with the PAS, they will have a lot of glycogen, PAS positive, PASD negative material. And if you do VHL gene, they will be positive. I will show the picture down the presentation. Hyperview, again, PAS will show a lot of glycogen, clear cells. This is another cystic lesion known as acinar cystic transformation. Previously, it is called as acinar cell adenoma. That can also be multiple, and these are pancreatic duct. See how beautiful this gross image is. See one of the duct running here, another one running here. This lesion is connected with the duct. The acinar cystic transformation may be connected with the duct. And microscopically, this may, on the low power, this may look like a serous cystadenoma. But when you go to high power, you can see acinar type of cells as well as ductal type of cells that are seen best in the high power. These are ductal type of cells, whereas these are acinar type of cells. If you are in question, you can do double immunohistochemistry. The ductal cells are brown and they are positive with CK19, whereas the chymotrypsin is red and they are staining the acinar type of cells. So the acinar cystic transformation or cystic transformation of acini shows both the ductal and acinar type of cells with a lot of cystic spaces that can be connected with the ductal system. Now we are entering into the ductal carcinoma. I think I will finish with this for today. Grossly, it is like a serous carcinoma of the breast. Okay, very fibrotic, and microscopically you can see lot of sclerosis and see the main duct. It is connected with the ductal system. Microscopically, there are 7 types: ductal carcinoma NOS, colloid carcinoma, micropapillary carcinoma, signet ring cell carcinoma, medullary carcinoma, adenosquamous, hepatoid, and undifferentiated. Undifferentiated, we have 3 subtypes that are anaplastic, undifferentiated carcinoma with osteoclast-like giant cells, undifferentiated carcinoma that can be sarcomatoid or can have both epithelial and stromal malignancy called carcinosarcoma. So these are the main types of ductal carcinoma of the pancreas. We will see individual pictures, and these numbers, I don't know why can they come up with one number. See here, for colloid carcinoma, you have to see more than 80% of the tumor made up of mucinous pool with floating cells. Adenosquamous carcinoma, you have to have more than 30% of squamous epithelium. Anaplastic carcinoma, you have to have more than 80% of tumor cells showing anaplasia. Micropapillary, you have to have more than 50% of tumor showing micropapillary pattern. For practical purpose, I use 50%. Okay, easy to remember. But I will always check with the books whenever I am seeing squamous component, how much is the component needed for the diagnosis. So this is a classic ductal carcinoma NOS. I told you grossly it is serous, and you can see a lot of desmoplastic stroma in the background. And these glands are irregular. Normal glands are usually round. For example, here, these are normal glands. Whereas malignant glands, they are angulated or incomplete. This is good for any adenocarcinoma. For example, breast or colon or stomach. Those malignant glands are angulated or irregular or incomplete. And in the pancreas, you see in addition perineural invasions. And these tumors may be seen adjacent to big blood vessels. So infiltrative, incomplete lumina, nuclear variation more than 4 times next to muscular vessels, perineural vascular invasion and necrosis. These are very characteristic of ductal carcinoma of pancreas NOS type. See the nuclear pleomorphism. Look at the smallest cell, look at the largest cell, more than 4 times. That means pleomorphism, and see the comedonecrosis here, and look at the mitosis. Here, nice perineural invasion. Here, we don't know, is it vascular invasion? Is it IPM1? To me, it looks more like a vascular invasion because our tumor cells lining the vascular-like channels. And immunohistochemically, whenever doubt, you can do P53 and SMAD. P53 will be mutant in pancreatic adenocarcinomas, and there will be loss of DPC4 or SMAD4 in pancreatic carcinoma. The background stromal cells act like internal built-in control, whereas the pancreatic carcinoma cells will be showing loss of SMAD4. Now we are going to see the subtypes of or types of ductal carcinomas. This you can see lot of mucin. So this is a mucinous carcinoma. Pools of mucin with, it's the same thing like in mucinous carcinoma of the breast, but in pancreas you have to see more than 80%. These are signet cells. So this is a signet cell carcinoma. Again, more than 80% of tumor cells should have signet cell features to call it a signet cell carcinoma. That's why in biopsy, you should never call mucinous carcinoma or signet cell carcinoma. You have to say this is carcinoma predominantly showing mucinous features or signet cells, because in biopsy, core biopsies, we don't know what is the rest of the tumor. So we can do the final subtype after getting the final specimen. In case of signet cell carcinoma, you have to rule out primary from the breast or signet cell carcinoma of the stomach. Here you can see nice squamoid components and a glandular component. So this is a adenosquamous carcinoma. Adenosquamous carcinoma, and the squamous component will be positive for P63. This, if you see here, this looks like a hepatocellular carcinoma, isn't it? But when you go to the low power, it's a well circumscribed tumor with adjacent pancreatic tissue. So this is a pancreatic carcinoma with a hepatoid features. This is a medullary carcinoma, well circumscribed tumor, lot of lymphoplasmacytic infiltrate. Tumor cells are arranged in a syncytium. This is the criteria for medullary carcinoma for all the organs: pushing margin, syncytial growth, poor differentiation, and a lot of lymphoid cells. And the minute you see a lot of lymphoid cells, you have to think of PD-1 and PD-L1, because the immune modulators treatment will be very helpful whenever a tumor is showing a lot of lymphoid infiltrate, whatever may be the organ. That you have to keep it in mind. And these are undifferentiated carcinomas. So this is having both epithelial component, and the epithelial component looks very anaplastic. So this is a undifferentiated carcinoma. Here you can see undifferentiated tumor with a lot of necrosis, and you can see osteoclast type of giant cells. So this is a undifferentiated carcinoma with osteoclast. This is undifferentiated carcinoma with micropapillary pattern. These are all papillae without fibrovascular core. And another characteristic feature, they produce artifact, tissue retraction artifact. So they look like a vascular invasion, but these are not blood vessels. So when you do IHC for endothelial cells, no endothelial cell will be there. These are retraction artifact. And why you have to know, these tumors have a very high incidence of lymph node metastasis. The other rare types of carcinomas are oncocytic carcinoma, non-mucinous, glycogen-poor cystadenocarcinoma, choriocarcinoma, clear cell carcinoma, and ciliated cell adenocarcinoma. These are very rare, but I am mentioning here for completion's sake. This is the clear cells, and whenever you see clear cell, you have to differentiate metastatic renal cell carcinoma. But clear cells can be seen in more than one type of pancreatic tumors: solid papillary, pseudopapillary tumor, serous cystadenoma, neuroendocrine tumor, ductal carcinomas, picomas can have clear cells. So you have to be careful, look at the adjacent areas, what they are showing. If it is totally clear cells, as I told you, rule out mets from RCC and do immunohistochemistry to subtype the clear cells. And this is adenocarcinoma made up of ciliated. So these are ciliated columnar type of adenocarcinoma. This is a new entity. It's been described in the pancreas, I think in the lung also, and other organs also. So ciliated columnar cell adenocarcinoma. So I think I want to finish it here for today's. We will see the rest of the lesions tomorrow. So I want all of you to have fun and enjoy the moment. Most of the time we think about the future, or we think about the past, and we are not enjoying the present. I kindly request all of you to enjoy the present, and I will see you all tomorrow. Thank you very much. Back to you, madam.
Sir, amazing, sir. Wonderful. I've gone back to my PG days. I have learned so many new points today. I mean, the last, of course, I just now realized that we can have clear cells in NETs as well. That was my latest learning. Of course, I have learned so many points here. And I do have 2-3 questions, but I think I will leave it for tomorrow morning, because tomorrow morning we are at leisure to ask you many questions. Amazing, sir. I just went back to my PG days, and I have Shirley, Dr. Shirley with me. We were like nostalgic PG days, and no wonder you have a great fan following in all around Tamil Nadu, India, and now in US as well.
Yeah, why can't we have the questions today itself? Are you running short of
One
time?
is, yes, one is that I remember in our PG days, we used to read about microcystic serous carcinoma. Is there still an entity or?
No, not in this current WHO.
Yes, sir, that was one. And for us, tubulopapillary is all same as IPM only, because it's so difficult to, to say that this is tubulopapillary. We just simply call it as papillary. That's all, intraductal papillary. So all those
No,
things
when you look back, they look more solid. And in high power, they will have a lot of tubules and no mucin.
Yes,
They
sir.
behave very badly. That's why we have to differentiate from IPM.
Yes, sir.
That's negative. I will be telling these differences in the molecular. But
Yes.
it's very easy, madam. The
Yes, sir.
minute we see a lot of cases, we will get, and now in the online, you can see
Prognosis of this intratubular variant, sir, is it the same as the others?
Ductal tubulopapillary is having a bad prognosis.
Okay. And sir, if we don't have chymotrypsin, how do we differentiate? Because ductal cuboidal cells and the adenoid cells will look similar. Only thing that probably the CK19 will not stain the adenoid cells. That is the only difference, because most of us don't have chymotrypsin at all.
BCL10, madam. If you have BCL10, that will be.
Yeah, BCL10 will, yes, sir. We can
Yeah.
even that is actually not available with many of us. We have to find out.
Yeah. But the Asnar cells, when it is solid, it's difficult. Otherwise, the gland formation is not very classic of Asnar cell. The irregular glands, the Asnar structures in the Asnar cell carcinoma will be more uniform. Whereas in ductal carcinoma, it will be more irregular. But the differentiation in polydifferentiated tumors, it's very difficult. But
Yes, sir.
there is no much treatment difference. The treatment is the same depending upon the stage of the tumor. So what I tell my PGs, whenever you have differential diagnosis, there should be treatment difference. If there is no treatment difference, don't split your hair.
That's very true, sir. It's a great practical lesson.
Yeah. And you talk to the clinician, these are the two differential, what are you going to do? They will say, never mind, as long as it is carcinoma, that's fine.
Yes, sir. Thank you,
Super.
sir. Thank you so much.
Sure. You want me to stay for the inauguration, madam?
Yes, sir. Please, sir. Stay back for the inauguration, sir. Just 25 minutes to 30 minutes, we'll finish our inauguration, and then you can go back to your sleep. And thank you so much for being awake for us.
Sure. I will
Yes,
stop.
sir. Stop sharing.
You
Dr. Jain?
Yes, ma'am.
Can you just verify if Dean, Madam, and the VC sir has joined? Because Dr. MS sir has joined already.
Dean ma'am had a little difficulty in joining in. We are sorting it out. She'll join in.
VC sir, I'm not able to.
Who is the current VC, madam, now?
Professor Sridhar sir, he is a pulmonologist from government hospital, retired from the government and he was also director in the TB sanatorium.
Okay. Is my sharing stopped?
Yes, sir. Sir, good morning, MS sir. Good morning, Dr. Prabhakaran sir. Thank you so much for joining us, sir.
Thank you, madam.
We already had kickstarted our program with Dr. Rajendran's session.
Yes,
He
madam.
is one of the, he's just not expert in one system. He is, what do you call it, the entire pathologist, the wholesome pathologist, pan pathologist, according to sir. And, but just not being a pathologist, he's an amazing teacher.
Yes, madam.
He's got a huge fan following all over the world. Right? Actually, he's a visiting professor in Ramchandra. Now he's in the US doing consultancy. And he's still, I mean, for past 3 sessions of CARE-PARE, 3 editions of CARE-PARE, sir has been with us. And we had one session on AI pathology, I mean, artificial intelligence as well with digital pathology. That was so good. He's got a session tomorrow also, sir.
Tomorrow also. Tomorrow morning he is also.
Morning again, 8 to 9, because that's his sleep time. He's sacrificed his sleep time for us.
Good morning to you, sir. It's a good night to me. Thank you for that.
Thank you, sir. Thank you, sir.
So just 5 minutes, Dr.
Yes.
Dean Madam and DC sir are joining.
Okay, ma'am. We can wait.
Who is the dean, madam, now?
Professor Meenakshi ma'am, she's also a pulmonologist from Madras Medical College.
In the meantime, if the participants have any questions, we can just
Yeah.
we can stop once madam comes.
Sure, sir.
Participants, feel free to answer question me so that I can clear my doubts or I can learn from you. Janani Karthik is trying to speak, but voice is not clear. Janani, are you trying to say something? Kundavai, do you have any questions? You are the only person whom I know.
Sir.
எல்லாம் கரெக்டா சொல்லிட்டேனாமா நீ சொல்லி கொடுத்ததுதான் only taught me pathology. Ask some of your PGs to just to tell what is their learning.
Kundavai herself is not opening up.
Kundavai, or what I tell them, madam, they won't ask any question. So I ask them, tell one learning you did today.
Yeah, that I
So
can do, sir. You can ask her.
No, you ask with the names, madam. I am not familiar with your PGs.
Agatha.
Just
she's
one learning.
So she can tell what she learned today.
Just one point, ma, and you should not repeat the same, so that it should be different.
Yes, ma'am. Ma'am, I learned the differences between PANIN and IAPM. They are very useful. The differences are told.
No, tell one point. Don't beat
One
around.
difference you tell.
Ma'am, the types, ma'am, the PANIN can have only the gastric foveal type differentiation, whereas the IAPM can have gastric, intestinal, and the biliary, pancreatico-biliary differentiation.
Super.
Okay, good.
Thank you.
Pass.
She'll be very happy because she's writing exam now, November. Anybody else who wants to volunteer?
They never volunteer, madam. You pull them.
Yeah. Sidhu.
Ma'am, Sidhu has gone.
Okay. Whoever has answered for Sidhu now will ask one question or will give 1 point. Kirtana.
Ma'am, it was, I could know the differences between low grade and high grade, sir. It was very useful, and usually, normally, pancreas will have flat epithelium with cuboidal cells and no stratification, no ATPA will be seen. Whereas in low grade, we'll see flat or papillary kind of cells with columnar epithelium, and there will be mild stratification. And ATPA will be mild to moderate, whereas in high grade, there will be severe ATPA, and cribriform and comedo is seen only in high grade, sir. This differentiation was very useful, sir. Thank you, sir.
Super.
She is our first year PG, sir.
Oh, very good, madam. First year la ivlo solranga.
Sir, unga teaching appdi, sir.
Unga institute la double promotion la unda, madam.
Yes, sir. Unga institute la irka engaludalla kadiyadhu, sir.
இல்ல நானும் சண்டை போட்டேன். நல்லா படிக்கிறவங்கள சீக்கிரம் பாஸ் கொடுத்துருக்கேன். படிக்காதவங்க மெதுவா போட்டுன்ட்டு அதை ஒத்துக்கணும்.
பெத்தாலஜில எப்படி சார் நல்லா படிக்கிறது டிஃபரெண்ட் பண்றது? அவ்வளோ இருக்கு பெத்தாலஜி, சோ வால்யூமினஸ். 3 வருஷம் போதவே போதாது பெத்தாலஜி படிக்க.
I am a PG in 40th year. Everybody is PG until they die.
Exactly, that's what, sir.
நல்லா படிக்கிறவங்க எல்லாம் ஒரு 2 yearsல முடிச்சிடலாம். இங்க அது மாதிரி கொடுக்குறாங்க. கிரெடிட் எக்ஸ்ட்ரா கிரெடிட் கொடுத்து சீக்கிரம் முடிச்சிடலாம். இந்த பழைய ஆளுங்க இருந்துட்டு ஒத்துக்க மாட்டேன்றாங்க. இந்த 80% ஆப்சண்ட் இதெல்லாம் போட்டு அது வராட்டி 100% ஆப்சண்டா இருந்து பரீட்சைக்கு வா நல்லா பண்ணினா பாஸ் முடிஞ்சிச்சு கதை.
அந்த பிராக்டிக்கலா கிராசிங்லாம் கத்துக்கணும்ல சார்.
எல்லாமே கேளுங்க மேடம், எல்லாம் நல்லா பண்ணிட்டு
Sir, just 2 minutes, sir. My PG has gone to Dean's office because they have some issue in opening up, I believe. Sir is
Sure,
joined.
sure.
DC, sir.
Hello, sir.
Good morning,
morning.
sir.
Madam, good morning. We have joined. You have joined from your mobile of your PG. Good morning.
Yes, sir. Jane, we can start the inauguration. Dean madam is there, sir?
Yes.
Hello.
Yes,
I'm also
yes,
here,
ma'am.
madam.
Good morning, ma'am. Thank you
We
so
are
much,
here.
ma'am.
No, not
So nice
opening.
to see you, and sir.
Good morning. Good morning. Good morning.
Madam, our first
Thank you.
speaker, Rajendran sir, is still with us. We already finished one session. So
Okay.
we'll start the inauguration now, madam.
Okay. Okay, ma'am. Thank you.
Mahil Maran's classmate, madam. You may be knowing him. He was the pulmonologist.
Oh, okay. Okay, sir. Okay. Welcome, sir. Welcome. Dr. Sridhar is also there. Our Vice Chancellor, I will greet him.
Good morning.
Good morning, sir.
So you're from Tanjore Medical College. You're a
Yeah.
classmate of Dr. Magilmar. He joined later with us at Stanley,
Yeah, now he's in ESI hospital.
ESI KK Nagar. Okay, fine. Thank you for joining with us today, sir. Thank you. Nice meeting you
Sir has
online.
already finished one session, sir.
Okay. Shall we go ahead with the inauguration, madam?
Yes, sir.
We'll start with the Dean's address.
We'll start the welcome. We'll start the inauguration, sir. Jane.
Yes.
Ma'am. Good morning, respected dignitaries, eminent speakers, and dear delegates, and welcome to the third edition of Chettinad Academy of Research and Education Pathology Review par Excellence 2024, where we gather to foster collaboration, share knowledge, and advance our understanding of pathology. Now, our request, our organizing secretary, Professor Dr. Rajesh Khanna, Department of Pathology, to give the welcome address. Over to you, sir.
Thank you, Dr. Jane. Am I audible?
Yeah, you
Yes,
are audible.
Rajesh.
It's a great privilege to give me to propose a welcome address for this CARE-PARE third edition 2024. A warm welcome to and a very good morning to one and all present here. And thank you for joining us at this CARE-PARE third edition, whose abbreviation is fully read as Chettinad Academy of Research and Education Pathology Annual Review par Excellence. This CARE-PARE is our annual review of pathology for PGs, which is completely conducted on a digital platform online. This webinar CME is a 2-day program for postgraduates, MD, DNB, who are in their early and mid-course learning, and also for final years and FRCPath aspirants. I am Dr. Rajesh Khanna, professor in pathology at Chettinad Hospital and Research Institute. Myself, Dr. Navya and Dr. Vimal are the organizing secretary for this webinar conference. I take this privilege in welcoming and addressing you all present here. And it's my great pride to welcome our Honorable Vice Chancellor, Sir, Dr. Sridhar, sir, who has always supported us and guided us to conduct conferences and research activities. It's my pleasure to welcome our beloved Dean Ma'am, CHRI, Dr. N. Meenakshi Ma'am, who has always given full support, liberty, free space for conducting academic programs, which helps the budding professionals to gain great knowledge and skills in the field of medicine. I am very honored to welcome our dynamic medical superintendent, sir, Dr. Prabhakaran, sir, who always inspire us to conduct special CMEs of importance. I bid a very warm welcome to all the renowned, most respected, inspiring speakers of this conference, to whom we are very grateful and thankful because in spite of their busy schedules, they have all accepted to share their expertise knowledge. And it's our gratitude and great pride to welcome the speakers individually by names. They are Dr. S. Rajendran sir, Dr. Shirley ma'am, Dr. Pradeep Kumar sir, Dr. Swaminathan sir, Dr. Lawrence D. Cruz sir, Chatura ma'am, Dr. Shruti Mishra ma'am, Dr. Sulakshana ma'am, Dr. Vinay sir, and Dr. Satyamurthy Selvarajan sir, and Dr. Rajaveru Indra ma'am. I extend my warm welcome to all the delegates who are going to be present for these 2 days webinar conference. I'm very humbled and honored to welcome our Tamil Nadu Medical Council observer, Professor Dr. Ramasubramanian sir, who is himself is our surgery department professor. I wholeheartedly welcome our dynamic and enthusiastic HOD Professor Dr. Vijayashree ma'am, whose constant dedication and leadership guides us through to conduct such events successfully. I welcome my beloved colleagues, my postgraduates, who are all the real heroes and members of this organizing team. The Department of Pathology, CHRI, has strived hard and consistently arranged many conferences every year, and this webinar facility has made easier for conducting more scientific sessions through online portals. Sessions held in this program will be interactive with multitudinal slide and cross discussions. And without any further delay, let us enjoy and level our updates from our eminent speakers. And we would be delighted to have your feedbacks and suggestions at the end of the conference. I request Dr. Jain to continue the proceedings. Thank you.
Thank you, sir. Now, I request our head of the department and organizing chairperson, Dr. Vijayashree Raghavan ma'am, to address the gathering.
Good morning, one and all. Namaste. Honorable Vice Chancellor CARE, Professor Dr. Sridhar sir, respected Dean CHRI, Professor Dr. Meenakshi ma'am, and our beloved Medical Superintendent CHRI, Dr. Prabhakaran sir, and my most beloved teacher, and today also I learned so many points, Dr. Swaminathan Rajendran sir, and my very close friend, Dr. Shirley, who's here with me to give the next talk. Of course, my entire team of pathology and my beloved students. It is indeed a great occasion. And this is, as you all know, this is a third edition of CARE-PARE. I will be slightly differing from Dr. Rajesh's version. Till now, yes, it was online. Actually, this year itself, we had planned to do an offline session as well. So we will be doing one more day of offline PGCME. Those who can come to Chettinad, they're willing to come and they'll give. But these are people who are so good in their, in their, not just in their field of subject, but they're good teachers. So we thought we will have an online session first for the benefit of postgraduates. But I assure you, sir, VC sir, that definitely we will have one offline session for our postgraduate as a PGCME, 1 day session, because usually our CARE-PARE is 4-day session. This time we just restricted to 2 days because of 1 day offline session. And actually, I have to thank, I take this opportunity to thank our mentors in our institute, VC sir, and Dean Madam and MS sir, who's always been very, very supportive, not just being supportive, they are, they really motivate the entire department. And whatever little issues we have, it's all been solved by them. And of course, they have a lot of motivation and the great guidance given by all three of them, especially VC sir and Madam, Dean Madam, they never show any kind of hesitation when we go with a problem. And MS sir is always there for us with his cheerful and joyful answers and solutions. And thank you, sir. Actually, MS sir, I have to thank you very specifically because in all the clinical pathological conferences and the clinical society, he makes sure that we do present cases and we are appreciated. Thank you for that. And I also take this opportunity to personally thank all our speakers because without them, it is not going to happen. And they're just not speakers and not experts in their subject. They're all passionate teachers. That makes a lot of difference. Especially today, the morning session, which we kickstarted with Dr. Rajendran sir. As a teacher, I have learned so many points as to how to teach our postgraduates. It's just not my learning for diagnosis, it's my learning for teaching my postgraduates the way it is very, very easy and put very nicely and simply. Thank you so much, sir, for the first session. And as I said, the Pilayar Suri was so good. We are very lucky to have you as our lucky mascot. Thank you so much, sir. And here I have with me Dr. Shirley. Dr. Shirley has been with us from 2016 till now. Every year, twice a year, she comes to our institute to give talk. And I've been inviting her all these 8 years, and she's never hesitated even once. She's here with me to give the next talk. And she's my co-postgraduate from Madras Medical College. It's really, really thankful. And yeah, I'm extremely thankful to Dr. Shirley for coming here all the way. And also my other speakers and other resource faculty in this seminar, in this program, my teacher, Dr. Rajvelu Indra, and my very close friend, Dr. Swaminathan from Tirunelveli Medical College, Professor and Head Department Pathology. And Dr. Lawrence from Ramchandra Medical College, he's also a very close friend of mine. And we also have from Karnataka 4 speakers. Of course, one madam, Dr. Chatra madam, is in Ireland, but she's giving us talk for both the days from Ireland. And the other 3 speakers from Karnataka are Dr. Pradeep from Anand Diagnostic, Dr. Vinay from Bangalore Medical College, Institute of Nephropathology, and Dr. Sulakshana from Cancer Institute, that is Shankara Cancer Institute, Bangalore. And we also have two new persons coming to us this time. Dr. Shruti Mishra from, she's an associate professor from ITBHU Hematology, and my other co-PG from MMC, where all 3 of us were students of our our former VC, Dr. Shanta Madam, that is Dr. Satyamurthy from Singapore. He is actually heading the bone and soft tissue anatomic pathology session in Singapore as a consultant and also as an associate professor of NUS Medical School. He is also giving us a talk. So I welcome one and all for this program. And I also take opportunity to thank them, my heartfelt, sincere gratitude to all of them. And I should say, and rest assured, I should assure VC sir that this department, pathology department, is fairly very young, except me, of course. And it is one of the most dynamic, vibrant, and with their infectious enthusiasm and energy, definitely 2025 CARE-PARE will be a offline session for 3 to 4 days with all your support and motivation. Thank you so much, VC sir, Dean Madam, MS sir, Dr. Rajendran, and Dr. Shirley for being with us. Thank you so much.
Thank you, ma'am. Now I request our speakers to say a few words. Rajendran sir, would you please say a few words?
Thank you very much for involving me in this program. It's an excellent program run by the pathology department HOD madam. The only thing I differ from her is she told that the department is buddingly young, except her. I think she is also very young. All of us are very young. As long as you are learning, you are young. And I thank VC sir, Dean madam, MS sir for their support to pathology department, because we are very nice people and we never argue with you. And your support is very, very important for us to grow. And Osler used to say, tell me your pathology department, I will tell about the medicine. So that's how the pathology department works. And I hope we are helping all the clinicians to do a good job to our most deserving patients. And I want to wish Madam congratulations and all the very best.
Thank you so much, sir. Thank you, sir. Thank you so much. Thanks a lot. As always, next year also we'll expect you with us. Even if it is offline, please make a trip to Chettinad. We'll be very happy. We'll be very, very happy to have you with us.
Sure. Thank you.
Thank you, sir.
Thank you, sir. So I request Shirley ma'am to address the gathering. Ma'am.
Respected Vice Chancellor, sir, Dean Madam, Medical Superintendent, sir, Rajendran, sir, it's so nice to see you after so many years. Though not in person, we never feel that listening to you, it's like as if you're here teaching us. So it's such an honor and a privilege to be a part of CARE-PARE. I want to thank my dear friend, Dr. Vijayashree, who has been there with me right through my postgraduate days. Of course, nudging me to study and, do better and excel. And it has been such a wonderful journey with her the past few years in CARE-PARE, almost being a part of Chettinad Hospital and Research Institute. And it's such an honor again to be here, not just to deliver a talk, but to listen to the other speakers and learn from them as well. And as rightly mentioned, I think this Department of Pathology is such a dynamic, vibrant department with a wonderful, excellent teamwork. And they all, put in their effort together. And each academic program that I've seen over the past 8 years have been so successful. So I wish the Department of Pathology, CHRI, great success in the, future plannings for CARE-PARE, which is going to be, real time, not just virtual from next year onwards. And for all the other academic activities, whatever they plan, I wish them best of luck.
Thank you so
Thank
much.
you for having me here. Thank you.
Thank you, ma'am. Now I invite our medical superintendent, Dr. Prabhakaran sir, to address the gathering.
Respected Vice Chancellor of Chettinad University, respected Dean of Chettinad Hospital and Research Institute, respected young HOD of Pathology Department, Professor Vijayashree Madam, respected organizing secretaries, Professor Rajesh Khanna, Associate Professor Dr. Navya, Assistant Professor Dr. Vimal Manikam, respected organizing committee members, respected esteemed national and international speakers, dear colleagues, and my beloved UG and PG students. I am truly honored to join you all today in this important event of CARE-PARE. Pathology, as we all know, is the foundation upon which much of modern medicine is built. As a surgeon, I can confidently say that no surgery is complete without the vital role played by pathologists. Your precise analysis, particularly in procedures like fine needle aspiration cytology, is crucial in distinguishing between benign and malignant conditions. In fact, it is often FNAC that guides the surgeon's hand, determining the course of treatment and ensuring that the patient receives the best possible care. I deeply appreciate the collaboration between our fields and the critical contributions you make to patient outcomes. It's a privilege to speak before such an esteemed group. Your presence here is invaluable, and I am certain that both students and professionals alike will benefit immensely from this event, CARE-PARE. Thank you.
Thank you so much, sir.
Thank you.
Thank you, sir. Now I request our esteemed Dean, Dr. Meenakshi ma'am, to address the gathering.
Good morning, everyone. I'm really very happy to be part of this annual review. And as you said, that to address all young gatherings, not only young gatherings and also young faculty. I'm very, very happy and congratulate the Department of Pathology. Actually, they are very, very enthusiastic, excellent initiative, very sincere in their work, and especially our HOD of Pathology Department, Vijayashree Madam. I know her for the past 5 or 6 years. Every time, whatever she is doing, she does it with passion and with involvement. Even after having so many health problems, she is actually doing this, inviting all the faculties, not only national faculties, also international faculties, and all eminent speakers. So I congratulate the department for organizing this CARE-PARE. Actually, pathology department, I should say, as a medical superintendent was saying, you are the backbone for all of us. Pathology madam also, she is trying to equip her department with all latest advances. And this review actually is not only for the postgraduates and also for faculties. I think this annual review, we also learn so much, all the pathologists. We hear from so many eminent speakers, and I hope these students should utilize this AV opportunity. Actually, this opportunity, students should understand that so much of effort has gone into preparing reviews like this. Every department is conducting this review for PGs. This not only helps in the exams also, but also in the future. Exams, I know you are having one paper, advanced medical sciences, but still This will help you in future endeavors also. I once again congratulate the department, and I also thank and welcome all the eminent speakers from all over India and international one. I wish the program a very great success. Thank you.
Thank you so much, madam. It's a blessing to be with you, ma'am.
Thank you, ma'am, for your kind words. Now I request our Honorable Vice Chancellor, Sridhar sir, to speak a few words. Over to you, sir.
Good morning, all of you. I feel very happy to be part of this inaugural program, though it is being conducted online, conducted by the Department of Pathology, Chettinad Academy of Research and Education, the Pathology Annual Review for Excellence. I am very happy to note the topics have been chosen with the utmost importance, which will help the budding pathologists as well as the academicians. And I am very thankful to all the faculty who are taking part in this noble endeavor. As pointed out by Professor Shirley, the department is vibrant, taking care of all the latest developments and taking pains to impart this knowledge to the young postgraduates taking career in pathology, not only in Chettinad, but in other institutions also. So being conducted online, it has got wider coverage. I thank the Department of Pathology, the HOD Madam Professor Vijayashree and her team for successfully conducting this program. And as assured by her, I am looking forward to the physical meeting
Definitely,
as well
sir.
in the future.
Yes, sir.
And I wish success for this annual review for excellence. And I once again thank all the faculty for taking part in this academic piece. And I wish all the postgraduates get immense benefit, and the academics and our academic faculty also gets a benefit out of this program.
Definitely.
And I wish every success for this event. Thank you, one and all.
Thank you so much, sir. Thank you for the great motivation and support, sir.
Thank you, sir. Now I request our Organizing Secretary, Dr. Navya, Associate Professor, Department of Pathology, to deliver the vote of thanks.
Good morning, everyone. So we have come to the end of this inauguration ceremony. It is my privilege to deliver the vote of thanks on behalf of Organizing Committee of CARE-PARE 2024. First, I would like to thank Almighty for all His blessings. I express our heartfelt gratitude to our esteemed patrons, Dr. M.A.M.R. Muttaya, Chairman, Chettinad Group, Srimati Geeta Muttaya, Chancellor, CARE, for their unwavering support and vision. A special thanks to our Vice Chancellor, Dr. R. Sridhar sir, for his leadership and guidance. We are very much grateful to our beloved Dean Madam, Dr. Meenakshi N, for her encouragement, and to our MS sir, Dr. Prabhakaran sir, for his continuous support in conducting such events. A special thanks to our HOD ma'am, who is organizing secretary of this program, Dr. Vijayashree R, whose tireless efforts and commitment have been the driving force behind this conference. And I would also like to acknowledge the contributions of organizing committee, especially Dr. Rajesh Khanna sir and all the faculty members and postgraduate students for their hard work in ensuring that every aspect of the event was perfectly planned and coordinated. Now I would like to express our deepest appreciation to our speakers who have taken their time in their busy schedules to share their knowledge with us. We understand how valuable your time is, and we are truly honored that you have chosen to join us and contribute to the success of this conference. Some of the speakers are giving talk for the consecutive second and third year with in the same conference. A special thanks to all of you, sir. And I thank our observer, Dr. Ramasubramaniam sir, for being our TNMC observer. And a special thanks to our IT team in ensuring smooth execution of the event. Finally, I thank all our delegates for joining us. We have delegates not only from Tamil Nadu, from outside Tamil Nadu as well. So I thank our delegates. And we once again thank you all for being here today and contributing to the success of the event. We look forward to the series of insightful and enriching sessions ahead. Thank you all. May this conference be fruitful and inspiring experience to everyone. Thank you.
Thank you so much. I hope that, with the PGs, it is going to be a great learning session for the next 2 days for all of us. Thank you so much.
Thank you.
Thank you, ma'am. Now, go on to the second session of the day.
Good morning, all. It's my great pleasure to introduce our distinguished speaker,
Dr. Shirley Sundar Singh Ma'am, Professor and Head of the Department of Oncopathology at Area, Chennai. Ma'am has completed her MBBS at JJM Medical College, Karnataka in the year 1996, followed by an MD Pathology degree from the prestigious Madras Medical College, Chennai in the year 2000. She has also earned a DNB degree from the National Board of Examinations in 2001. Ma'am has completed her PhD in molecular oncology at the Cancer Institute under the Tamil Nadu Dr. MGR University in the year 2017. Since 2000, she has been contributing to the Cancer Institute, where her work has focused on advancing oncopathology. Ma'am has been recognized for her excellence, receiving the Tamil Nadu Young Women Scientist Award in the year 2013 from Science City, Government of Tamil Nadu, and the Best Doctor Award from the Tamil Nadu Dr. MGR Medical University in the year 2012. With an impressive portfolio of 83 publications in both national and international journals, ma'am is a figure in the field of oncopathology. I welcome you, ma'am. Over to you, ma'am.
So, good morning, participants. I see that there are 56 participants here today. It's, as I mentioned in the inauguration just now, it is a real privilege and honor to be here as part of CARE-PARE. Because, you know, we realize that we are, you know, forever students, forever learning, and that never ceases as long as we keep an open mind. And I think it's very important that, you know, we continue to learn from whatever we hear. So Dr. Vijayashree has given me the topic of grossing techniques for GI tumors. And, you know, she wanted me to talk about best practices and pitfalls. So that is quite a very, you know, broad topic. And GI tumors, because, you know, right from oral cavity to anal canal, I wouldn't be doing justice if I try to rush through everything. So I just thought I will choose two systems, which is not very uncommon. We come across, but, you know, how do we go, you know, how do we approach these systems? And as you all know, grossing is an art. And it is something where we really have to be involved absolutely right from the beginning, because if we don't get it right the first time, then, you know, it's going to be very difficult. So with these few words, my focus today would be on grossing techniques for liver tumors, where hepatic resections are done, and for rectal tumors, where, you know, resection of the rectal tumor is done. So grossing of liver tumor. So when we talk about grossing, you know, once we finished our as postgraduates, most of the time we are very interested in seeing histopath slides. And, you know, we are all focusing more on slides, you know, trying to diagnose and slide for diagnosis and who got the right answer, how we go about it. But only later do we realize, of course, we do a lot of grossing, and it is something that we have observed, like, you know, how our seniors do, they teach us. And then when we are also putting our gloves on, you know, we just take the hints that they provide, and we read up a bit here and there, and we try to, you know, do some grossing. Just having, you know, very, maybe sometimes just an overview, which might be quite narrow at times. But only after finishing post-graduation, when you start practicing, do you realize that you really need to go in depth into the anatomy. So, you know, I opened my Grace Anatomy after I finished MD Pathology, and when I started working, where I realized, particularly when, since I was working, you know, since I joined Cancer Institute, I realized I needed to know so much of anatomy, which I didn't know as a postgraduate, because all I knew was, okay, how to gross a tumor, and, you know, just from the exam point of view. But any grossing, before you go to grossing, it's very important that you know the anatomy of the organ, the structures, its relationship to the adjacent organs, because that is what is going to help you to approach a specimen when you try to gross it. So as far as liver goes, any organ for that matter, they always have surfaces. So these surfaces are something that we just ignore. Once we get a specimen, we are in a haste to cut the specimen and fix it, and then, you know, give bits from the tumor, and all we would like to focus is on the tumor. And now, of course, you know, with the kind of with all the TNM staging and, you know, in-depth analysis coming, we look at the depth of invasion, the resection margins, the lymph node status. But how do we approach a specimen, particularly if it's going to be a liver resection? So you need to realize that the liver, it has a lot of surfaces. in the superior, anterior, right, posterior, inferior surfaces. And there is only one border, which is the inferior border. Otherwise, all the others are surfaces. And it can be divided both anatomically as well as functionally. So as far as anatomy goes, we have the right lobe and the left lobe of the liver. Right lobe is the largest, left lobe being the smaller one and thinner than the right lobe. And of course, the caudate lobe, which is in the posterior and inferior surface, which you will not be able to see it from the anterior aspect if you're trying to look at the liver specimen from the anterior aspect. And the quadrate lobe as well, which is seen as a prominence in the inferior surface. So these are the anatomical lobes. So this is just for us to know how liver is divided anatomically. But when it comes to grossing of liver resections, we need to know something more. So this is what I just told you about, the anatomical division, the anterior view on the left side and the posterior view on the right side. So you can see that broadly the falciform ligament separates the liver into right lobe and left lobe. And posteriorly, you're able to see the caudate lobe, which is kind of medial and posterior to the vena cava, the inferior vena cava, and the quadrate lobe, which is lower down on the inferior surface. So this is something just for us to know that the liver is divided kind of into all these lobes. But when you look at resections or specimens or hepatectomies that is done, how is the approach? How does the surgeon approach a liver or a liver tumor? So that is what we need to understand today. So the French surgeon, the first one who kind of divided the liver into functionally independent segments, he was Quino, and he realized, of course, the Americans also had a different way of doing it, but he realized that there are multiple segments in the liver, and each segment having its own vascular inflow, outflow, and biliary drainage. So based on the vascular supply and the biliary drainage, he divided the liver into 8 liver segments. So it starts from 1 to 8. Earlier, it used to be Roman numericals, but now they have replaced it with Arabic numericals. And all of them are, 1, 2, 3, 4, up to 8. Segment 4 alone is sometimes based on bismuth classification. It can be 4A and 4B. And the numbering of these segments is in a clockwise manner. So this segment 1, so I mentioned about the caudate lobe, that is otherwise known as segment 1, which is located posteriorly. So as a result of which you will not be able to see it from the anterior surface or when you have a frontal view. So these are the segments of the liver. So the lobes are different. The lobes are basically anatomical classification, whereas the segments are functional classifications based on their vascular supply and biliary drainage. And as you can see here, they range from 1 to, it's in a clockwise manner. Okay, it starts from here and it goes like this: 1, 2, 3, 4, 5, 6, 7, and 8. And there are 3 vertical planes that basically divides the liver into these multiple functional segments: the right hepatic vein, the middle hepatic vein, and then you have the falciform ligament. So falciform ligament also divides the liver into its anatomical lobes into right lobe and left lobe, as well as it divides them into segments. So now what are the peritoneal attachments and the ligaments of the liver? Now, why do we need to know this? Because, the peritoneal attachments and the ligaments, they also play a role not only in attaching the liver to the anterior abdominal wall and, the diaphragm and the other peritoneal, it's kind of suspended and it has a lot of relationships. If you can see here, you can see in the posterior aspect, there are a lot of impressions because there are a lot of organs, which are there, the hepatic, the, stomach, the impression of the stomach and the impression of the duodenum, gallbladder. So a lot of organs are related to the liver. So you need to know what are the peritoneal attachments. And most importantly, the falciform ligament, as I mentioned, is something that we kind of receive as part of our surgical specimens as well, where the liver is attached to the anterior abdominal wall. The round ligament, which is important in abdominal surgery, because, they kind of divide the round ligament when they want to mobilize the liver. So this is something that we may not be able to identify grossly as well as the falciform ligament, but nevertheless, sometimes you do receive samples from the round ligament. Then you have the coronary ligament, the triangular ligament, the lesser omentum, ligamentum venosum. So these ligaments, these ligaments, now this is from the anterior side as well as posterior side, they also play a role not only in the anatomical division, but also in the functional division of the liver into various segments. So when do you get a liver resection specimen? What are the indications where resection is performed? Of course, it can be for a benign tumor or a tumor-like condition or a malignant tumor. Now, when you look at malignant tumor, the commonest reason why liver resection is done is hepatocellular carcinoma, depending on whether it involves one lobe or two lobes, whether it's a single focus or multiple focus. There are different types of resections that are done. Then, of course, you have the intrahepatic cholangiocarcinoma, the perihilar cholangiocarcinoma as well. Then carcinoma of the gallbladder, because as you all know, gallbladder is very intimately related to the liver. And when, as far as metastasis goes, one of the commonest areas where resection is done is for colorectal carcinoma, metastasis of the colorectal carcinomas. And there are, as I mentioned, other benign entities as well where liver resections are done. So these 8 functional segments which I mentioned about, they kind of form the basis. So this is these functional segments, as I mentioned earlier, were devised by a surgeon because they realized that these segments, they represent the watershed. So the entire, right lobe of liver, although for us anatomically it is one huge lobe, there are multiple branches of the hepatic artery, portal vein, and the bile duct. And they realize that each segment is kind of, this forms the center for each segment, and they are supplied by this vasculature and drainage of bile. So that's the reason they kind of went into dividing them into functional segment, because the surgery that is done is very often based on their functional segments and not on the anatomical, but very rarely it can be based on the anatomical division of the liver as well. So what are the different types of surgeries that you can come across, the specimens that you can come across? So when we talk about a total hepatectomy, so total hepatectomy is usually done when the patient is waiting for a transplant. And it's a case of multifocal or huge hepatocellular carcinoma, and the patient is offered transplant. So before that, they do a total hepatectomy where all the segments, segment 1 to 8, are removed. So right hepatectomy is where segments 5 to 8. So why am I mentioning this? Because it's very important for us as pathologists to know in depth about the functional segments. Only then will you be able to relate. Because grossing for a liver resection specimen is very important. And not just doing it in isolation, but there has to be a surgeon to help you identify the segments and orient the specimen for you. Otherwise, you would just be going about orienting the specimen in an anatomical way. But when you look at the functional division, it is totally different. So sometimes they say, okay, we have only removed segments 5 to 8. So immediately you should be able to correlate and say, yes, that is a right hepatectomy. So similarly, left hepatectomy, segments 2 to 4, or right trisegmentectomy. Now, all these are based on the size of the tumors and as to how many segments they involve. Then you have the left lateral segmentectomy, where there's resection of segments 2 and 3, and left trisegmentectomy, resection of segment 1 to 5 and 8. So how do you handle resected specimen? Now, this is something that is not specific only to liver, but to any specimen that you receive in the pathology department, ideally in an unfixed state. But of course, sometimes if you have the, the pathology department in another block building or another campus, and the hospital is in another campus, it may not be always possible for us to receive it in unfixed state, because it's ideal to fix it as early as possible within 1 hour, because that is a cold ischemia time. So ideally, it would be good to receive the specimen unfixed. Why do you need it unfixed? Because of course you would want to weigh the specimen, particularly if they are pediatric, specimens. If a hepatectomy is done for hepatoblastoma, then you would want to weigh the specimen and then, record the 3 dimensions accurately. Because we all know that with gut organs and luminal organs, some amount of shrinkage also happens once fixation takes place. So we would like to, weigh these specimens and record all the dimensions when they are still not fixed, and photograph the specimen. So this is something that is very important, because as you all know, as fixation, once the specimen is fixed, the color alters, and there are a lot of changes that take place. You may not be able to see what you saw in the unfixed specimen in the fixed specimen. So that's the reason it's always good to have photography and try to correlate both the macroscopy and the microscopy. Not just that, even macroscopically, how it looked before fixing and how it looked after fixing. Now, when you receive a specimen, first you examine the surfaces, you examine the external surface very carefully. Don't be in a rush to, cut through, and because once you cut it, then the orientation is totally lost. So it's very important that you orient the specimen first with the help of a surgeon, preferably, particularly when it's not a total hepatectomy specimen, and identify the margin, the porta hepatis structures. So it's what is porta hepatis? So porta hepatis is usually on the posterior aspect of the liver, and that will usually have a lot of sutures, because you have the blood vessels and the bile duct, all of them are kind of entering through that point. So it will be quite easy for you to identify this, because that is where you're going to give your resection margins, apart from the resection margins. So identify the resection margins, see if all the surfaces are smooth, if the capsule is intact, before you slice the specimen and fix it in 10% neutral buffered formalin. So gross examination would be like any other specimen, where you look at the size, if there are nodules, if there are tumors, then how many number of tumors are there, where are they located, how close are they to the blood vessels. This is very important in liver, because any invasion of hepatocellular carcinoma into an adjacent blood vessel, it upstages the tumor. So it's very important that you examine all this grossly, otherwise you would miss it, and you might not be able to give a bit from there. And then, of course, look for presence of necrosis, hemorrhage, scarring. And when you describe the nodule, try to describe it as whether it is, just well circumscribed, vaguely nodular, or confluent, keeping in mind the background. So the background is very important. As I mentioned earlier, you need to kind of see whether it's cirrhotic or non-cirrhotic, and then distinguish. Sometimes even cirrhotic nodules, macronodular cirrhosis can kind of mimic a tumor if the size is large enough and the tumor nodules are small. But when you cut through, when the cut surface will help you distinguish a tumor from a cirrhotic nodule. So it's important to look for the background changes. And of course, as I mentioned, macroscopic gross involvement of the vessels, because this is something that has to be recorded not only macroscopically, you need to give the bit also from that part to for accurate pathological staging. So you look at the bulge, the surface, and okay, everything is intact. The capsule, okay, that is the glissons capsule. You see whether it is intact, or whether, at some point, whether it was iatrogenically cut through, or there is some discontinuity. That is something that you need to look at, and slice the specimen before you fix it. So this is very, very important for any specimen, right from breast, because we talk a lot about fixing the specimen and cold ischemia time as far as grossing of breast specimens go, because we are looking for prognostic markers, ER/PR, HER2, and Ki67. So these can really get altered if the specimen is not fixed all right. So extrapolate what you would do for a breast specimen to all the other specimens, because it's important. The cold ischemia time holds good for any specimen, irrespective of where it is, whether it's breast or pancreas or colon or stomach. Everywhere it is very important that we try to fix it as early as possible, and particularly in solid organs like liver, ensure that the slices, that the thickness of the slices is 5 millimeter at least. I don't think that should be a problem in liver, because liver is usually a solid organ, right? And how do you slice it? Usually, if it's going to be a total hepatectomy specimen, then perpendicular to the long axis of the specimen. I'll show you an image later. And in case of multicentric, now if it's a large mass, then you slice it perpendicular to the long axis of the specimen. But if it's a multicentric tumor, on imaging wise, they have said it's multiple nodules are there, then you cut the specimen parallel to the long axis, so that you are able to identify all the nodules in one go through one slice. Of course, photography is something that is going to help you. So here, this is a tumor. It is a single tumor, and you can see this is the external surface. So examine the external surface carefully. This is the capsule, the glissons capsule, that is kind of glistening. There is no defect here. So this is the anterior surface, and this is the posterior surface. So the posterior surface, you will be able to see the porta hepatis. Now, why is it important for us to identify the porta hepatis? Because this is where the surgeon ligates the vasculatures. So when you need to give resected margins, particularly if it's going to be a partial hepatectomy specimen, then apart from the liver resected margin, you need to identify the porta hepatis. And as I mentioned earlier, it's not going to be very difficult, because a lot of sutures and identification marks, staples will be here. So this is where they ligate the specimen and they remove it out. So you need to identify this carefully and identify the artery, the vein, and the bile duct as well. because all of them will be forming a part of the resected margin, status of the resected margins, to say whether it's R0 or R1. Now, this is a single tumor. So as I mentioned, this is the long axis of the liver. And when it's a single tumor, then you slice it perpendicular to the long axis. So since this is the long axis, you put perpendicular slices like this. So when it's only going to be a single tumor, you're not going to have any problem. You'll be able to identify it properly. You can see that there are some areas of necrosis and degeneration here. Please, we need to, document all those factors. So you can see that it's extending throughout. Okay, so even in this slice, you can see that this tumor is there. So it is a single large tumor, which very easily you can be able to measure the extent and, see the extent and measure the thickness of the tumor by serial slices. But if you're going to be having multicentric tumors, then if you just start putting slices like this, that there are chances that, if now these slices, I said it should be at least 5 millimeter, right? But you can see that there are some slices which are thick. So if there's a multicentric small nodule sitting here, then we might miss it when we give such slices. So in such instances, you give, you slice it along the long axis of the specimen. So that helps you in identifying multiple tumors, and it will help you document how many tumors are there. So this is what I mentioned. And the lymph nodes also. Now you look for lymph nodes. So lymph nodes are very often in the hilum of the specimen. So this is the hilum. So what is the hilum? It is the porta hepatis. So this is where the vessels are entering or exiting the liver, and you have the biliary drainage as well. So look for the presence of any lymph nodes here, because unlike other organs in liver, you will not be finding any, lymph nodes around the liver. I mean, it's only liver, right? It's only the parenchymal organ. So lymph nodes need to be looked for here, or they're sent, if they're removed from the portoduodenal, ligament, hepatoduodenal ligament, then it's sent separately by the surgeon. But if it is in the specimen, then you need to look for it in the hilum, and this is the hilum, the porta hepatis. So representative tissues blocks are given from the tumor, usually 2 to 4 sections from the tumor. And if there is fibrosis or cirrhosis, you need to record that. And particularly, why do we need to record that? If it's a non-cirrhotic liver, then you need to look for any, if this might be a cause, it might be a fibrolamellar hepatocellular carcinoma arising for it, or it might be even a hepatic adenoma or focal nodular hyperplasia, which will also be like a nodule, like an adenoma, or it can be a metastasis. So this is something, if it's going to be having a nodular cirrhotic background, then you know that it's, the conventional hepatocellular carcinomas that you'll be dealing with. So when hepatocellular carcinoma, as far as grossing of partial hepatectomy, so I finished grossing of total hepatectomy specimen. Now, partial hepatectomy specimen, that is no different from total hepatectomy specimen, except that, as I mentioned earlier, you need to know the different segments. And if it's going to be a right hepatectomy or a left hepatectomy, which are the segments? Because when you give out a report, grossly, unless the surgeon comes and identifies the segments, it's going to be very difficult for us as pathologists to say which is what segment. But with their help, we will definitely be able to exactly explain, whether it's a single tumor or a multifocal tumor, whether it's involving one segment or multiple segments. And if multiple segments are involved, what are the segments that are involved? Because why do we need to know this? Because this is something that will make the report comprehensive. The staging of liver tumors is based on the size of the tumor and the presence or absence of vascular invasion. But when you give out a report, and if it's going to be multiple segments, 3 or 4 segments that are removed, then it only makes sense for us to give a pathology report which actually mentions which segments are involved. Now, if you don't have the surgeon's assistant, you can always go back to imaging, discuss with the radiologist, and find out which are the segments that have been involved and describe it accordingly. And other structures, so extrahepatic bile duct, so that would form one of the resection margins. And if there is an adherent gallbladder, definitely you need to sample the gallbladder, that is the gallbladder edge, the resected edge, and the lumen of the gallbladder as well, looking for any involvement of the gallbladder by the liver tumor, and the lymph nodes, because around the gallbladder you might have some pericystic lymph nodes as well. So the initial sections always have to be, the sections, it's through the center of the nodule. Now, as far as liver goes, center of the nodule might be because of the vasculature, the functional nature, the segments, as I mentioned about, just merely because of the vascular the way the vasculature of the liver is, very often you'll find that, the central areas may be necrotic. Grossly, you may not be able to see it well, but when you give a bit and you take it out onto the microscope, you find it's only necrosis. So always make sure that when you're giving bits from a hepatectomy specimen and you're studying a nodule, you have some bits from the periphery as well. Do not focus too much only on the center, because the periphery of the nodule, which is a hepatocellular carcinoma, is less likely to be necrotic compared to the center. And if there are multiple nodules, you also need to measure the closest, distance between the nodule and the closest margin. How many centimeters it is away from the resected margin. And if it's more than 2 centimeters away from the resected margin, then you can just give a random bit. You can just give a shave margin, just like how you give for bile duct and vascular margins. But if it's less, then it's better to give a perpendicular or a radial margin. Now, as far as intrahepatic cholangiocarcinomas go, so these cholangiocarcinomas, they can be either intrahepatic or perihilar or distal. So depending on the location and the diagnosis, now if it's going to be intrahepatic cholangiocarcinoma, that is, the grossing for intrahepatic cholangiocarcinoma is going to be very similar to how you gross a hepatocellular carcinoma. But if it is going to be a perihilar cholangiocarcinoma or a distal cholangiocarcinoma, of course, in distal cholangiocarcinomas, that's something we don't come across very often. But if it is something in the perihilar region, then here as well, you have good amount of liver tissue that is around, and you need to take note of the structures that you need to gross. Now, how is cholangiocarcinoma different from hepatocellular carcinoma? So cholangiocarcinomas, as the name suggests, they arise from intrahepatic. Now, if it's going to be intrahepatic cholangiocarcinoma, it's going to arise from intrahepatic bile ducts. And they have different growth patterns compared to a hepatocellular carcinoma. So it can either be a mass forming. So mass forming intrahepatic cholangiocarcinoma is going to be a differential diagnosis for your hepatocellular carcinoma. And of course, both of them can have bile pigment, the pigmentation can be there. But you will be able to trace the tumor to an adjacent bile duct. So it can be either mass forming, or it can be periductal infiltrating, or intraductal growth pattern. So very often, if you try to trace, carefully look, you'll be able to see that these tumors are arising from the intrahepatic bile ducts, and they're extending into up to the second order bile ducts. So this is how grossly you will be able to differentiate a cholangiocarcinoma from a hepatocellular carcinoma, because of its relationship to the bile ducts. So this is very similar to what we heard in the previous talk about pancreatic tumors, right? You see whether there is any relationship to the pancreatic duct. So when there is a relationship to the pancreatic duct, it becomes a IPMN. When it is not related, then it becomes either a mucinous or a serous. So this is very similar to that. And you should not be taken aback, because sometimes, the diagnosis might be a hepatocellular carcinoma, but what you are seeing here might be a cholangiocarcinoma. Very rarely, particularly when it's a mass forming, these two can be a close differential diagnosis. So as I mentioned, the grossing is very similar to how you proceed with the hepatocellular carcinoma. But it's important that sectioning of the bile ducts is done, and you need to see, particularly if it's going to be a mixed mass forming, then you need to also look at the periductal growth pattern and the involvement of the bile ducts as well. Macroscopic involvement of the vessels. So this is very important as far as resection, liver resection goes. Always carefully look whether the tumors, be it hepatocellular carcinoma or cholangiocarcinoma, whether there is any involvement of the vessels apart from the bile ducts, and the regional lymph nodes, usually up to 6 lymph nodes. Unlike other organs, you don't get many lymph nodes in liver resections. Particularly when it's cholangiocarcinoma, you might get more number of lymph nodes compared to a hepatocellular carcinoma. So this is a perihilar cholangiocarcinoma. Now this is again, you're kind of coming to the hilum, which I mentioned is in the posterior aspect. And that is, where you have, you not only have the bile duct, but you have also the blood vessels. So you need to very carefully know what is the difference between grossing intrahepatic cholangiocarcinoma and a perihilar cholangiocarcinoma is you need to be very careful in assessing the resection margins. So, you might be having the bile duct and the blood vessels, which is kind of coming to quite a distance outside it can be extrahepatic. And if you're not able to identify these structures, please call a surgeon. because very often they would have tied it with some sutures or ties, but it really helps to have them involve them as well in this. And there are some instances they would like to know, okay, we want to know whether this structure is involved or whether that structure is involved. But most importantly, in these, perihilar cholangiocarcinomas and in hepatocellular carcinomas as well, apart from invasion of the bile duct, please look for the presence of any tumor thrombus. So that you will be able to do only when you distinguish a blood vessel from a bile duct. And for this, you might need the help of a surgeon. So this is, perihilar cholangiocarcinoma. So the resection margins, as I mentioned, you have quite a number of margins compared to your hepatocellular carcinoma or intrahepatic cholangiocarcinoma, the bile ducts, the hepatic artery, the portal vein, and the liver parenchyma. So in a systematic way, you need to give bits from all these because all of them form resection margins so that you don't miss out on anything and you give a comprehensive report at the end saying that, yes, it is an R0 resection, all the resection margins are free. And as far as, so this is, as I mentioned earlier, the distal, perihilar cholangiocarcinoma, it's not something where you have the liver as well. So, that will just be a segment of, maybe, it will be coming down. You'll be having the pancreas and the periampullary area where, that will be a kind of forming a part of the specimen, and you will have to orient it anatomically according to that and give bits accordingly. So it's more often the intrahepatic and the perihilar cholangiocarcinoma where you get a hepatic resection, where a hepatic resection is sent to you for examination. Now coming to post-treatment liver resections. So what do I mean by post-treatment? As I mentioned earlier, total hepatectomy is usually done for patients who are going to be going up for transplant, who are going to be taken up for transplant, particularly hepatocellular carcinoma. So during that waiting period, some kind of locoregional therapy is given in form of radiofrequency ablation or chemoembolization. So you should know how to handle these specimens when you receive them. So you kind of give, receive the specimen, gross it, and you section it just as you would section a hepatocellular carcinoma. And ideally, because what is different between grossing a post-treatment liver resection and upfront liver tumor is that you will need to assess tumor response. So how do you assess tumor response? So you cut the tumor once you start sectioning it. If the tumor is less than 2 centimeters, then you give one full slice. An entire cross section is given, and you study it. You grid it, and you study and give the percentage of tumor response or the percentage of viable tumor cells. But if it is going to be a tumor nodule or a tumor which is more than 2 centimeters, then you have to give additional sections for each 1 centimeter so that you will be able to accurately report on the extent of necrosis and look for the presence of viable tumor. So you should really take care to document this tumor response because that is something they would want to know. Now, gallbladder, grossing of gallbladder carcinoma. So you can have a liver, resection as part of carcinoma of gallbladder as well. When extended radical cholecystectomy is done, there will be a non-anatomical resection of the, the liver also will be removed along with the gallbladder. Of course, it will not be neoplastic, but how do you approach that? So you all know that gallbladders, they have to be opened longitudinally from the serocell surface so that the gallbladder bed, which is the liver, that is not disrupted. It's very important for us to see whether the tumor which is involving the gallbladder, apart from studying the resection margin and the extent of the tumor per se in the gallbladder, we will have to document whether the tumor is invading the liver. So that's the reason why we need to be very, careful not to disrupt the gallbladder bed margin. And you give serial blocks and document the presence of invasion into the liver parenchyma. And of course, you have, when part of liver is taken along with the gallbladder and radical cholecystectomy, the liver resection margins and the bile duct margins also have to be examined. So in a nutshell, I would like to say that when you receive a hepatectomy specimen or a liver resection, be it total hepatectomy or partial hepatectomy or as part of resection for cholangiocarcinoma or gallbladder carcinoma, first, it's very important to understand and study the surface, see whether everything is intact and look at its relationship to one another, and be very careful to identify the margins, because once fixing of the specimen takes place, once a specimen is fixed, it might be difficult to differentiate margins from what is the margin, what is not a margin. one clue to, kind of distinguishing and confirming that it is indeed a margin is because it will be ragged. Okay. Usually if it's going to be an intact surface, which is going to be covered by the capsule, like I showed earlier, it will be smooth. Okay. It will not, be ragged. It will be smooth. But if it is going to, if it's not going to be smooth like this, then you know that it's likely to be a margin, because this can be difficult sometimes once the specimen is fixed. So that's the reason why, liver specimen has to be, or any specimen for that matter, it's good practice, it's a good practice to examine the specimen grossly and take photographs, as I mentioned earlier, because after fixing, you do see shrinking and shrinkage is happening. It's not as smooth as it is when it is in the unfixed status. And then you document all these findings before you proceed to slicing through fixing. And only after 24 hours, of course, you're going to take it up for grossing. So you need to spend quite a lot of time. So this is something that I would like to really emphasize on, spending time with the specimen before they are fixed. Don't be in a hurry. I know that it's going to be difficult. You really want to wind up, because most often these specimens are coming in the evenings and you want to finish work and go, but it's really worthwhile spending time, because as I always mention, once a good grossing is equivalent to 50% of the job is done. And what you look at under the microscope is only going to confirm your gross finding. So the other special circumstances where a liver resection is done is for metastasis, most often a colorectal liver metastasis. So this approach again is similar to a hepatectomy specimen or a wedge resection that would be done. Very often wedge resections are done for metastasis. So here again, you give, some 2 to 3 or 4 bits from the tumor. And if it's multiple nodules, document that there are multiple nodules, and you need to take sections from the nodule which is closest to the margin, and of course comment on the resection margins. And if any hilar lymph nodes are there, look for metastasis in those lymph nodes as well. Finally, grossing of pediatric tumors and mesenchymal liver tumors. So as I mentioned, in the beginning, it's very important that you weigh these specimens, all these pediatric tumors, as soon as you receive them, you examine, you document their size and their color and how they look, and then you weigh them before you proceed for further fixing and other examination. And many of these tumors, like for example hepatoblastoma, it can be really heterogeneous. So, and you need to give, and they may be treated, because neoadjuvant chemotherapy may be given for these cases. So you will have to take slices, multiple slices for every 1 centimeter. Hepatoblastomas are usually huge tumors. For every 1 centimeter, you take a slice, and you need to give bits from the central as well as the peripheral, because you are going to document the response, tumor response. And if it's going to be a cystic lesion, then you need to carefully look whether the cyst is communicating with the biliary system. Now, this is something that I'm not going to go into, the pre-neoplastic. Similar to what we heard in pancreatic lesions, you do have pre-neoplastic lesions in the biliary system as well. So that's the reason that if it is going to be a cystic tumor or a cystic lesion of the liver, you need to, when you cut it, look carefully and see whether it is connected to the biliary system or it is not connected, and document all the findings before you go on further to grossing, fixing the specimen. So now that I have finished, resection, grossing of liver tumors, I would just go to the second part of my talk, which is grossing of colorectal tumors. If there are any questions, we can address them now, or maybe we can just continue with that and we can have your questions at the end. So please note down your questions. Now, this grossing of colorectal tumors. Now, this is, a statement that I really love, and it sums up everything about grossing, not just for colorectal tumors, but for any tumor, for any tumor, any organ that you're going to be grossing. So this is the importance of grossing. The microscopic assessment of a colorectal resection specimen is of utmost importance. And what does it say? The second part of the sentence says, no amount of clever microscopy can redeem a poorly dissected specimen. So this is the reason why I was stressing on what I mentioned earlier about meticulous gross examination of the specimen. As postgraduates, we give a lot of importance to slides, right? But you need to give as much importance as you give to the slides to the specimen as well, because that is going to speak volumes. And that's going to tell you, that makes you an astute pathologist, and a pathologist who meticulously, studies the specimen and gives all the findings. So if you don't have your gross well, if you've not done your gross well, then your microscopy, how much ever you try to, kind of salvage it, once, you gross it, you're never going to be able to reconstruct everything on the gross specimen. So you definitely need to have a very good gross examination, not just of colorectal resection, any resection specimen, before you go on to looking at it under the microscopy. So why do we do grossing of colorectal tumors? Of course, a biopsy is done, always a biopsy is done and a diagnosis is obtained. Unlike in hepatic liver resections, you may not have, because diagnosis of hepatocellular carcinoma or cholangiocarcinoma is made radiologically. So, just with the radiological diagnosis, they might have done the resection. But as far as colorectal tumors, always there is a diagnosis, a preoperative diagnosis that is done, and then later, they go on to the resection. So you would like to confirm the diagnosis and give, information on the prognosis. So that is staging. So staging of colorectal tumors as you would stage any other tumors, and to confirm whether this radical surgery was necessary, because you're going to study the extent of the tumor to determine the effects of preoperative therapy, because today preoperative neoadjuvant chemotherapy has become a part of most of the advanced cancers. They are not taken up for straight surgery until a preoperative chemotherapy with radiotherapy is given. Of course, to plan the adjuvant therapy based on the lymph node involvement, whether there is serocell involvement, whether it was a complete or an incomplete resection. And most importantly, as far as rectal cancer, I think as pathologists, we are constantly validating the surgeons. Very often as pathologists, sometimes it becomes very difficult because people are just making fun. They're like, okay, you don't give a report and you always say it's inadequate. You're asking. So constantly we are being judged, right? Not just by a surgeon, by a physician, but by the whole medical fraternity. But, little do the surgeons realize that, this pathologists are quietly assessing, the quality of the surgeries that they are doing. And more so, this quality of surgery has really been studied in depth in rectal cancer, because it's something that actually predicts whether the outcome, the outcome is predicted based on the quality of the surgery. So I think that is very important for us to bear in mind when you approach a colorectal tumor. Otherwise, you would not know, you would miss this important key point, which I will just mention it later. And of course, to audit, as I mentioned, all these procedures in relation to the clinical outcome. So any specimen that is received in the pathology department has to be accompanied by a request, which should have some bare minimum, definitely apart from the name and age and the hospital ID number, the sex of the patient, the site of the tumor, the nature of the resection, whether any preoperative, therapy was given, and particularly in rectal tumors, the plane of operation that was attempted. So what are the types of specimens that you receive? In colorectal surgeries, it can range from total colectomy to abdominoperineal resection. So where total colectomy, where the entire colon is removed, particularly if it's carcinoma arising, or, even in familial adenomatous polyposis or malignancies arising from familial adenomatous polyposis, the entire colon is taken out. And if it's going to be a rectal tumor, then you will have either anterior resection, if it's the, sigmoid colon involved, and low anterior resection. Very often is the low anterior resection and the abdominoperineal resection that we come across in rectal cancers. So the specimen, as I mentioned earlier, they should be sent fresh. So this is ideal. So if you can, have a good rapport with your surgeons, your surgical colleagues, and, you prime them on sending the specimen fresh to the department as early as possible, that would really help. Nevertheless, even if they don't send it, if you can take a walk, go to the theater, and before they fix the specimen, if you can see it fresh, it really helps you document a lot of findings that you would actually want to do. Believe me, only when you start doing it, you'll realize that. So you inspect the specimen externally. Don't be in a hurry to cut. As I said, always inspect the specimen, look whether it's intact, and look whether, there are any artifacts, whether there's any perforation, because as far as rectal cancer goes, if it is perforation, that is spontaneous perforation, not iatrogenic. Iatrogenic that is induced by the surgeon. But if there is going to be a perforation, you know, that is spontaneous, then it automatically becomes a T. So it's very important for us to, you know, look for all that. And then the plane of resection, depending on whether it's anterior resection or abdominoperineal excision, look for the plane of resection, and definitely having photographs will support the evaluation. Now, something as far as rectum goes, you need to know that the entire rectum is not covered by peritoneum. Okay, so colorectum, right from the cecum to the rectum, this is something all postgraduates and all of us as pathologists, we need to know that except for, you know, for some areas where the, you know, the colon or the colorectum is entirely covered, like for example, in cecum, it is entirely covered by peritoneum, that stretch of transverse colon and sigmoid colon. So these are all intraperitoneal. They are covered by the peritoneum. Otherwise, you can see that along the ascending colon, the descending colon, and the rectum, this colorectum, it traverses, it says retroperitoneal in location. So here you can see that in ascending colon and descending colon, the posterior surface will lack a peritoneal covering. And now, as far as rectum is concerned, the upper third is covered by peritoneum on the anterior and lateral. And as you keep going down, the peritoneal covering, it decreases. In the middle third, only the anterior surface is covered, and the lower third of rectum has no peritoneal covering at all. So what is the surgery that is done for rectal cancers? It's called total mesorectal excision, TME. Now, what is mesorectum? So as I mentioned here, in rectum, you can see that the entire rectum is not covered by peritoneum. There are surfaces where it is exposed. Now, in those areas around the rectum, you see connective tissue. That is known as perirectal connective tissue. And this is what you're interested in examining under a microscope to see whether it is free or not. So this is the mesorectum, the envelope, and the mesorectal fascia. You can see that here you have the tumor, and this is the mesorectum. So throughout, there are some nodules. These might be tumor nodules, or these might be lymph nodes as well. So this total mesorectal excision is something that they found out from 1990s, that it really improved the outcome of surgery for rectal cancers. And they shifted to this technique where the mesorectum, that is the perirectal tissues also, a good amount of them were removed along with the rectal tumor, where the prognosis was good and the survival as well was good. So this is a terminology we need to remember. Now, how do you grade? So I was telling you that we, grade the specimens and we comment on the quality of the surgery. Now, these are all mesorectal excisions. Okay, these are rectal tumors, and you can see that the entire, the mesorectal fascia. This is the perirectal soft tissue, which is covered by this glistening fascia. It is intact. So, which means the surgeon has done a good job, and there is going to be a good clearance. But here you can see that the muscularis propria is exposed. So when you see muscularis propria, then it means that it is an incomplete surgery, incomplete resection, and this patient is going to come up with a recurrence sooner than later. Now, coming to abdominoperineal resection, when the tumor is lower down, the lower rectum and the anal canal, you have abdominoperineal resection. The traditional method, this is how the specimen would look, because in the traditional method, they say that the specimen will be having a waist. You can see that it's coming like this and there is a waist, and then it comes out like this. But when the sphincter is paired, when it's extra sphincteric, then you see that it is a broad, you don't have any surgical waist. This is a surgical waist. It is created surgically. But here in the extra sphincteric abdominoperineal excision, you can see that it's it's just the same. It's a cylindrical specimen throughout. And usually these, cylindrical specimens, the extra sphincteric resections, the chances of the margins being positive is less because quite a good amount of tissue is removed and it's extra sphincteric. So you have more clearance that is given. Now, very, very important, please remember that as far as rectal cancer goes, one of the margins, we talk about margins. Margins are so important. And we talk about proximal margin, distal margin, but the most important margin in rectal cancer is your circumferential resected margin. Now, what is the circumferential resected margin? This is the margin where, you assess on the bare area. That is the area which is not peritonealized. So I mentioned, right, that only part in the upper rectum. Rectum is divided into upper rectum, mid rectum, and lower rectum. So lower rectum is totally bare. There is no peritoneal covering at all. So you would have to give circumferential resected margins all around. But in the upper rectum and mid rectum, apart from the areas which is peritonealized, the bare area, you need to ink the specimen and then study and look for the presence of tumor involvement. Now, this is the gross specimen. Now, it's very important. This is the anterior aspect and this is the posterior aspect. So here you can see, this is peritonealized. Okay, peritoneum is coming till here. And here you can see that it is only the mesorectum. That is only the perirectal fat. You don't see the serosa that is coming down. So this peritoneal lining or covering is lacking here. So this is where you look for circumferential resected margin. Now, if you're looking for this margin, then it's known as serosal margin. So you need to know the difference between a serosal margin and a circumferential resected margin in rectum. This is the posterior aspect. You can see that, quite a bit of serosa or the peritoneum is seen here, but the other areas are bare. Okay, so there you need to look for the circumferential resected margin. Now, this is depending on the location, whether it's upper rectum or mid rectum or lower rectum. So from this image, you can see that the lower rectum is totally devoid of peritoneum. So you need to give a circumferential resected margin all around, anterior, posterior, right lateral, and left lateral. The mid rectum, you can see that there is some peritoneal in the anterior aspect, but the lateral and the posterior aspect will be lacking the peritoneum. Whereas upper rectum, you have peritoneum or the serosa both in the anterior and the right and left lateral aspect. Only the posterior aspect will be lacking the peritoneum. Okay, so serosa. So you need to give the circumferential resected margin. So this is something, if you know this anatomy, now this is something that you can only assess when the specimen is fresh, number one, and number two, when it is not cut. Do not cut the specimen. You think, okay, it's a luminal organ. You just cut through the lumen and you expose it for the tumor to be fixed. No. As far as rectal cancer goes, as I mentioned earlier, always there is a preoperative biopsy and the diagnosis is confirmed that it's an adenocarcinoma. What are you going to do in addition to, giving a diagnosis is to assess the depth of invasion and looking for the presence of whether the tumor is involving these margins or not. Because as far as colorectal carcinomas go, you're not rectal cancers, you're just not going to be talking about the staging. You're also going to be talking about the post-surgical outcome, the prognosis, whether the patient is going to have local recurrence or not. So for that instance, you need to study all these non-peritonealized surfaces, after inking them. So this is what I mentioned about inking. So you ink, so whichever area is, not smooth and shiny, that it is not peritonealized. Peritonealized surfaces are always smooth and shiny. The bare areas need to be inked before you gross. So as soon as you receive a specimen, first you identify where the tumor is. Always see the imaging finding. An MRI would have been done. See whether it's in the upper rectum, mid rectum, or lower rectum. And then you ink all these non-peritonealized surfaces. So this is how it is. Okay, so here, you see that here there is peritoneum. This is non-peritonealized. Similarly, you can see the peritoneum or serosas here. All this is non-peritonealized and you ink it. So which area is inked? The non-peritonealized area is inked. And then you cut. So you can see that here we have cut the specimen only till here. You don't cut through the tumor, because the grossing of rectal cancers is totally done in a different fashion. We don't want to cut through it. Here you will be giving only serial slices and sections. So cutting is done only from above till the point of where your tumor is, and even from below as well, because you would want to fix it. And how do you fix the specimen? You can, kind of put a foam or absorbent paper that is soaked in neutral buffered formalin so that some kind of fixation happens in the lumen. But nevertheless, we don't need to worry much about the luminal aspect of the tumor, because what we are going to be interested is in the extraluminal extent of the tumor and whether there are presence of lymph nodes and whether there is any tumor nodules as well. So you document all these findings as you would document for any other, tumor, the nature of the specimen and, the length and the margins. So that you have two types of margins. One is the longitudinal margin, that is the proximal and distal. And then, of course, the circumferential margin, which I've been talking about, the circumferential resected margin. Plane of surgical excision. Because why do we need to know the plane of surgical excision? Only then will we be able to grade and comment on the quality of the surgery that was done. So what do you mean by grading? So grading is usually done only for tumors, right? Microscopically. But in rectal cancer, we also grade the quality of the surgery by looking at the specimen. whether it is complete. That is, when it's complete, you know that the mesorectum is, you know, it's smooth and there are no defects at all. If at all there is defect, it is not more than 5 millimeter. So, you know, it's a complete mesorectal excision. Nearly complete is where there is a, you know, defect, but it is somewhat deeper than 5 millimeter, but the muscularis propria is not exposed. So it is nearly complete. So this is grade 3. Okay, it goes in the reverse. We may tend to think that grade 3, as far as histology goes, grade 3 is bad. But when we grade the quality of the surgery in rectal cancer, complete is grade 3. So what is good is actually grade 3, and what is bad is actually grade 1. And incomplete surgery is when the surgeon exposes the muscularis propria. So the patient is going to have a high chance of recurrence. So that is the reason you need to know the plane of excision of the mesorectal fascia. And this is something that only the surgeon can say. This needs to be mentioned in the request form when you receive the specimen. Based on that, you say whether it's a mesorectal excision, which is grade 3, that is complete. Okay, mesorectal means it's complete. Then intramesorectal or muscularis propria. So this is mesorectal. As I mentioned, grade 3 is good. So the mesorectum is intact. Intramesorectal is when there are some defects, but the muscularis propria is not exposed. But when muscularis propria is exposed, then it's poor quality of surgery. It's only grade 1. So the mesorectal grading is grade 1, and that is associated with high chance of local recurrence. Now, as far as, you know, plane of resection, so these were all the plane of resection for toto-mesorectal excision, TME. Now, the plane of resection for abdominoperineal excisions will be different because the levators, the sphincters are also involved. So here as well, you have 3 types of, you know, plane of resection. So extra levator is where, you know, the sphincters, they are all kind of removed. So it is a cylindrical specimen that you get here. The sphincters are not spared. So the clearance is not a problem, and usually the quality of the surgery is good. The risk of recurrence is less, local recurrence. Sphincteric is grade 2, where even if there is some defect, the muscularis, you know, the wall of the rectum is not exposed. But intrasphincteric is where the muscularis propria, this blue arrow that you see, the muscularis propria is exposed. And so it becomes a poor quality of surgery. So this is how we grade the rectal specimens based on whether they are total, you know, mesorectal excision or abdominoperineal resection. And this gross grading of the gross specimen is important because it plays a major role in the outcome of the patients. So I mentioned that we don't cut through the tumor, right? So how do we gross? You know, similar, rectum and esophagus are grossed in the same way because esophagus is also similar to rectum, non-peritonealized. So why do you need to slice it, you know, in serial sections like this? Because you not only see, so this is the mesorectum, that is the perirectal fat, which has also the lymphatics, the lymph nodes. And if there are any tumor nodules, even that can be documented here. And you can see that, you know, all these. So now this is the anterior. Usually the, you know, amount of circumferential margin in the anterior aspect is quite close. In the posterior, it is more. So this is the posterior aspect and this is the anterior aspect. And if this is going to be a lower rectal tumor, then you need to ink the entire surface because it is all non-peritonealized. So wherever it is peritonealized, you don't need to ink. That is the serosa. Non-peritonealized needs to be inked and you need to give the circumferential resection margin. And if lymph nodes are positive, you can see that this lymph node is very close to the margin. You need to document this as well. Although it has not become a regular practice, they say that if there is a lymph node that is involved, which is very close to the margin, the outcome may be inferior. So these are all the lymph nodes. So you don't need to worry about the number of lymph nodes because when you do a serial sectioning, automatically you'll be able to document the number of lymph nodes. And as far as colorectal resection goes, you need to have at least 12 lymph nodes to give a proper TNM staging. So this is the resection margin I already spoke about. And the difference between serosal and a radial margin. So when do you say it's a serosal margin? When it is peritonealized, when there is serosa. But when there is no serosa, then you say it is a radial margin. Okay. And radial margin, if it is going to be lower rectum, then it is going to be circumferential because all around you're going to be giving the margins. You're going to be inking and giving. So please remember these margins in rectal cancer. You need to know whether it's a serosal margin or a radial margin, ink it and document that in your report as well. Now, response to preoperative therapy, there are various grading systems, but the commonly used is the Dworak tumor regression grade, depending on the presence of or absence of tumor. When there is no regression, it is TRG0. And if there are tumor cells, when there are tumor cells, it is TRG0. So there is no regression at all. But if there is regression, there are no tumor cells and only fibrotic mass, then it is TRG4. Anything in between can fall between 1, 2, and 3. So lymph nodes, of course, you need to ensure that all the lymph nodes are harvested, retrieved, and the highest lymph node you look for Duke staging, particularly in colon cancer. Median number of lymph nodes need to be at least 12 lymph nodes. Now, the challenge in harvesting lymph nodes, particularly in a rectal cancer, if preoperative neoadjuvant chemotherapy, radiotherapy has been given, it might be a challenge because everything will be fibrous. So sometimes you may not be able to distinguish a lymph node from fibrosis. So what do you do then? There are fat clearing agents that can be used, ethyl ether, diethyl ether, or intra-arterial methylene blue injection, which will help you in the fresh specimen. It will kind of trace back. You'll be able to see that the lymph nodes are highlighted after you fix the specimen. So that will help you harvest more number of lymph nodes. So to conclude my talk, grossing of GI tumors, as I mentioned at the outset, it requires a sound knowledge of the anatomy and the relationship of various structures, one to another. So it's very important for you not only to know the parent organ, its surfaces and, its anatomical attachments, the ligaments and, the surfaces, the borders, but also its relationship to the adjacent structures, particularly when we're talking about liver resections. And why do we, the grossing, as far as grossing of whether, now today I have just spoken about liver and colorectal cancer specimens, but grossing of any specimen for that matter, at the end of it, as pathologists, we should be able to accurately assess the pathological stage. So what is the T status? What is the N? And if there is metastasis, which is histologically proven, then you can add that as well to your TNM staging. So analyzing surgical margins is of utmost importance. And as I mentioned, this may vary from organ to organ, depending on the organ that you're dealing with. Of course, I had spoken about grossing pancreatic tumors earlier. So there the margins are going to be totally different. So know your anatomy well. This is, the take-home message that I would like to give all of you, because without knowing the anatomy and the surfaces and the orientation, it's going to be impossible for you to give a proper, complete histopathology report of the resected specimens, because it's not only about giving the diagnosis, but you're also giving all the prognostic parameters, and you're documenting lymphovascular and perineural invasion as well. And particularly if the patients have undergone some form of neoadjuvant therapy, then you need to know how to assess the therapeutic effect and gross the specimen meticulously according to its need. Thank you.
Dr. Shali?
Yes.
Wonderful. I mean, liver was so extensive and very, very nice. Of course, we do get partially resected specimen. Even for cirrhosis, sometimes we do get partially resected specimen. I don't know what is the reason for that. Because generally, earlier we used to get total, this one, resected. Be partially resected, rather even a very small slice of liver parenchyma with HCC. So that is the only two types of specimen.
Segmental, yeah.
Slice, it's totally different. We don't even know what is the orientation. Absolutely. Anyway, it was so good. So henceforth, any liver specimen come, yes, definitely we will. I mean, even if it's partial, we know what all to do now. If we identify and still otherwise also we can call the surgeon to identify the margins. It was very good, very good. As you say, cholangiocarcinoma, intrahepatic cholangiocarcinoma and HCC, how many other times you see under the microscope, you can't. It is very difficult to distinguish. If you have a good gross, yes, your diagnosis itself, even without a marker, probably you can be very confident of it.
Yes.
So nice. And colorectal is a revision for us because you're talking to us for the second time. It was so good.
Yeah. Now, how many ever times you listen to it, it's always going to be new and there is going to be some take-home message from that. So, that's the reason I thought it's worthwhile for the benefit of the postgraduates who have come in new, how to kind of assess colorectal specimens is very, very important. Not just colorectal specimens, but when we're talking about GI tumors, then I cannot let go off without talking about colorectal specimens.
Amongst all the grossing, that and head and neck is your favorite topic on grossing. So it was just a question. I think next time we will call you, and you're already in our institute now, but we will have a, a real time with grossing specimens so that you can demonstrate to them very well, and it will definitely have a very great impact when somebody sees how they're doing it.
Yeah, sure.
So much for sparing you, and a very small token of appreciation for you as a certificate. And really, I mean, any amount of thanks is not sufficient, because the times you have come and without any hesitation, you have always accepted our invitation. Thank you. Thank you so much.
Thank you so much, Vijayashree. I think I have to thank you because you keep giving me the opportunity to come to Chettinad. And I'm very thankful to you for that. And it's always a pleasure to come to Chettinad and be with all of you. Thank you for having me.
Sure.
Thank you.
Thank you, ma'am.
Thank you.
We will go on to our next session of the day. I request Dr. Usha to introduce our next speaker.
Good morning, one and all. It's my pleasure to introduce Dr. Pradeep Kumar sir, who is currently working as consultant pathologist head of Department of Hematopathology and Diagnostic Laboratory, Bangalore. Sir has completed his medical education at Sri Devraj Medical College in Karnataka, India, followed by residency in program in pathology in Bangalore Medical College. He further honored his expertise with short-term training in flow cytometry at Tata Memorial Hospital in Mumbai. Sir has great interest and focus on cell counter scatter-plot patterns in both neoplastic and non-neoplastic hematological disorders, with particular emphasis on hemoglobinopathy and flow cytometry analysis. Sir has strong passion for teaching and mentoring postgraduate students and technologists while providing comprehensive clinical insights into routine hematology practice. Sir is currently working on 3 research papers, which includes studies on cell counter pattern recognition in leukemia, histogram patterns related to pre-analytical causes and hemoglobinopathies, and other hemolytic anemias. We welcome you, sir.
Good morning. Am I audible?
Yes, sir. You're audible, sir.
Dr. Pradeep, good morning. This is Dr. Vijayashree.
Yeah, hi.
And hello. Sorry that I missed you during our inauguration. I think you were there in the Zoom. I didn't notice. Very, very sorry. And
no problem. No
thank
problem.
you so much again for accepting. I know this is your 3rd time you're with us.
Yes.
Next time, as I already promised RBC, you should all be coming here. We'll have a real-time session. And
Sure.
Keep arrangement. Probably next July to somewhere between July to September, we will have a session. So keep yourself free for us. Thank you so much.
And I remember that we met for a very brief time this July when I was in Chennai, and so thanks for the opportunity again for having me here. And this time I think all the time I was speaking on only automation, but this time it's on automation with QA, which made my job a bit difficult, I would say. And actually, I'm not been well from last evening and have a slight sore throat. So,
so sorry.
If anything with my voice, just let me know.
So sorry. You can take your time, relax, and do no issues.
Yeah, not worry. So I'm Dr. Pradeep, and let's try keeping this interactive. And I think it was quite a exhaustive session by the previous speaker, and for me now when I look at colorectum and all, I don't understand anything at all. So let's move out from that and let's get to the hematology part. So this was the title which was given. So in my talk I would be briefing on how the automation is and the quality assurance is, but how we can include both hand in hand and get the process running. So my sincere gratitude to the organizing team, and of course way back here in Anand, the founder, A.V. Ramprasad, and a few of the teachers, Dr. Jairam, Dr. Sujay, and Dr. Shubhangi from, she has published a book on quality assurance way back, almost 10 years back, and I could borrow a few things from that book for this session, and my utmost gratitude to my teachers and patients, colleagues over there, and clinicians. So when I speak of quality, I think we have to be very much aware. So just like in the comic, they just promise it's a 5-star, but they never knew what they were getting into. So let's get to a few routine scenarios. You can probably unmute and speak. So any of the routine scenarios where, let's say, we have to buy something or do something, what are the few things which we usually choose on a day-to-day, in day-to-day life? Anything?
Milk, sir.
Milk. So I would say that's probably food. Anything else? Where you just want to choose, you want to buy something. It's okay. No negative marks, please.
Any wallet, bag?
Okay. So I would say clothing. Okay. Or we say we have to buy a cell phone, or we say we have to choose a vacation to go to, or sometimes a simple movie. Now, when we are buying all these or choosing all these, there are two aspects that matter. What do you think those are?
Quality.
Sorry?
Quality.
Quality. Before that?
Cost.
Huh? Yeah.
Cost price.
So I would say budget and the
Yeah.
quality. So we have quality day in, day out in our life, but we don't usually look like that. So if you just open if you just Google and ask what's the actual meaning, it would say the standard of something as measured against the other things of a similar kind. But in lab, how can we measure quality? That's the first question. So you can just say, you just reduce your errors, and then probably the quality automatically will go up. But how do we measure or reduce error? It can be either by user satisfaction, where you have three things. It can be the processes which are involved, or the personnel, maybe the technologists, the doctors, or someone who is doing the registration, or even for a fact, your simple instrument as such. So we'll get through these things, but before that, this is what I borrowed from that book which I just mentioned. Like they say, if quality assurance is the core thing, how do you improve? One can be just your assay performance can be improved, consistent procedures, like let's say you have a standard operating procedures which are there and you work on that, or maybe just the instrument performance. And then you have things like accreditation, which is always kind of headache, I would think, for any organization, and of course the record keeping and all this. But before we speak, even there are a few terminologies which we are very familiar with, but probably might not know what exactly they are when we speak about quality. They are standard, control, calibrator. We'll come to each of this, like what exactly a standard means, control means, calibrator means. And when you're analyzing outliers, there are these terminologies which you look for, which is called drift, trend, or noise. That's what happens with like internal quality control, even with external quality assurance and things like Z-scope. So why do we have to do the quality aspects basically? Because we always have a sample in our hand, being the lab people, but that sample has to get converted into what exactly? If we have to get it back to the doctor who has given the sample, what do you think it has to get converted into? We have a sample, and what would we give at the end of it? You can just unmute.
Report, sir.
Yeah, report. So you have a result or a report basically, but from sample to the result, you have a journey. So we'll take that particular journey, what a sample can go through from the moment a patient enters a hospital or a lab, and by the time he gets the result, basically. Okay, so we have processes basically, and in the process you have 3 steps always. Anyone who can say about this? There's 3 steps in a process wherever the sample gets in. What are those?
Pre-analytical, analytical, post-analytical.
Yes, absolutely. So you have pre-analytical, analytical, and post-analytical for any process you handle or any sample you handle, basically. So we'll deal with this one by one. So pre-analyticals, and we'll take a test sample. But before we get a test sample, there are a few prerequisites which you want. So the test may be a random one, a CBC for that matter. You can give any time of the day. You need not have things like fasting or fasting basically. And then time basically when you want to have anticoagulation, the patient is on anticoagulation and you want to get a INR for that particular patient, or as simple as fasting blood sugar if you have to get to that particular specifics in biochemistry. And then you have a billing for that particular test, and then you have the vacutainers. So these are before we collect the sample basically. So we take that as pre-analytic, or even before the sample reaches its analytical state. Okay, so then you have the phlebotomy which is performed, and then we have to know whether the sample has to be centrifuged or not. If it's a coagulation thing, we know that we have to centrifuge, but if it's a simple ESR, CBC, electrophoresis, you need not actually. So we'll just take the step 1 about the prerequisite. So random, time, and we also have to know whether it's a post-transfusion or a post-treatment. Sometimes a case of severe anemia which is there, they would have just transfused, but let's say if they want us to do a hemoglobin electrophoresis, we know that we can't because the transfused blood will actually interfere. So I've just a minute. Is the screen completely visible, or is there anything which is obstructing the text?
So it's completely visible. I think you have to switch off your video so that everything is seen.
Yeah, now the text is completely visible, which is on the right hand side also.
Yes, sir.
Yeah, okay, thank you. So the necessity for a sample, the prerequisites. So for the time, as we told, it can be just a simple monitoring of anticoagulation therapy, and if at all they have a post-transfusion sample, we won't be able to do tests like electrophoresis or even osmotic fragility, because those will interfere with the test results we might be giving. And if we have the facility, because now we are so much into automation or at least digitalization, you can always capture the test request which is probably sent across to your lab, or if you have your HIS integrated, just they can have that particular prescription or a test request form being scanned. So that is one thing, because once there are things like, let's say, there is an investigation where they've asked for CBC, peripheral smear, reticulocyte count, LDH. What do you think the clinician is actually looking for? You have PS, retic, LDH. What do you think the clinician wants to know, or what pathology is he broadly trying to get the answer for?
Hemolysis.
Yes, hemolytic anemia. So your TRF can give you the clue about what they want to look for. If they just say CBC with a dengue profile, then we know that we have to look for any reactive lymphocytes there. Or very similarly about if they say malarial parasite or things like that, you exactly know that they're working it up for fever, and you have to look at that particular parasite or things like that. So having a TRF scan while the sample is being collected, I think that will give you a value add. So billing is one particular thing where it can be a manual process or token generation. This is slightly different when we get to a hospital setup, but this can be even this part can be automated as such, because let's say you have a kiosk, or let's say you give them a link to you on their phone that this is where you have to fill your demographics. I think those errors can be taken care of, and I think we had a similar experiment in our lab where the errors almost from, though it was at 1%, when we started providing them the complete demographic registration kind of thing, that error almost came even further down to just like 0.1% kind of thing. So those things can be automated if you get to the billing process. And of course, like vacuotinus, which is so important at this particular thing, because let's say the tests may be multiple, but if we know for a retic PS, it can be just one EDTA. That's when you can just avoid an additional vacuotainer. Or let's say the request is for electrophoresis in further. You have CBC retic electrophoresis, and you still can do, because the amount of volume the sample is utilized is actually way too less than what you can. There's some noise. Am I audible?
Yes, sir. You're audible, sir. I've muted
Okay.
the other person.
Okay, no problem. So you have thing called the number of vacuotiners which we have to get, and the order of draw. So in the order of draw, we can actually provide in an automated way where you can have a tube sorter. First of all, if at all the patient needs LDH and retic. So we know that LDH is done on a serum sample and retic is on a EDTA sample. So if it's a beginner and we have to get it system based, you can use a tube sorter where the machine delivers the particular tubes required. And also for the order of draw, we just provide the order of draw in the label where we say the EDTA or a heparin, whatever the order which is there, where you get as sterile, heparin, EDTA, fluoride basically. So we just provide each vacuotainer a number, or each anticoagulant a number, so that even if it's a beginner, he will know what to draw first and what to draw next. So then you can have barcoding instead of writing it manually, because barcoding at all levels definitely reduce the error in a massive way. And whenever we say positive sample identification, is just like when a phlebotomist and the patient are sitting across and they just ask them to see whether the labeling has their name in it and is it right kind of thing. So that is kind of positive sample identification. So the automation with this particular step can be a tube sorters like this, where there are multiple things where you just swipe the barcode here from the bill and it delivers what exactly is required. If at all there is a request for PT, it would just send a citrate across. If it's only for A1C, it delivers EDT across. Or a simple chemistry where you have to analyze your renal function, it would just deliver the LO tube across. So that can be the automation at this particular level. And then you have the fourth step, which is the phlebotomy. So you have the bill with the patient, you have the vacuotainer with them. We have given it to the phlebotomist across who has to draw it. So there you have two things, which is called open or closed system, where the closed system is just where you can put a needle and straight away connect the vacuotainer to it. And based on the vacuum which is inside the vacuotainer, it will know what is the adequate sample that has to be delivered. And once that level is reached, the blood stops flowing basically. So that's a closed system. Open system is where you take your syringe and you draw it and then deliver it onto the vacuotainer. And then you have to know whether the centrifuge has to be done for that particular assay. I just thought I would just take you through a few things where we are speaking about pre-analytics. This becomes very crucial in the assays of coagulation. So these two articles if we can go through, and it's actually very well written about how the pre-analytics have a greater impact when you are analyzing your coagulation assays. And this is one more where they just brief you about how a APTT abnormal or a PT abnormal that has to be kind of dealt with, and with taking each step in isolation and then in combination, basically. So if at all you want to know about the pre-analytics and then the interpretation of how the abnormal results are, these are the articles which I would recommend. So these are the few experiments I thought we would share, because it was eye-opener for us also, where in a citrate tube, whichever you take, whichever company, they'll always have a mark basically in the tube till which you have to fill the blood sample. So in this, as you see, there is the mark, but the blood is somewhere here. That means it's underfilled. Or you also would have to take the history of, is there any blood thinners there on, because that would also help in interpreting these results. And they have to be aware about how the blood collection has to happen with respect to coagulation. And this is just the another example of how the underfilled tubes are. And we actually found out that it provides falsely prolonged clotting times due to the excess calcium binding citrate which is present. So if you have an underfilled tube, you definitely will end up getting a high PT or APTT. And these are a few things which we kind of tried doing. I would just skip this, but here, when you see a normal underfilled and overfilled, actually on the PT, there is hardly any change, but it's your APTT that kind of has a variation, which is normal in this particular case. Whereas in underfilled, you always have a prolonged APTT, which is coming up. Whereas in overfilled, it doesn't actually like has much of impact. But always be aware whenever you receive a underfilled citrate tube, if it's a APTT that is requested, be aware, because that will give a false high APTT. So this is just from one of those particular articles, if I'm not wrong. And let's say this happens quite much in the pediatric things, where there is less amount of blood which is drawn, and then they draw another tube, and then they kind of mix. Again, if they mix two different tube samples, you always have a prolonged PT and APTT. And APTT, the effect is way too large than what we expect in a PT-INR, but APTT is way too huge. So if they tell that they have provided you two citrate tubes because they weren't able to collect in one, and they mix and they give it, but this is the one which you have to be aware of. So just moving away from coagulation, and just a request, just let me know if at all you want me to repeat anything, or we can proceed basically for now. We can proceed?
Yes, Dr. Pradeep, you can proceed.
Okay, so we have the test sample which is there already. So we have just collected it, and now we have to bother about what instrument has to do with, the reagent has to do with, and the personnel. And this is a very, very important thing. This is applicable most of in any of the quality assurance thing or a quality control whenever you for, but I think it even is so close that you can use this even in your day-to-day activities. You have just put a timetable, let's say for studying or doing something or a hobby. You first plan it, then you do, and you check whether you're doing it regularly or not. And then you say, if you're not regular, let's do it again, or probably change the plan slightly. So this applies so much to your day-to-day activity, but so much to your quality controls. And anyone is familiar with this person? He's an author. Anyone? Okay, so he's the author. He's Simon Sinek, or and is author of this book called Start With Why. It's a very, very interesting book. And if you just want to, like, I think this book helped a lot when we have to deal with our QC things and stuffs like that. So in that, he just defines this particular circle about why you can do things better, or what can do things, like there are processes there, and if you have to improve, basically what all you can do. So there are three things, but what determines what to do the best is why. If your purpose, so let's say we have a sample and the ultimate purpose is to give the best result because there's a patient at the other end. So if that becomes clear, you will know that how can I do it, you would say. And you would say that, okay, I will learn about the instrument or even the pre-analytics associated with it, and probably like impart that knowledge on to the others, basically. But what can we do about it? So probably we can have more interactions or learn from the experts or things like that. So, but all that we can do is to ask why is that we have to give a best result, because there is a patient at the other end. So we just take, so you have the sample already with you. So we have to bother about the instruments now, whether they are fine or not. We have ensured that the sample collection is done, it's fine, and we have barcoded it so that the error is minimized. So we have the instrument. So instrument, whenever we come, there are the analyzers. Let's say it can be a cell counter or a coagulation machine, but you have the supportive equipments across, which are refrigerators, centrifuge, and pipette. So refrigerator for if you have to preserve your samples or even QC materials or things like that. Centrifuge, of course, like for the coagulation studies and the rest where your separation of the plasma has to happen. So in the instrument, you have things like installation, calibration, and standard, which will give you your IQ, OQ, PQ. That's what it's very famous for, like that particular abbreviations. And you have the supportive instruments, and those have to be calibrated now and then. So if at all you take what a standard is, it's just a material which will almost biologically inherent or similar, the control basically, where it has to be very similar to the test sample, whereas the standard is so different. It's just something which can give you that value. If you want to say, I want to analyze hemoglobin in one particular standard, it will just give you what exactly it is, but this is nowhere near a test sample is being checked. Whereas control, the sample which you're going to feed would be just as similar as to your the test sample, which is just the blood. Okay, so you have few terminologies related to QCs when we come to the analyzer. It is accuracy, precision, drift, shift, and trend. So this is just from the cell counter, where now the graphical data has improved so much that this is your overall QC of that day. And like if you just see, this is the 2SD and this is the 1SD, and everything is within 2SD, so you know that it is acceptable. But if it's not, let's say there's an outlier somewhere like this, so then it will mark it with red and say that this is not in acceptable limit, basically. So you need not go through the entire numbers. You can go through these graphs which are there, and this is from the Sysmex instrument. And but every cell counter, if you go through, has actually developed a very similar kind of graph, and you will know that whether your QCs have an outlier or not. So accuracy is when the closeness to the measured value to the true value. So you have a value which is measured, and then you have to see whether it is close to the true value. So you have a particular value of hemoglobin you are looking for. So let's say it has to come at 11. So the measurement, whatever you do with this particular calibrator or a standard, it has to reach almost what is defined for. So why we have to look at these? Because this will tell whether the calibrator or the standards you are using for, are they actually are not degenerated or they are still fine. This can also define how the pipetting of the sample is, and how the reagent quality is, and how the storage is. and of course the distilled water. And then you have precision, where you do one test very multiple times and you have to get very similar values. But let's say you're not getting. So if your precision is gone, that means maybe the technique, whatever you're using, is gone. Or let's say it's a power supply, because your cell counter has a lot of these voltages which are there. So if that is gone, then definitely the reproducibility is gone. So whenever you're looking at things like precision, if you're not able to reproduce whatever the value is, that means we have to look at these particular things. So this is just a graphical representation of how the accuracy and precision can be. Sometimes you can say that my IQC values are coming fine, there are no outliers, but let's say you've done a EQUAS and it has given an outlier. That's because probably we have probably established a mean which is required for that particular assay, and we think that there's no outlier and it is fine. But actually there was some issue with your particular analyte. So we had this issue with one of the parameters, so PCB, which is measured in Sysmex, and the voltage was slightly off. But when we see the IQCs, it was actually fine. But then when we got a EQUAS results, it was all out because the measured value was way beyond what is actually expected. So this about the EQUAS, where EQUAS measures about the accuracy, whereas internal quality control speaks about precision. And then you have how to measure the IQC. You have the LJ chart, which is being embedded in each cell counters of late. And you can also set a lab mean by going through 20 data points. So then you have the controls, which we set along. So these are the substances that are inserted to the run alongside the test material. You can either have it in the beginning of the day and at the end of the day. You can have it even between the runs. So whenever we speak about drift, so there is a gradual change. If you just look at this particular thing, there was this events of QC which are on one side, but suddenly there is a change and they have gone on to the other side. This happens when there is a slow deterioration of reagent, okay, or there is a gradual drift in calibration. And this is what happened in one of our cell counters, where the calibration of that PCB was kind of off. So, and that actually got us to the error where when we observed a very similar graph was there, and we knew there was a point where the voltages were off and it went on to the other side. So whenever there is a drift, you just remember there is a change in calibration or the reagent is getting deteriorated. And this is called a shift pattern, where there is a sudden and abrupt change. And this can be because there is contamination of the reagent, or again, the instrument problem itself. And then you have trend. So where there was one side and it gradually goes, and then reaches on to the other side. So this is again, if there's a deterioration of reagent or the standard or the instrument performance. And this from the book, Start With Why itself. And I think if we can make a difference with few things, it's only because if we can believe. So the reason why we are speaking about shift, trend, drift, it's all about we have to know what goes wrong before we get the sample being analyzed on that cell counter. So we have to know whether the collection is fine, and then coming to the instrument, if the reagents are fine, and if the reagents are not doing good, what is the error which we are looking at? So all these things is what we have to know before we feed the sample. So that's the journey we are taking, that we have collected the sample, we have the instrument ready, but there are things like this lot verification. This you can get in the NABL document, and this is for the instrument and reagent, where your external quality and internal quality can be done. I think that's a repeat. So then we know that instrument is fine, And then we have to come to the personal, which is the technologist and the doctor. So you can improve the competency by training them on the equipment and of course how to screen the cell counter, or even a simple assays like how coagulation assay is done, or even just how the gel card integrity would you check and all those things. Anyone can name which movie is this? You can unmute. And I think we'll finish in next 15 minutes. Are things clear till now, or it's too much of an information overload?
Postgraduates, I think you should respond rather than we responding.
Yeah, please speak
because
up.
Any number of times you listen to drift and shift, it is always useful on a daily basis. It's just not for us. We have to train our technicians, we have to train our senior residents, junior residents to go through the QC file every single day and the graph every single day. So it is always nice to keep listening to these things.
But until we do, I don't think we will actually learn. That's
That's what we do here. We keep teaching our technicians as well, because they are the most important people who identify that first.
Yeah, and for us, it's learning every day still.
Yeah.
Okay.
Yeah, please continue.
No, which movie? Anyone? This out of the subject.
KGF, sir.
KGF, yeah, right. So what do you think he says at that particular point? It says, what do you want? And he says everything. So now we have the sample ready, we have the instrument ready, we have the people who take care of the reporting, they are ready. The people who feed it into the machine, you have it ready. So you have sample, so you can do anything now. So as what you want, we can do anything now. So it's like you have a served food in front of you, just like we have to eat. So whenever we come to the analytical, there are these instruments which we are so familiar with and which we use probably day in, day out. So cell counters, coagulation, electrophoresis, and there are a few miscellaneous things like maybe a urine analyzer, all those things. So in cell counter, we know that it has evolved from how the impedance principle is. I think I would speak a little bit on this tomorrow when we speak again, and this is how a 3-part and a 5-part or 6-part analyzer is. And here again, the automation is that if you just see in this particular 3-part, it was about feeding one sample at a time, and there has to be one person placed and he has to keep loading every time there is a sample. But what automation has done is you can almost send up to a rack can almost hold nearly up to 150 samples. If you have these tracks inbuilt, they can almost hold up to 150 samples or 200 even with few, and that goes on to the instrument because it's programmed that way. So once the rack is there, it will just get it onto the cell counter and it moves further basically. So that's the automation with respect to cell counters, where you have the graphical data, but of course where the manual feeding and all has been reduced, and this is the automation part of it. And also you can get into automation in terms of a smear making and staining, where it's a QR code which is inbuilt and you just scan that in front of your system or even with your mobile basically of it, because you can scan these QRs. You just scan, you know that which patient slide it is, and you can then just do. And there's one practice which we have in the lab where we just write NC whenever the platelet is on the lower side. Less than 1 lakh, we just look for the clot in the sample, because if we have a low platelet, we know that we probably might be missing a clot in the sample. So we check for the clot, and the technologist who just checks, he writes no clot. So that's one thing which probably we can implement. So this is the thing. So you can have a smear review criteria based on numerical flag based, histogram based, where you say hemoglobin of less than 7, we would require smear. So that time the analyzer itself, if it's integrated to a stainer, it will give the signal to that, Or if that is built onto your system where you still do a manual slide, the analyzer will give a note saying make smear kind of thing. So those are the kind of automations which we can build in the analyzers, or you can have automated smear maker and stainer, and also capture of microscopic images that is also automated of late in many of the laboratories. So basically we were looking at the numerical data where we're looking at counts of hemoglobin, the WBC count, platelet count, but you also have the graphical data which are available. So this is the automated part of the cell counters if we come across. And of course, you always have the morphological data. This is kind of a digitalized slide from which we have taken. So basically the numerical, graphical, morphological, that is what can get you to the diagnosis. So you have your graphical data, the numerical and morphology, all that put together. We'll discuss this in more detail when we speak of cases tomorrow in PS. So I just thought we would just take you few cases where we just conclude even the post-analytical part and what all we can include in the analytical part. Okay. So this is the first case where this is a female for antenatal check. MCV is 65, MCH is 19, and hemoglobin is 9. Now the question is, okay, this is a smear. You hardly have any, you have some mild anisocytosis, but you can see target cells, elliptocytes, and few things. Now this is just the comparison from the normal, and this is the case. Basically, you know that the histogram has shifted to the left. That means we're speaking of microcytic. And then platelet is fairly normal. It's the microcytic RBCs which are interfering. That's why the graph looks a bit shorter when compared to this. So the findings in this particular case, we know that the RBCs are microcytic hypochromic and erythrocytosis is there. Now, how many of you would sign this out as, like, what is the next test which we want to do in this particular case? Any particular test next which you want to suggest the referring doctor?
Iron studies, sir.
Iron studies. But the RBC count in this particular patient is 5 million. So do you think
What else will you do?
What else can we do, basically?
Will you calculate something and then
Menser index. Menser index.
Menser index. Okay, if Menser index comes positive, what's the next test?
HP hemoglobin electrophoresis to rule out
So basically it's anemia, but because the RBC is on the higher side, we thought we even would consider minor hemoglobinopathy as you all are speaking, and we ask for electrophoresis. And how many of you do use A1C in your labs? Anyone here?
Actually, we don't use here.
Okay.
It's a microbiology which does the electrophoresis.
Right. So I just thought this kind of awareness which we thought we'll build, just that even the A2 values which are provided in the A1C, they are quite accurate. And if you can see, it's A2 and there's an exclamatory mark to it. So that means that's reliable value and A2 is elevated. So we have an elevated A2. The same we just performed in the HP electrophoresis mode, and it showed a elevated A2, and there's a beta thal minor. I just got this because we have built in something in our LS, so where based on Menser index and 3 more indices, when we kind of built in the formula onto the LS, it gave an alert about what it can be. Is it PIDA, means is it a possible iron deficiency? Is it confirmed? Or it's more likely a beta thal trait? Or is it an overlap when there is anemia, basically? So this is just one of the examples where MCV is low, hemoglobin is normal, RBC is on the higher side, and it said it's possibly beta thal minor, and it said the confidence level is 95%. So this is one of the post-analytical, where you have analyzed already, but your LIS or your information system, when you have built in a few things, you can start doing this in your Excel itself, where you can just feed a few cases where it's proven Thalminder, and you can ask with the tools, AI tools which are there in the web now, which are easily available. You can actually build the algorithm and ask it to predict, basically. So this can help whenever, let's say, we have a lot of, like, you have 200 reports in front of you to clear, and suddenly you know that this comes as a pop-up only when there is microcytic hypochromic anemias or a blood picture, and that can help you tune that, okay, I have to mention this particular thing in this particular patient. So things like that. So this is just another, I think, just a detailed view of the same image. And the same case when we just did electrophoresis, the A2 is 4.5. So your LIS or the information system can still give you inputs and help you that you have to go for this, basically. So I have another case 2, which is a 55-year-old male who is being evaluated for anemia. MCV is low, which is at 64. RBC is also low, which is 3.5 million. Hemoglobin is 5. What would you think the result, like your sign-out report, would be in this particular case? We are speaking of microcytic hypochromic and a severe drop in hemoglobin. So it is PG's first year.
Recording in progress.
No. I don't think I'll speak till someone else speaks from the other end.
ID is iron deficiency.
Iron deficiency anemia. But in a 68-year-old, it's an elderly male, which
Any history of bleeding, any history of cause of cancer.
Yeah, so we have to look for occult blood, basically. So what we can do is here, if you can just see, in the LIS, what we have got is this the occult blood column. And you can capture the images. So if we just look at LIS, the entire graph is kind of interfaced. So we know that we are looking at the same values which are being interfaced. And then if you have captured something like this, so the occult blood was done in this particular patient, and it just needed one click there to look whether the occult blood was positive or negative. So this was a chronic blood loss, and he had a GI malignancy. So just like the previous talk, I think after this, he would have gone through whatever we discussed, the surgeries on. So he had CA in the lower GI tract, and it was diagnosed, and it's only because it would not stop there at MHA, and we have to tell that there is chronic blood loss. But in a post-analytical or at analytical level, your information system, if you can capture the additional tests which are being done, that will give you the diagnosis. Okay. So post-analytical, whenever we have a test sample, you can have the form in the form of feedback from the patients who have done tests, or even for us to provide them a paperless report. Like nowadays, WhatsApp is so much there, browser is so much there. You can just give them a user ID and password, and they get the report. And of course, communication is the most important aspect when we speak of post-analytical aspects. So before that, so I think I still have time. Hello? How much time left still?
It's already 11:38, but I think you started 10 minutes late.
Okay, fine.
So
And
maybe another 10 minutes you can.
Okay. So you have a lot of samples which are being done, and this is one of the most thing in the analytical phase itself, the critical alert. So you can just refer to this particular article which is there, and you can define when can you call it a critical alert. Hemoglobin of less than 7 in adults, basically. So, but there are a lot of samples like this which are there and you have to pick this particular thing, and anyone can find the odd man out. You have 1, 2, 3, 4, 5, 6. So A, B, C, D, E, F, and you have 12 rows. So anyone, which row is the odd one out?
E row, sir.
E. Okay, great.
E row.
Anyone can guess what's the right order? I know it's a bit confusing. So that, like, I would just say, like, whenever, huh?
Color variation in the second G, sir, smaller G.
Yeah, but what's the right one? That's the question now.
Second one. Second one, sir.
Second one. Yeah, so, but I think if at all in a hurry, if you want to look, it's very impossible. So just like you have so many samples, but you know that there are few samples which need your attention. Basically, that's the critical alert. So one of the samples like this, where the hemoglobin is 6, and you know that this has to be reported faster. If you want to get it through a lot of papers and stuff, again, it's confusing, but this was the instrument data which was given. We'll come back to that. So how do we identify that particular sample amidst so many is the first question. So you can build in a software where you can say this particular value has to be reflected onto another window where you say it's a critical alert, and that gets to the attention of the doctor. And this case was acute leukemia, basically, that was giving a low hemoglobin, and it just came up in one of the windows. And what we can do is, okay, so amongst this, to pick an odd one out, it's easier because as in the first case when we saw, it was so difficult because we have to spend at least 5 to 6 seconds to get to that, but not when it's so straightforward like this, or straightforward like this particular lady. So it just highlights and says at the top of the screen that this is the report that has to be certified. But how do you do that? You just take that entire data in, you take your help of your IT team, you triage it and get to that particular low value which needs that attention. And also one thing you can do during your analytical, post-analytical is, as said in the previous case, you can just integrate the image basically. So this is a blood group which is done. We know that this is forward B and RH, and it is B positive. This is being interfaced. So these are a few things which you can do in your post-analytical phase. So you had a pre-analytical, analytical, where you looked at instruments, reagents, personnel, and then the reporting part of it, and then the post-analytical, what all you can do with it. So again, quality, how can we measure? It's by user satisfaction, where you improve the processes, personnel, or the instrument. But all this will just help you reduce the error. So obviously the quality goes up. But then when in a real time, what are the things which we can use as quality indicators? That can be incidence of double prick in terms of your phlebotomy, how efficient is the phlebotomy practice, how often is the instrument breakdown when it comes to the analyzer, how are the IQC outliers, and then how is your performance in EQA, the turnaround time also, basically. So let's say it was a severe anemia and we know that we cannot take a longer time and we have to get to the diagnosis there. So turnaround time matters in a lot of other things, like let's say it's a dengue case and you want a platelet count. So this is a very similar one. I think I'll skip this, probably we'll take this tomorrow. So that's how we conclude the talk, but it has to be kind of a teamwork from the side. So I just tell you one particular scenario. So there's this random kid in a classroom and he gets up in a panic voice and says, I need to go to the hospital. My parents have been there. And the teacher permits, and there's another teacher who sees this kid leaving the class and he goes to the classroom where the kid was coming from. And he asks, like, why did he leave the class? And the teacher says, apparently his parents are in hospital. And she says, yeah, that's where they belong because they are doctors. So your quality has to be good, or you should know what's the right question to ask and what's the right thing for that particular instrument or assay. And that's how it is. So my sincere gratitude again to all of you, and this is our team at Anand. And if you want to reach out to me, and I'm available on this. Thanks.
Dr. Pradeep, I do have some questions, but I think I will leave it for tomorrow.
Yeah. Sure.
It's mainly about your practice, nothing about this one. I just want to know about how many smears do you see in a load of, say, probably if you have 1,000 samples a day.
Right.
So what is your smear turnaround?
So smear review for us, it's come down to just 10 to 15%. So let's say there are 1,000. So we are doing about 100 for now. And that's mainly because we have been able to screen the cell counter data well. And since the digital morphology has also come up, the ones that go under the microscope out of 100 would be just 10 or even less. So, but it's about how we can integrate the cell counter and use that data to see which has to go for smear. And while looking at the smear, looking at the cell counter data, what can we utilize from there to see any particular cell, or let's say platelet clumps or things like that. I think we'll take that up in detail tomorrow. I think 45 minutes would be quite a long time. Today I thought I would finish it in 45 minutes. I didn't know that I would get to the 60th minute. Sorry.
It's quite good because there are so many learning points, and you're not well as well. Despite that, you were able to finish so much. There were so many learning points. I do have one more question, but I think I'll leave it for
tomorrow.
I hope you recover by tomorrow. You take rest, and very sorry to trouble you when you're
no problem. It's always a pleasure speaking here, and it's my third time. So it's like I've known you all for more than 2 years now.
It's more online, because once you did this.
Yeah.
Next time we will invite you in person.
Yeah, sure.
Please take rest. You don't look good also now. And as a small appreciation.
Yeah, thank you.
So much.
Thank you. Yeah.
Thank you.
Thank you so much, sir. Now I request Dr. Kirtana to introduce our next speaker.
Good morning, one and all. It's my pleasure to introduce Dr. K. Swaminathan, sir, a distinguished expert in pathology and the current professor and head of the Department of Pathology in Trinalveri Medical College. And sir has earned his MBBS from Madurai Medical College, where he was recognized as a best outgoing student. He completed his MD in pathology with distinction at Dr. A.L. Mudaliar PG Institute of Basic Medical Sciences in Chennai. His notable awards include a senior research fellowship from ICMR, focusing on the role of EBV DNA in Hodgkin's lymphoma, and he has served as a research associate with the Tamil Nadu State Council for Science and Technology. Sir is also a founder for Advancement of International Medical Education and Research, fellow in medical education, and has furthered his expertise with an advanced course at CMC Vellore. He is currently the principal investigator for an ICMR project on triple-negative breast carcinoma and holds an MPhil in health professionals education from Sri Balaji Vidyapeeth University. Sir has contributed significantly to the field with publications in both national and international journals, including research on Epstein-Barr virus in pediatric Hodgkin's lymphoma and a textbook for nursing students. We welcome you, sir. Over to you, sir.
Thank you so much, madam, for a very lavish introduction. And thank you, Team Chettinad, for your kind invitation, particularly Vijayashree, madam, for calling me over here to be a part of your CARE-PATH. And thank you again with folded hand. Thank you so much for your thing.
Welcome, Dr. Swaminathan. Actually,
shall I start, ma'am? Without wasting much time, shall I start?
Yeah, sure.
Yeah,
Thank you so
screen
much.
myself. Yeah. And so, dear postgraduates, breast pathology. So the task given to me by Vijayashree madam is to decode the spectrum of benign and malignant lesions. So in this slide seminar, I have included a set of benign and borderline and malignant cases. And particularly this whole slide seminar has been tailored for your exam point of view. So much more useful for exam point of view. So greetings from Tirunelveli. This is the institute where I work, and basically they are very sweet people. And so, and for the exam coming pages, breast pathology, you kindly focus on these lesions, which are the most common slides which are kept for examination. On cytology, you might have a case of granulomatous mastitis, phyllodes tumor, mucinous carcinoma, or a lobular carcinoma. And on histopath side, you can have a granulomatous mastitis slide, Paget's disease, mucinous carcinoma, invasive lobular, medullary, neuroendocrine, or metaplastic carcinoma. Okay. How do we approach a slide? Just a brief overview. During your exams, just read the history because history will often have a clue. Look at the slide grossly for the number of sections and scan all of them under a scanner. Check the stain, whether it's HND stain or a special stain or it's an IHC slide. And most of the slides for diagnosis will carry the normal organ in it. So just check that and you comment on the background. Next, move on to the next power to identify the predominant pattern. More information about the cell, arrangement of cells, more information about the stroma or any other finding you see. Then only move on to the higher magnification to check or to confirm your cytoplasmic and nuclear details, mitotic figures, or any other finding. Now you gather all the information, come to a conclusion. Categorize it as neoplastic or a non-neoplastic. Non-neoplastic will generally mean an infection or other lesions. Neoplastic, whether it's benign or malignant. Give the differentials accordingly. Do not mix all categories. That's very, very important. So whenever you think of a benign lesion, you give all differentials should be benign. Don't mix up. And in certain cases, you can suggest further workup for confirming the diagnosis. And just a brief overview of how to look at a cytology slide. Check for the adequacy. Of course, all your exam slides will be adequate smears. Check the clinical data and examination findings. What the predominant cell you see, round, oval, or spindle, size of the cell, whether it's small, medium, and large, any peculiar pattern you have, like papllaroid or microcina or any pattern you see, then comment on the cytoplasm. You have to look for two things. One, the amount of cytoplasm and the staining of cytoplasm. Comment on the nucleus shape and size, presence of other cells and the background, and jot it down in an organized fashion. Your diagnosis is almost ready. So when you do this, then you will not miss out anything and you always get a correct diagnosis. So with this background, we'll now venture the first case. So it's a 52-year-old lady who was obese, present with a pendulous breast. She had a painless mass lesion, mostly in the subaerial region with slight retraction of the skin. The whole story goes for around 2 to 3 weeks, and there was a physician suspected a malignancy for the lesion. So here the points to note are an elderly lady who is obese, having a pendulous breast, lesion in the subaerial region with skin retraction. Then a mammogram was done, which showed a poorly defined mass with speculated margins and punctate calcification. Sonography followed, showed an ill-defined mass with distorted architecture. So a true-cut biopsy was done to rule out malignancy. Now we are going to see the slides. So these are the mammogram and the ultrasound picture of this case. Now this is the section we got. What do you see? Be interactive. So I want the postgraduates to say at least their key observations in these slides. What do you see in this power? Postgraduates? Yes? Anyone? Not the diagnosis.
Inflammatory infiltrates.
Very good. So it basically you have some fat cells and a lot of inflammatory cells. Very good. So basically, and you see there are a lot of fat cells with a lot of inflammation, and this is rimmed by some fibrous tissues. And going on to the higher power, you see some histiocyte-like cells, some multinucleate cells. This slide shows a lot of multinucleate cells. So this is a pathology in which you see disruption of the fat cells with dense inflammation, collection of histiocytes, few multinucleate cells, infiltration by a polymorphous population of lymphocytes, plasma cells, and eosinophils. with some areas of fibrosis. So what's your diagnosis? Put everything into one basket. What do you think? Elderly lady, pendulous breast, subareolar region, having a fat with inflammation with histiocyte and giant cells. Probable diagnosis is?
Fat necrosis of breast.
Excellent. So you got it right. It's a case of fat necrosis. We often always, in a true cut, we mistake it for a malignancy. So we all know it's a non-neoplastic inflammatory disease with necrosis of the fat cells and foamy cells. And based on the location, the cause or the etiology could be proposed. If the lesion is mostly in the periareolar or the subareolar region, then you suspect a traumatic cause. And if you have the same lesion in the upper outer quadrant, you think of a non-traumatic cause. And this is a disease which has got its own natural history. So which we classify in the early, intermediate, and late phases. So basically, this is a case of fat necrosis of the breast. So case number 2, a young lady who had a lump in the breast. She was a type 1 diabetes on insulin, and the mass was ill-defined, non-tender, firm to hard. So mammogram showed an increased density with heterogeneous parenchymal pattern, and they suggested it could be a fibroadenoma. And she underwent an excision biopsy. So here the points to note are: an young lady, type 1 diabetes, non-tender mass, looks like fibroadenoma. So this is the ultrasound which shows the lesion, which almost looks like a fibroadenoma. This is the gross, which is predominantly yellow-gray with some whitish areas, and the mass was firm in consistency. So with this gross, what do you think? Doesn't look like a conventional fibroadenoma. So with this gross in an young lady, what do you think it could be? Postgraduates? Because we may have the diagnosis in gross. Yes? Surface is predominantly fatty with whitish areas, firm. Any takers for gross? Okay, I'll show the slide, then you'll jump with diagnosis. What do you see in the slide? Can someone describe it? Which is predominant, you say? Is it stroma or the ducts?
Stroma.
Okay, what is the stroma made up of? Does it look like the conventional stroma of the breast or something different? Yeah, I'll show much more. See the stroma. See this slide. Fibrosed. And how are the collagen arranged? In an orderly fashion, suppose I give the history as it's a lesion in the pinna, what will you say? How are the bands?
Half is that pattern.
Very good. So it is a keloid-like fibrosis. Excellent. And what else you see?
Inflammatory infiltrates.
Focal collection of inflammatory cells. So you have got a lesion, which is stromal predominant lesion, having keloid-like fibrosis with some pattern of inflammation. So abundant stroma, fibrous, as you rightly said, and in higher power you will be able to make out few plump myofibroblast-like cells, perivascular inflammation, and with plasma cells and leukocytes. So the diagnosis is, it becomes, now you correlate everything, all the triad: keloid fibrosis, myofibroblast proliferation, inflammation in a patient with type 1 diabetes presenting as fibroadenoma. Yes.
Complex sclerosing.
Yes. What? Please open up. Yes.
Diabetic mastopathy.
Excellent. Done. See, history had helped you. Diabetic mastopathy. Excellent. So here some more picture from the textbooks where you could show the fibrosis and so you see a lot of inflammatory cells again to show you this. So this is the triad: keloid fibrosis, lymphocyte infiltration, myofibroblast. So these patients also have a higher risk of autoimmune disease. Predominantly the IgG4 disease is being associated with this. And what is the pathogenesis? We already know about the advanced glycosylation end products. So here these products which we deal in our diabetic nephropathy, same AGEs, they go and they abnormally affect the collagen synthesis with a brisk B cell response. So this is a case of diabetic mastopathy. Now we want to case number 3. Shall we? Clear for you, or you have some doubts to be cleared? Yes. Yeah. I presume there are no doubts. Case 3 is a 45-year-old lady with an ill-defined mass in her right breast. The mass was present since month with variable pain. There was a positive history of breast cancer, and mammogram again showed suspicious of malignancy. So the patient underwent a Fruquet biopsy. This is a lesion you see where the margins are irregular, but you don't have any calcification, but density is more. And what do you see here? Can anyone describe this picture? What do you see in this power? What are these small round ones?
Tubules.
Tubule. Very good. So these are ducts arranged in tubules. And how are they arranged? In an orderly fashion or in haphazard fashion? Haphazard fashion. And you could see the margins are not well delineated. This lesion is infiltrating the stromal fat. Now we'll go to the higher powers, which wherein shows you see a lot of these proliferation of these ducts in a tubular fashion, infiltrating the fat, and the ducts are well delineated. And you don't see any myoepithelial cell also here. So basically the lesion is there's a proliferating of small round glands or ducts lined by a single layer of flattened epithelium with a clear to granular cytoplasm, lacks a myoepithelial layer, and has an infiltrated growth pattern. In a young lady with pain in the breast with the duration of 1 month. So what do you think is the lesion? Yes. Is the lesion benign or malignant?
Tubular
Tubular adenoma is. How will be the myoepithelium in tubular adenoma? Whether it will be intact or absent?
It will be intact, sir.
Intact. So here we already saw there was no myoepithelium.
Microglandular
Benign looking lesion. Yeah, very good. So it's a benign looking lesion. Excellent. You got the correct. So it's a benign looking lesion. So you see, so it's a case of microglandular adenosis of the breast. And you could see in few of them, you could see secretions. It's a PA stain. You could see the secretions, retained secretions within the lumina of the ducts. And the basement membrane is well delineated here. Reticulin will delineate the basement membrane. And the predominant thing is there is no myoepithelial cell. And laminin stain, which will highlight more the outline of the ducts. So this is microglandular adenosis. We have a subtype or an entity called atypical microglandular adenosis, where we have more complex glands. Here the point is the glands are fused and cribriform, whereas in microglandular adenosis, the glands are individually discrete. And you have cytological atypia with cells having more pleomorphic nucleus. And the other things you could see in microglandular adenosis are you find clear cell chains, a lot of clear cells, or you have an oncocytic chain. So you can have, or even they call it as an apocrine chain. So you can have all these as an additional feature in a case of microglandular adenosis. So the different diagnosis, as someone said, the most common thing, what particularly in a Fruquet biopsy, we mistake it for a tubular carcinoma. And for the predominant points in tubular carcinoma, angular glands, whereas here the glands are regular and they're beautifully round glands. Whereas in tubular carcinoma, the glands are mostly angular with a stellate pattern, and both of them like myopathy. So if we can't take that as a criteria, but elastosis is predominant in tubular carcinoma, whereas you don't find elastosis in a MGA, and positivity for ER-PR and negativity for SR. Second one is sclerosing adenosis. The first point is the location. Sclerosing adenosis is always lobulocentric, and when you look at the morphology of the ducts, they have a compressed lumen, whereas in MGA, you will be able to see a clear round lumen. And third point is the intactness of the myoepithelial cells, whereas in microglia adenosis, they completely lack it. So here the main takers, particularly in a true cut biopsy, is if we can give it in a supersede as an invasive carcinoma because of the infiltrative pattern of growth and the absence of myoepithelium. So we have to be very careful in making this. What is the importance of knowing about microglandular adenosis? Why should we give this diagnosis? What can happen to these women, unfortunate women? Or I will say like this, microglandular adenosis often precedes, it's a neoplastic lesion to what?
Triple negative breast cancer.
Excellent. So it is a obligate precursor for a triple negative. So this has to be cautioned to the consultant so that patients are followed up, and they have a lot of cytogenetic alteration, namely the recurrent loss of IQ and gain of AQ. Okay. Now we move on to case number 4. In a 45-year-old female patient, a teacher by profession, she has noticed a lump in her left breast since 2 months. It was a painless lump, rubbery, and it was because the patient was educated. She insisted in the mass to be removed. It was excised. So the mammography showed a dense mass with smooth borders, no calcification, and ultrasound again showed a well-defined hypoechoic mass. This is the excised mass, which is grey pink in color or brownish grey in color, well demarcated, smooth outer borders, and the cut surface is again grey brown. Okay. Gross diagnosis. Does it look like your conventional fibroadenoma? These postgraduates? Have you probably would have seen a lot of fibroadenomas in your grossing sessions? So you would have seen a lot. What is the normal color you see? Fibroadenoma?
Slit-like spaces.
Slit-like spaces in
Color. Yeah, that will be there. The color. Here, the color looks quite odd, no? It might give me a clue. So only I'm asking here. I'm putting a break here. For the normal color of fibroadenoma, grossly.
PGs, you're seeing every day fibroadenoma.
Yeah, it's a very common thing we see. So only yeah. Normally it's gray, tan, or tan white. Yeah, gray, yellow. That's the common thing. So what the difference here? What color is different here? It's more reddish and reddish brown. Okay, what can it be? Doesn't look a fibroadenoma on a gross.
What tumors will have this color? You at least guess.
Guess, at least you can make a guess. So the pathology becomes interesting. No? When you take bits and look at a slide, it becomes
something which is reddish. Vascular tumors.
Yeah, so it could be very good. So you can think of a vascular tumor. Excellent. Have this in your mind. Now we are going to see the slide. Which is predominant? Stroma of the ducts? Stroma. How is the stroma here? How is the stroma here? We already saw a stromal dominant lesion, diabetic mastopathy. How is the stroma? So in this power only you will be able to make out there are a lot of white spaces. Okay, we'll now have so you have got a stroma which have got lot of spaces having the formed elements of blood. They look like vascular spaces, but they are spaces between the stromal cells. Yes. So these are the ductal an area which shows the proliferation of ducts. And again, you see a stroma, very big, it's a retracted stroma having spaces with formed elements of blood. Okay. So again, from the textbooks, I picked some pictures to show you this unique thing. You can see RBCs within. So your diagnosis, someone already said it is excellent. So nicely you're able to make it. So it's a complex anastomotic spaces. In a dense collagenous stroma, spaces may contain erythrocyte, which is a very easy way. So you also have some spindle-shaped myofibroblastic cells. There is no necrosis, no it. So a red tumor having no necrosis always suspect this. So this is a case of pseudoangiomatous stromal hyperplasia, which is often mistaken for a phyllodes tumor in Trucat or some other stromal lesion in Trucat. So it's a stromal lesion characterized by formation of slit-like spaces, and they are formed by myofibroblastic cells, and you can also have an associated glandular hyperplasia. Okay, and this is positive for CD34. Normally we don't do markers to confirm it, but yet suppose you get a short notes on PASH, this could help you. It's positive for CD34, negative for CD31, and ER negative. And it's often an incidental finding in other biopsies, and it's always, it comes as a differential and fibroadenoma on imaging. And sometimes, as someone said, vascular tumor, we even mistake it for a low-grade angiosarcoma. It's got a very good prognosis. Excision is curative. Okay, so this is a case of PASH. So CD34 positivity in a PASH. Now, case number 5. We'll slightly go to, after simple case, we'll now slightly go to some cases where we had to really work on it to make a diagnosis. So it's again an young teacher, 37-year-old, who had observed pain in the left breast, but no obvious lump was present. The patient was very apprehensive because they had a recent death from a case of ovarian cancer, and they also had few breast cancer in the family. So she said she wanted to know about the thing. So she asked the surgeon has excised the lesion and sent her for HPE. This is what we got. So we didn't have an ultrasound or mammo. It was directly sent, and we got the slides for review. This is a slide picture you see. So what do you see here? Basically, you have got cystically dilated ducts. You're able to make out. And there is filling of the duct with fenestrae in focal areas. Again, you could see florid cystic change. And here you could see a partial occlusion of the lumen with fenestrae. Again, you could have this hyperplasia of the ducts with lot of secondary lumens. Again, to make a thing almost filling the duct, but again, you have this fenestrae and secondary lumen. Some collection of histiocytes or foam cells in these cystic spaces. And again, it's a heterogeneous population of cells, mild anisonucleosis, but again, they maintain the polarities maintained here. So to summarize, it was heterogeneous proliferation of the ducts with irregular secondary lumen, and in few areas you saw syncytial growth pattern of the cells. There was a great variability in the orientation of the cells. Cytoplasm was again very much variable from amphiphilic to eosinophilic cytoplasm. The nuclei was round. It was in certain case it was ovoid, and it had a finely granular chromatin with uniform nuclear membrane, no nucleoli, no mitosis, and few years you had overlapping of the nucleus. So, what's your opinion? We almost described the entire spectrum. Benign or malignant? Yes, postgraduates.
Agatha, Soumya, is it benign or malignant?
Malignant, ma'am. It's a metastatic.
Why?
Malignant.
Why malignant?
Vignesh, you only said malignant. Why malignant?
You saw some invasion or something?
No, sir. It is actually spread from ovary. It is a metastasis.
You thought of ovarian tube. Okay, fine. Fine, one possibility. Predominantly, what is the lesion? Suppose a metastasis, you have cystic component in the metastasis. Predominantly, the spectrum was a fibrocystic disease, and you had some ducts which showed this abnormality. Clear? What do you think?
Agatha, Soumya, benign or malignant? Benign. Yeah.
Benign, excellent. Which category can you fit this?
Is it a proliferative, non-proliferative lesion?
Or it's just a fibrocystic disease? Whatever PGs you talk up, we need not make a diagnosis at all. At least you summarize what you saw. Diagnosis can be referred to the textbook and we can give it. There's no problem. But at least our findings, none of the textbook will teach you. Your
What
observation.
is the ducts show?
We have cystic dilated ducts and varying degrees of ductal hyperplasia. And some areas it was completely filling the lumen. Some areas still you have got a lot of empty gaps or fenestry or something like this. So which category does it come?
Sir has already given the diagnosis.
Can it be a ductal hyperplasia? Yeah, so it's a ductal hyperplasia. Basically, we know that because we already saw the ducts are big and the cells, there is excess proliferation. So it is hyperplasia. And basically, looking into the finer details, there was not much of anisonucleosis, not much of frank malignancy. So this is the thing what we commonly encounter in the biopsy. That is the usual ductal hyperplasia. I think it's not an exam slide, so I think most of you don't want to commit on that. But sometimes they can, because this is the area what we commonly see in our practice. So you have been trained for doing a consultant practice outside once you pass out. So you must know to describe these lesions, at least come to a conclusion what should be done next, because there is an anxious patient sitting next to you to find out what has gone wrong. So this is a case of usual ductal hyperplasia, fibrocystic disease with UDH. It's a benign lesion where there's epithelial proliferation within the ductolobular system. There's heterogeneity, great variability in size and shape, no obvious features of malignancies. Suppose you have a chance to look at the glass slide, then you'll be able to appreciate this. Then you have got fenestrated growth pattern, and these UDH may have associated lesions like papilloma, radial scar, or a nipple adenoma. So there are various ways to classify it, but the simplest way is milder form and florid form. What the milder form is 3 to 4 layer thick with intact basement membrane, and florid form is almost fills the lumen, or which could be a partial or a complete obstruction. Based on the pattern, we can have 3 types of growth patterns. The most common one, what we saw in this case, is a fenestrating pattern. We can also have a micropapillary or a gynecomastoid pattern or a solid pattern. I'll just show the pictures. This is a classical one, which we saw in this case, which is a fenestrated pattern with lot of angulated slit-like secondary lumen, which is again very, so you see a small lumen, you see a bigger lumen, an angulated lumen, all these heterogeneity you could see. And this is a gynecomastoid pattern where you have micropapillary projections, just looks like a gynecomastia slide. Solid pattern. Again, almost filling the duct, but you will be able to make out this secondary lumen, collapsed secondary lumen, again with not much of anisonucleosis, not much of. So these are the 3 patterns: fenestrated pattern, gynecomastoid pattern, and solid pattern. And as I already told you, whenever you have a case, you have to make a lavish sampling of the slide to see for the papillary lesions, any radial scar, nipple adenoma, or a papillomatosis. And we have a confusing entity, just I want to highlight this, which we call as infiltrating epitheliosis. It was coined by Azzopardi, where we have a foci of UDH with a mild infiltration in the surrounding tissue with lot of elastosis. So here care has to be taken to see whether it is not an invasive tumor, it's only an UDH with infiltration. And markers again help you. Suppose you are confused or you are not convinced whether it is just an UDH and you think it is an atypical ductal hyperplasia, then you do this basic cytokeratin marker. So CK5/14 is positive in a case of usual ductal hyperplasia, whereas it is negative in a case of AD, because they lose the pattern of the expression whenever they become atypical. So this could be used, and we have got a lot of double immunofluorescence method to show you. This picture is first taken from Rosen's pathology to show you, highlight the expression of CK5 and CK18 in case of UDH. So you got an idea about UDH. Now we go to case 6, which is a 48-year-old female patient with a superficial mass in the left breast. Skeletal retraction is there. nipple is inverted. So she was diagnosed as a case of malignancy. So directly went for a true cut biopsy. So mammogram showed a round, well circumscribed lesion had some calcifications. Ultrasound again showed a fully marginated mass with posterior shadowing. And the mass was excised, which was gray-white and irregular, with variably, it's slightly demarcated, but we don't have a circumscription. And true cut biopsy initially was done, which showed done elsewhere, and they reported it as it's a case suspicious of malignancy. So the mass was excised in total. But what we got in the mass is a different story. Can anyone say the diagnosis? It's a spotter for you. But site won't be breast. They'll give you some other site. Yes, excellent. Now, if you can clap yourself for a very correct answer, it's a granular cell. Why do you say so?
Eosinophilic granular cytoplasm.
Cells are large. We start from the shape and size of the cell. We don't jump to the cytoplasm. Okay, so they are round and large and polygonal cells having an abundant eosinophilic granular cytoplasm and a small round nip. Very good. So granular cell tumor of the breast. So you can see a compressed duct here, and we have this tumor cell proliferation. Benign or malignant? Yes.
Yes, Soumya, you told us.
Why sudden silence? You said a very correct diagnosis, and why? This is the problem, no? Whenever we make a correct diagnosis, when don't substantiate diagnosis, then the examiner will become suspicious. I think someone has given you the clue. Very good. Benign, yeah, it's a granular cell tumor. You never said granular cell carcinoma. You said tumor. So it's a benign tumor. As I told you, we already saw this. So it's a granular cell tumor, and it's positive for S100 and CD68. Here the point to ponder is particularly in a case of true cut, is always mistaken for an invasive because we don't think of granular cell tumor in breast. That's the problem. So we mistake it for an apocrine carcinoma or a lobular carcinoma histioid variant. So here we have to carefully look whenever you have a lesion with an abnormal morphology, non-conventional cells, then you just pay notice to the nuclear features and mitotic features. Sometimes it's even mistaken for a metastatic, particularly metastatic melanoma, renal cell carcinoma, or an alveolar soft part sarcoma, or the other DDs. So particularly in a lumpectomy, it's not an issue, whereas in a true cut, as it happened in this case, it's always mistaken for you to be very careful. Okay, next we'll go to a spotter. Just take 2 seconds, give your diagnosis. Lump breast. Yes. Gross, what do you think? Mass with lot of chalky white calcification. Now we see this.
Diagnosis. Students, please.
Yes.
Spotter.
Spotter. Suppose they change the history, will you say nodule skin? See this cell, and give your diagnosis. And see this areas. Does this cell have nucleus? These pink cells?
No,
Are you able to? No, sir. So what do you call those cells? Ghost cells.
Ghost cells.
What the color of these cells? Blue or pink?
Blue, sir.
Blue. So it is a basophilic cell. So ghost cells, center, basophilic cells in the periphery with some areas of calcification. Diagnosis is?
Pilomatrix.
Excellent. Pilomatricoma. Yes. So it's a very, very rare thing. It's not so to break the monotony. I kept this slide, but always you think of this case, pilomatricoma. It's a pilomatricoma of the breast. Okay. So it's a pilomatricoma. Next, we move to case number 8, which is an young girl, a college student, having a lump in the breast for 2 weeks. No pain, firm mass, solid, circumscribed in the upper outer quadrant. So a clinical diagnosis of fibroadenoma was made, but again, the breast cancer family history made the family got worried, and she underwent an ultrasound where they were able to make out an ill-defined heterogeneous mass with lot of cystic spaces, gross. So it is lobulated with multiple cystic spaces. Some show some papillary excrescences, and it almost looks like the Swiss cheese. What's your diagnosis? Grossly. Young lady.
PGs. Sir has already given the diagnosis. Swiss cheese. Sir has already told.
Gross Swiss cheese. Yes. Yes, madam.
Proliferative fibrocystic disease.
Age of the patient. He's
Juvenile papillomatosis.
Excellent. Juvenile papillomatosis. The Swiss cheese is very, very important. And this appearance is very classical. So you have got a lot of cystic spaces, papillary excrescence. So this is very good. So this is a scanner view showing this cystic, multiple cystic spaces of varying sizes. And again, you could see this complex papilloid pattern proliferation in few of these cysts. Again, to show you this predominant of cystic, this Swiss cheese appearance. Some cysts are having this complex arborizing papillae lined by cuboidal cells with stratification. Again, to show this complex arborizing papillae in a dilated cyst. Again, to show you this very orderly proliferation, benign looking cells. You can have this. What is this change?
Apocrine change.
Yeah, so there's a sudden transition. See, sudden transition to apocrine chain. Then you must. So it's again one more clue. So plenty of cystic spaces, papillary-like pattern. Sudden transition to this apocrine make you think of this. Again, you could see this collection of these foam cells, foam cell collection. So to summarize, so you got a cyst of varying sizes, lined by flattened cells, cuboidal cells or apocrine cells, dilated ducts with lipid-laden cells. Then you have a distinct transition from ductal hyperplasia to an apocrine metaplasia. And we have papillary areas, some showed sclerosis. So diagnosis is, as someone rightly said, it's a case of, it's a pattern diagnosis where we make out a very classical slide having a very classical morphology and a microscopy. So the closest differentials are cystic lesions of breast, duct ectasia, particularly in elderly people, or in younger age group, we think of cystic hypersecretory proliferations. Case number 9 is a 32-year-old woman working as a typist. She noticed a lump in her right breast for 3 weeks. There was no pain. It was a solitary, well-circumscribed mass in the subaerial region. Again, it was thought of fibroadenoma and it was planned for excision. So the ultrasound showed an ovoid hypoechogenic mass with regular margins. And again, the picture in mammo shows an opaque, dense, homogeneous mass. So the mass was excised. So it was a non-encapsulated mass, firm and fibrous. See the color of the breast and the tumor, and it's fairly well demarcated. So what's your diagnosis? What do you think so here? Benign or malignant? Yes, postgraduates? Feeling hungry?
Benign.
Few more slides. I'll finish it fast.
Yeah, benign or malignant?
Malignant.
Good. Why malignant?
That's irregular.
Non-encapsulated.
Yeah, so it's not well, you're not happy with the margins. Fine.
Irregular.
Okay. Suppose it's malignancy, what do you think here? Is a conventional ductal carcinoma, NOS could be there, or any other thing will you like to offer? A very small lesion. Keep your minds and brain open in grossing. Okay. We'll move on to the slides. Now it's quite obvious. So what do you see here? Yes, what do you see here in this slide? It's an infiltrative lesion. And you see a lot of ducts with arranged in a micro-SNR pattern, which is looking obvious here. Which feature looks very staring at you? What is the human contain?
Mucin.
Is it mucin or some secretion? This power we cannot say it's mucin. Some secretion. Again, higher power view, you have a proliferation of ducts, almost back-to-back arranged. The bottle cells having the secretory component. Again, you see there's an haphazard proliferation of these ducts having this secretory material. Okay. What do you think? So it's a round cells arranged in microcystic pattern. They have a granular cytoplasm with dense secretion, and some of cells show a discrete nucleoli. So your diagnosis is benign or malignant?
Secretory carcinoma.
So it's very good. It's a malignant tumor, probably a secretory carcinoma. Very unique morphology. So normally we have 3 patterns: secretory carcinoma. Solid pattern is very difficult to make a diagnosis. The most common one is the microcystic pattern. And again, tubular pattern, we always miss it or confuse it with the tubular carcinoma. So here the microscopic hallmarks are mild nuclear atypia, a very low mitotic activity, and an extracellular secretory method. Very, very important. The points, someone said it's a mucinous one. Mucinous will be much more larger, it will be much more basophilic in nature, and the cells you see will have a moderate to severe anisonucleosis, whereas here the nuclear atypia is very minimal. Then the margins are infiltrative. You rarely have necrosis or lymphovascular permeation. And it is ER negative, it is PR negative, HER2 negative, it's a triple negative breast cancer, and the proliferative index is very low in this case. The ducts are positive for CK56 and c-KIT. So c-KIT is usually the marker which we use whenever you want to confirm it as a case of secretory carcinoma. It's also positive for CK8 and 18, S100 and mammoglobin. Molecular pathology is very unique in secretory carcinoma. It has got a very unique translocation in chromosome 1215, the ETB6 and NTRK fusion. So this fusion gene can be demonstrated with the help of FISH in the case of secretory cancer. Now a question for the postgraduates. What are the other tumors which have this ETB6 NTRK3 fusion? 2 more tumors have this fusion, unique genetic profile. What are they? Not in the breast. Could be a soft tissue, and one is soft tissue and one is renal. Yes. Which tumors have this fusion gene? It's a type of fibrosarcoma. Congenital fibrosarcoma is one tumor having this unique fusion, and in the kidney we have a cellular mesoblastic nephroma, which again has this fusion. So just to have these are nothing to do with secretory carcinoma. These are the 3 lesions having this unique fusion. Okay. Now we move to case number 10. If you're a homemaker having a vague pain in her right breast, and the mass was detected by her family physician, it's a very tiny lump. So she was referred to a surgeon who did a mammo and ultra. Mammo showed a mass lesion with central density, an occasional calcification he noticed. And again, on ultrasound, it was a ill-defined hypoechoic mass with posterior acoustic shadowing. So they say when you have such shadows, it always mimics malignancy, or is always high suspicion of malignancy. So having malignant, so that she went in for a lumpectomy of the mass. It's a very tiny mass, 1.4 to 1.2 centimeter, with ill-defined firm lesion. What do you think on grossly? Benign or malignant?
Yes.
Malignant. Gross, you can make a guess. Gross, you can make any guesses. No, it's not like histopath where we cannot commit much on that. So here, as we saw in the previous case, the margins are regular and slightly looks infiltrative. So it could be a malignant lesion. Fine. We'll now see the sections. Sections, what do you see here? You see the normal ducts here. And this is the tumor area, which are made up of irregular, small, angulated ducts having dark cells with dark staining nucleus in an elastotic stroma. Next power to show the angulated glands, elastotic stroma, infiltration into the fatty tissue. Diagnosis, postgraduates?
Tubular carcinoma.
Yes?
Tubular carcinoma.
Excellent. Tubular. We already saw the cousin of this some slides before. Angulated glands, elastotic stroma, infiltrative mark. Very good. Again, to show these areas. So here we have got haphazard proliferation of glands in tubular configuration, angulated margins lined by single layer of cuboidal cells, no myoepithelial cells, and we have got sometimes you have got a lot of apocrine like cytoplasm with apical nodes. So diagnosis is tubular carcinoma of the. Why do you want to make a diagnosis? Because it's malignancy. Why do you want to spend so much time to say it is tubular? What prognosis tag it will carry? How will be the prognosis if you say that that particular lady is suffering from tubular carcinoma? It's a good news for her or it's a very bad news for her? All these subtypes this we give is just to give. Yes. I'm not able to hear you. It carries a good prognosis tag. That's very, very important. So it's not. So it's a common alteration. If we see, suppose it can be even seen as a part of an ductal carcinoma NOS. So here, to make a diagnosis, we must have more than 75% of the pattern must be tubular, or even more 90% must be having tubular pattern to call it a frank tubular carcinoma. And if it's more than 70%, less than 90%, we call it as ductal carcinoma having tubular areas. What is this Rosen's triad, which we discuss whenever we talk on tubular carcinoma? Coined by Rosen. Who is Rosen? Have you heard this name?
Graduates, postgraduates, do we have a book like that?
Book, no, says.
What
is this? Yeah, he found out some unique. Yeah, he's author of a very beautiful book on breast pathology. So he found 3 lesions coexistent: columnar cell change or hyperplasia, lobular neoplasia, and tubular gas. So he found that the unique coexistence of these 3 lesions, and he called them as Rosen's triad. Just an extra point to add here. So here, tumor cells are positive for ER, they're positive for PR, always diploid, and have a very low proliferative index. They're HER2 negative and have a very good prognosis. So again, the differential, we already saw the other side on MGA. Same the common DD, what we have is sclerosing adenosis, because we again have a collapsed lumen. The only thing is the location, lobulocentric. So sclerosing adenosis is often always lobulocentric in location, whereas tubular carcinoma is not lobulocentric. Then again, radial scar, we have a sclerosis, the distorted nidus, which we don't have in a tubular carcinoma. Again, how to differentiate from tubular adenosis? The stromal desmoplasia. In adenosis, you don't have any stromal desmoplasia. The 4th DD is what we already saw, MGA. How to differentiate this? MGA, we already saw it's a diffuse lesion, whereas tubular carcinoma is a localized lesion. So with that, we can easily say, because both of them will lack what? In both what? Yes, so that the criteria what we taught you. When you don't see myoepithelium, it is malignancy, but this doesn't obey. It's a paradox. So we can't go by myoepithelial cells. Case number 11, again, it's a very easy case. 63-year-old BD roller worker having an itchy lesion in the nipple for the past 1 month, had a serious discharge, now had a bloody discharge, which made her come to the hospital. This is a lesion where the lesion is excoriated with ulceration of the nipple. Nipple is inverted. What's the diagnosis clinically? Very good. So only have that in your mind. Just we'll see. Mammogram showed this. There is a distorted lesion in the limfoareolar complex, and you don't have any definite mass lesion here, but you have some irregular speculations with calcification. Yes. Diagnosis. What do you see here? Yes.
Paget disease.
Yeah. Why Paget? What do you see? So you have got irregular hyperplasia of the epidermis with a dense infiltration of these large round cells. We'll see more about these cells. The cells are very large, round, having an abundant cytoplasm, irregular nucleus with variable chromatin condensation. Again, you could see here this epidermotropism, invasion to the epidermis. Again, to show the malignant nature of these cells, which is infiltrating the epidermis. So you have epidermal acanthosis with hyperkeratosis, large pleomorphic malignant-looking glandular cells, which are called the buckshot scatter. And these cells are located in the epidermis. You saw them either as a single cell, nests or sheets. So diagnosis is very obvious. It's a case of Paget's disease of nipple. Okay. So we'll see something about this. So it's a 1 to 3% of breast tumors. First case James Paget in 1874, and 80 to 90% they have an associated invasive breast carcinoma. So how to describe a Paget cell? It's a large cell. It could be an epithelioid-like, abundant pale eosinophilic cytoplasm. Sometimes they can have PES positive material in it. Nuclei is very large, pleomorphic with prominent nucleoli, and you also see some mitotic figures. The upper dermis will have a lot of inflammatory response. And we have 3 or 4 variants of Paget disease. The most common one are the anaplastic variant and the acantholytic variant. Both of them are mistaken for a squamous cell. We mistake it for a squamous cell carcinoma because they look like a malignant squamous cell. And the third variant, pigmented variant, is mistaken for a malignant melanoma, and because unless we pay characterization to the location of the nucleus and the prominence of the nucleoli, we mistake it for a melanoma. And sometimes we take the help of immunocytochemistry to help your diagnosis. They are positive for low molecular weight cytokine. This is the way we differentiate this from squamous cell carcinoma. Paget's disease cells are positive for low molecular weight cytokeratitis, whereas squamous cell carcinoma cells are positive for high molecular weight cytokeratitis. And they are HER2 positive. Very, very important one. Paget cell shows a very beautiful membranous positivity for HER2 in all the cases. 100% positivity will be there. Again, for melanoma, it's all, if we have to look for the nuclear features, suppose it's still confusing, you take the help of your markers. HMB45 will be positive in melanoma, whereas it will be negative for Paget disease. And we have some more entities like Pagetoid Bowen's disease, where we have a Pagetoid distribution of cells with diskeratosis. But we have to look in for diskeratosis, full thickness involvement, and presence of other cells. What you see in Paget, like your mucin-laden cells, are missing here. So this is one of the closest to DD, Pagetoid Bowen's disease of nipple. Or the other closest DD is superficial spreading malignant melanoma, where we mistake it for a pigmented Paget disease. If you suspect a melanoma, then look into the dermoepidermal junction. So there will be, it's a site of origin, so we have an abnormal proliferation of the melanocytes at the dermoepidermal junction, whereas you don't see such things in Paget's disease. Third one is mycosis fungoides. Again, very, very rare lesion. We go by, the diagnosis is made by the cerebriform or the convoluted nucleus, and in confusion, to confirm the diagnosis, we take positivity for LCA and CD3, whereas mycosis fungoides are negative for the EMA and CAM 5.2. Still more rarer are the Langerhans cell histiocytosis, where you have the nucleus, which are popped out nucleus, what we see in Paget's disease with abundant cytoplasm, whereas these cells are grooved. Look in the nuclear grooves are very prominent in LCH, and positivity for S100 and CD1A and HLA, DR and Langerhans markers. And Toker cells. So what are these Toker cells? So they are normal cells which are laden with mucin, what we see in the nipple. These cells are often confused with Paget cells. And the importance of these cells are, these cells can be the cell of origin for Paget's disease of nipple, where you don't have any underlying invasive ductal carcinoma. Okay, so they're very, very important one. The other one, Paget cells are, we already saw, they're negative for ER and 100% positive for HER2, whereas Toker cells are ER positive and negative for HER2. So that way we can differentiate a Paget cell from a Toker cell. The other thing, other diagnosis which is always mistaken is clear cell papulosis of the nipple, where we have got hypopigmented papules, but here it is distributed along the milk line. That's one clue, clinical clue, what we take to do. So Toker cells and clear cell papulosis are the other rare lesions of the nipple, which closely mimics a Paget's, but we have to differentiate it from Paget's. Now the last case of this slide seminar, which is a very, very rare case, just to highlight that we have to think of certain abnormal cases in abnormal sites. So again, a patient, similarly an elderly lady with nipple ulceration, so it was, no mass was palpable. So she was probably diagnosed that it could be a case of Paget's disease, and she went in for an excision of a nodule. But to her surprise, the entire pathology was down. It was not in the skin. So you see, there was tumor-like, there was infiltration of this large round to oval cells in these nodules in the upper dermis and the lower dermis. Again, there was areas wherein you could see the tumor cells infiltrating the upper epidermis, and the cells were very large, very highly anaplastic cells, prominent nucleoli. What do you think so? What could be the diagnosis?
Suppose at least give you a differential diagnosis.
Suppose I change the history. Suppose I'll give it as a neck mass. Elderly male patient having a lower deep cervical mass, and this is a biopsy from that mass, either a true cut or a incision biopsy. Wherein you see large cell. What lymphoma?
Cells. What lymphoma?
What cells? Just describe the cell, it will come. How are the cells? Small, medium, large? Large cells. And yes, someone said already. So they are large cell anaplastic lymph. So this is a large cell anaplastic lymphoma of the mammary skin. So here you see sheets of large cells which efface the dermis and they infiltrate the epidermis with marked cytological pleomorphism, large nuclei, numerous mitosis, and you also see multinucleate giant cells. So this was a case of anaplastic large cell lymphoma of the mammary skin. So they are positive for CD30, diffuse positivity. And just to say that it comes under the group of this peripheral T-cell lymphoma spectrum. So we have a certain entities which are grouped under peripheral T-cell lymphomas. They include the peripheral T-cell lymphoma not otherwise specified, anaplastic class, like in this case, extranodal NK or T-cell lymphoma, angioimmunoblastic T-cell lymphoma, gamma or delta T-cell lymphoma, and subcutaneous paniculitis-like T-cell lymphoma. So we have, these are the various spectrum of lesions which come under the family of peripheral T-cell lymphoma. And one of this thing is anaplastic large cell lymphoma. Okay. So with this, I conclude my slide seminar on the benign, borderline, and malignant lesions of the breast. So we have to optimize all the resources and we have to come to a reasonable conclusion. So any questions or any clarification I'd like to take few questions also from you if something was not clear or
Postgraduates, there is still time. You can ask questions if you want to. It was really, really wonderful session, Dr.
Thank you, Vijayashree Madam. Thank you for again yet another opportunity.
No, it was so good. I'm very specific that you have to talk to postgraduates because the way you teach them with the differential diagnosis and each point, your points to ponder, each one of them is so essential that they understand this is how a diagnosis is made. And diagnosis, not most of the time it is a spotted diagnosis. You have to sit and analyze and then make your diagnosis and then give your differential diagnosis accordingly change. So that kind of importance is very well brought in this section, and you covered I should say a spectrum of most important cases, right from benign to non-neoplastic, benign, intermediate, and malignant lesions, including the rare cases as well. It is very difficult to cover these kind of lesions in a very short time, making sure that the postgraduates do learn with each case. That is very important. Just covering is anybody can do. But the most important thing is putting those very important points and your pictures correctly depicting only those important points. That makes a lot of impact on the PG's brain, because a picture says more than words. So they understand much better. Thank you. Thank you so much.
Thank you, ma'am.
And
Thank you,
for
Vijayashree
all
madam.
the
and the
effort
team
you have
setting up.
taken.
Yeah. Okay.
Thank you so much, sir.
Thank you, madam. Thank you, sir.
Dr. Swaminathan,
Yes, madam.
I will be calling you for one UG session and PG session in
Sure,
person
ma'am.
here.
Sure, ma'am. Sure, ma'am.
You please tell your convenient dates sometime later in November or December.
Okay, sure.
Thank you.
And I also thank my postgraduate resident, Dr. Praveen, who has helped me in this presentation, because I was already stuck with some other meeting. So he only did all the work for me, and I want to thank him so much. He's sitting next to me here, patiently watching the presentation. Thank you, Praveen. Thank you so much.
Thank you, Dr. Swaminathan.
Thank you, madam.
Thank you, sir. We will now break for lunch and join by 1:20 p.m. for the afternoon session.
Dr. Lawrence, good afternoon.
Afternoon, madam.
How are you, Dr. Lawrence?
Yes, madam, I'm fine. How are you, madam?
I'm good, I'm good. Thank you so much for accepting our invitation. And
thank you, madam. Thank you for having me here.
Good afternoon, everyone. Welcome back. We will now move on to our next session. I request Dr. Catherine to introduce our next speaker, Lawrence, sir.
Good afternoon, all. It's my immense pleasure to introduce our esteemed speaker, Dr. Lawrence, Associate Professor of Pathology at Sri Ramchandra Medical College and Senior Consultant at Sri Ramchandra Medical Center. Sir has completed his MBBS at Katihar Medical College, BN Mandal University, and his MD Pathology at Sri Ramchandra Medical College, where he was awarded the prestigious Dr. SJS Paul Gold Medal in 2010. With 14 years of teaching experience, he has made significant contribution to the field, boasting over 56 scientific publications in index journals. Sir has presented papers and posters at various national and international conferences and has delivered guest lectures. Sir is also an active member of the esteemed Spark National Program. His expertise extends to authoring chapters in books related to neuropathology, head and neck pathology, and quality control procedures in histocytopathology. Sir is here today to enlighten us on the topic navigating the complexity of CNS tumor, key concepts for accurate diagnosis. We welcome you, sir. Over to you, sir.
Thank you for the kind introduction. Good afternoon to all. So, is my slide visible to all?
Yes, sir. It's visible, sir.
So, today I'll be discussing about CNS lesions in the purview of WHO 5th edition. So I'll start with a brief introduction, then I'll navigate through the CNS WHO, that is the 5th edition, and we'll see what are the changes in the classifications, what new things has been introduced. We'll also learn how to approach the gliomas in the context of the new WHO, and in each we'll try to analyze some case scenarios so that we can bridge our concepts with the reality. So starting up with a bit of the background, CNS tumors are not the common things that we see. It accounts for only 10% of all tumors, and it is just next to leukemias. And in fact, it has become more common nowadays, because not that its incidence has gone up, but because the treatment for leukemias have already evolved. So this has become the prime area of interest. And if you look at the adults, where metastasis is more common than primaries, but we get to see both. So now if we have to remember some tumors in both the adult and children category, so you could just remember in this manner. Most of the supratentorial tumors are in adults, and there are diffuse gliomas, and the prototypical example is the astrocytoma high grades, or you like to call them a glioblastoma. Then you have metastasis and meningiomas. Whereas when you look into the children, most of them are infratentorial, and the common ones there are medulloblastoma, pilocytic astrocytoma, and ependymomas. So these are the adult tumors, which is supratentorial. And when you look for children, most of them are in the infratentorial region. So CNS tumors, when you see what you see in the right side, you see a picture there. So this picture tells you the site where it belongs to. So in neuropathology, location of the tumor is almost everything. And there are so many entities, about 142 entities in neuropathology. And if you have to narrow down to a very few differentials, it would be rather difficult. So patient's age is very critical because the tumor we see in children are quite a bit different from the adult counterparts. And neuroimaging is very important in this case, and it often becomes a gross pathology surrogate. Therefore, location and imaging features are very critical in terms of differential diagnosis. So in neuroimaging, what do we see? We get an important clue about the diagnosis, where the tumor is situated, whether it's intraaxial or extraaxial lesion, whether it's multicentric or a single lesion. And we also get to know about the contrast enhancement and whether there is a shift to the midline to the other side. And also the reaction around the tumor, because if there is peritumoral edema, it tells us that the tumor could be a high-grade one. Now, the algorithm to follow is, if you get a tumor in CNS, the first question to ask is whether it's a glial or non-glial tumor. If it is a glial tumor, it should be intraaxial. And then you should think of what kind of glial tumor is this? Is it low grade or a high grade one? So here you see a bit of the history. The first edition of the Blue Book started in 1979, and all the way it has come up to 2016, and the latest edition is 2021. So what does this tell us? Initially, we used to diagnose CNS tumors on the basis of morphology. But of late, our clinical colleagues are more interested in the outcome of the tumors, that how these tumors are going to behave, because that is what finally matters to them, and also the treatment outcomes in these patients. So that is why from morphology, we have gone into molecular basis. So initially, if you see, in earlier days, we used to grade tumors into grade 1, 2, 3, 4, depending on how much these tumors are differentiated. And if how much necrosis is there, it will go to a high-grade tumor. So in 2007, that is the earlier WHO is 2016, and just before that. So gliomas used to be divided into astrocytoma, oligodendroglioma, and mixed oligoastro and ependymomas. It used to be divided like that, and astrocytomas used to be divided into diffuse and localized type. Then in 2016, a great change had come. So you see gliomas now broadly divided into diffuse and localized type, and this diffuse type can be in pediatric as well as adult type. And you have oligo and astrocytomas coming under the diffuse type of gliomas. And oligoastrocytoma, that entity doesn't exist, although you can mention in the diagnosis, but it has to be either an oligodendroglioma or an astrocytoma, because it has to be molecularly defined. Now in the new WHO, there are 13 entities that has been revised. So the ones that are highlighted are the common ones that we see. And if you can see the first one, the glioblastoma IDH mutant the term has been eliminated. Because if you put the term glioblastoma, it cannot be IDH mutant. It has to be a wild type. If it is IDH mutant, the word should prefix with the astrocytoma and not a glioblastoma. Then you can see solitary fibrous tumor. This term has come. It was earlier called as a hemangiopericytoma. Now we call it as solitary fibrous tumor. Then you have the craniopharyngiomas, the two types, which were the two subtypes. Now it is not a subtype because molecularly they are different. So we have the adamantinomatous craniopharyngioma and papillary. There are two different types. And in the pituitary lesions, we used to call it pituitary adenoma. Now we have to term it as pituitary neuroendocrine tumor. Other than this, there are various other less common conditions, which I'll not be going through. So what are the new entities which has been introduced? So you have almost 22 new entities that has been introduced in the new WHO. If you look at the gliomas, there are 7 glioma entities that has been introduced. And all of these gliomas that has been introduced are regarding the pediatric type gliomas, because this is a major change that has come out in the new WHO. So you can see diffuse astrocytoma, that is MYB altered, and you can see diffuse low-grade glioma, that is MAP kinase pathway altered. You can also see the histone altered gliomas and the midline gliomas. So all these gliomas that has been introduced in the pediatric age group are the new ones. Then you can find one pituitary lesion has come, the pituitary blastomas. Sarcomas have also come into the new category. And you have 4 embryonal tumors and ependymomas, that is the supratentorial ependymomas and the posterior fossa ependymomas, depending on whether they have the YAP fusion, positive or negative. And also you have a spinal ependymoma, MYCN amplified category. Now this picture is very important. So on the left side, you have a localized glioma, okay, a localized tumor. In this tumor, what you see, it is very circumscribed, and this is amenable to resection. So it can be completely cured by resection. Whereas if you see a diffuse glioma, the lesion has already spread beyond its confines. So it is not curable by resection alone. So medications has to be given. That is why the term diffuse comes into play. If you look into the survival rates of gliomas, the higher the grades, the less is the survival in these patients. So on the left is the previous 2016 classification. In the 2016 classification, there are numerous entities. Like you have a diffuse astrocytoma, IDH mutant, IDH wild. Again, you have the anaplastic type, which is IDH mutant. So there'll be numerous names given, which has now been very simplified. It just tells you in 3 categories. That is astrocytoma, it can be an IDH mutant, or it can be a glioblastoma, which is IDH wild type. And you also have an oligodendroglioma, which has to be IDH mutant, and it has to be 1p19q co-deleted. So compared to the 2016, it has been far simplified, and now you have only 3 categories to concentrate on. Also, you see in the new WHO, they are using the Arabic numerals to avoid confusion and mistakes. They also use the term CNS WHO grade. Okay, so this has to be put in the final diagnosis, and they've removed the word oligoastrocytoma, and they've also removed the term anaplastic. So in the previous WHO 2016, you see there are 15 categories compared to the only 3 categories you have in 2021. That is oligodendroglioma IDH mutant, 1p19q co-deleted. You have the astrocytoma, that is IDH mutant, and you have glioblastoma IDH wild type. You cannot call any glioma IDH mutant. It has to be IDH mutant to call it astrocytoma. You cannot call a glioblastoma if it should not have IDH mutant. So it should be IDH wild type. So if you see this, 2016 is just updated to 2022. Now there has been various inputs given by the C-IMPACT. The C-IMPACT stands for the Consortium to Inform Molecular and Practical Approaches to CNS Tumor Taxonomy. So neuroradiologist, oncologist, as well as neuropathologist from various parts of the world, they come and they give the inputs of the research, and that is what is incorporated into the new WHO. So they suggest that we have a multi-layered report in this. So there should be a 4-layered system. So in the layer 1, we have an integrated diagnosis incorporating all tissue-based information. Layer 2, we have the histological classification. Layer 3, we give the WHO grading, reflecting the natural history of the disease. And layer 4, we give the molecular information, whether it's IDH mutant, ATRX, or 1p19q or p53 mutant. Now, if you look at the simplified 2021 classification, gliomas are divided into adult type and pediatric type. And you also have the circumscribed astrocytic tumor, and you have the ependymal tumors. So it's very simplified now. So the pediatric type gliomas are further divided into low and high grade types. So the adult type diffuse gliomas in the 2021 classification, what do you see? It has to be an IDH mutant to call the tumor as astrocytoma. So it has to be an IDH mutant, and it has to be from grade 2, 3, 4. There is no grade 1 astrocytoma. Glioblastoma has to be IDH wild type, and it is a grade 4 tumor. Oligodendroglioma by definition has to be IDH mutant, and it has to have 1p19q co-deletion. And it could be graded into grade 2 or 3. And the IDH mutant glioblastoma glioblastoma term, which had been used earlier in 2016, has now been discarded. And now one important aspect which has come into play is the homozygous deletion of cyclin D kinase N2AB. So earlier we used to grade the gliomas on the basis of mitosis. We used to KI labeling index we used to use, but now there are no proper literature to suggest a specific KI labeling index to grade the gliomas. It was just arbitrarily graded based on how much, like if you get 2 mitosis easily found, then you grade it as 3. If you find 1 mitosis, you grade it as 1. So it was very arbitrarily given. And so now they are suggesting that it is mandatory to put cyclin D kinase N2AB. And if it is altered or deleted, then it is graded directly as 4. But if you're observing a tumor that is looking like a glioblastoma, that is having necrosis, microvascular proliferation, then you need not do a cyclin D to prove that it is a grade 4. So what are the markers recommended for the diagnosis of diffuse glioma? So you have to do an IDH1 mutation, you have to look for ATRX mutation, P53, and you have to see 1p19q loss. So these are the markers. And for grading the tumor, you have to do CDKN2AB and a KI. So mutation of isocitrate dehydrogenase. So it is seen that IDH1 mutation is much more common than IDH2. And this IDH1 can be done by using antibodies, which we usually do. And more than 90% of IDH mutation is located in codon 132 of IDH1 gene. And if it is positive, it implies a favorable prognosis. So if IDH is positive, it also denotes that it is of astrocytic lineage. And it could be graded from 2 to 4. So in this picture, you see the cytoplasm and membrane positivity. So that is how you have to detect an IDH1. Now, IDH positive could also be seen in oligodendroglioma. And it could be oligodendroglioma has a lot of differentials like a neurocytic neoplasm, DNET, clear cell ependymomas, clear cell meningiomas, pilocytic astrocytomas, metastatic tumors like clear cell RCCs. So all these tumors could be differentiated from oligo because these tumors are IDH negative, whereas oligo is IDH positive. So IDH also could be detected, ideally is detected by doing immunohistochemistry, but for non-canonical mutations, you can also use Sanger sequencing to detect other mutations like IDH2. ATRX mutation in gliomas. So ATRX is in diffuse astrocytomas. What happens? It is uses an alternate mechanism that is alternate lengthening of the telomeres with mutation of the ATRX. So what happens is ATRX is frequently mutated in grade 2, 3, and 4 astrocytic tumors. And instead of doing 1p19q co-deletion, you could rather do an ATRX by immunohistochemistry. So it could be like a IHC surrogate marker for 1p19q co-deletion. It is rare to find ATRX mutation in glioblastoma wild type. So if you see in this picture, the left side, it is negative, whereas the blood vessel endothelial cells are positive for ATRX, and some infap neurons are positive in the background. This is a mutated one, whereas in the right side, where it's positive, it is non-mutated and it's positive, that it is not loss. TP53 gene mutation. It is characteristic of astrocytic tumors that are graded from 2, 3, and 4. And it is not seen in low-grade gliomas like pilocytic astrocytomas, and rare to see them in oligodendrogliomas. Now, what is the method to evaluate them? Mostly we do it by IHC. You could also do it by sequencing. So what is the diagnostic importance of doing a P53? So it helps us to differentiate between an astrocytoma versus an oligodendroglioma. Okay, and also it helps us to identify infiltrating tumor cells in the adjacent white matter. 1p19q co-deletion is done by FISH, So it is the characteristic molecular signature marker for oligodendroglioma that are of grade 2 and 3. So by definition, an oligodendroglioma has to be 1p19q co-deleted. However, in a resource poor setting, you can do ATRX instead of doing a 1p19q co-deletion, so that along with IDH1 mutation, you can confer a diagnosis of oligodendroglioma. So also you can use radiological features to your benefit, like seeing an MRI. So in this, 1p19q co-deleted tumor will show calcification. It will be non-circumscribed, and it is usually a cortical or subcortical location. If you see a tumor that has more than 50% T2 flare mismatch, it is probably a non-co-deleted tumor. So there are other tumors which show 1p19q deletion in isolation or together. They are neurocytomas, meningiomas, and diffuse leptomeningeal granuloneural tumors. So molecular markers that has been recommended by the C-IMPACT now in the new WHO is that it recommends CDKN2 homozygous deletion to be done in all IDH mutant astrocytomas that are grade 2 and 3. If there is deletion of CDKN2, then it directly takes these IDH mutant astrocytomas to a grade 4 tumor. If you can see here on the left side is a 2016 and the right side 2021 WHO classification of tumors. What you see on the left side, the astrocytomas used to be graded on the basis of mitosis and on the basis of necrosis and microvascular proliferations. Whereas on the right side, what you see is astrocytomas which are grade 2 and 3. If it has CDKN2 homozygous deletion, it directly takes it to a WHO grade 4 tumor. So we no longer rely on the mitosis for grading these tumors. However, if you have microvascular proliferation or necrosis, you could directly label these tumors as astrocytoma, WHO grade 4 IDH mutant. You need not do a CDKN2 in these cases. So now astrocytoma IDH mutant grade 2 tumors, you need to prove that these tumors do not have microvascular proliferation, do not have necrosis, and CDKN2 homozygous deletions are absent in these. Similarly, in grade 3 tumors, you have to also show that they don't have proliferation of vascular structures, there is no necrosis, and they do not have the CDKN2 deletions. In the grade 4 tumors, it can either be proved by showing microvascular proliferation, necrosis, or you need not do a cyclin D kinase in these cases if this biopsy is showing a microvascular proliferation or necrosis. Now, what about the wild type low-grade tumors that are IDH negative? So when it is IDH negative, we called it wild type. So what about these tumors? These tumors, if they show TERT mutation, EGFR mutation, and gain of chromosome 7 and loss of 10, so they show a poor prognosis, which is similar to that of a IDH wild type glioblastoma. So in every tumor that is IDH negative, that is wild type, we need to do a TERT EGFR, and we need to check for the chromosome 7 gain and 10 loss to see whether these tumors really belong to the grade 2 or 3 category, or they belong to the grade 4 category. So if you have a grade 2 and 3 tumors that are IDH wild type, that means that are IDH negative, you need to check for the EGFR amplification and TERT mutation. So if these are present, if these mutations or alterations are present, you can directly label these tumors as glioblastoma IDH wild type. So TERT mutations can be done by Sanger sequencing, and EGFR amplification and monosomy 10 can be detected by FISH. So what are the terminology changes which are there in the CNS-WHO 5? So IDH mutant is only for astrocytomas. If it is IDH mutant, you have to label the tumors as astrocytomas. Glioblastoma, IDH is always IDH wild type, and you cannot call it an astrocytoma. Now they have employed the use of arabical Arabic numerals like 1, 2, 3, and they have not using the anaplastic word anymore. And for grading the tumors, they are asking, it is mandatory, in fact, to do the CDKN2AB homozygous deletion to call it a grade 4 tumor. So this is very important. What is NOS and what is NEC? Not otherwise specified, not elsewhere classified. So suppose you have a tumor, you're able to do the immunohistochemistry or molecular testing, and you have a final conclusion regarding the diagnosis, then you give it as give an integrated diagnosis. That is the green signal. Suppose you do not have enough investigation, you do not have immunohistochemistry, you do not have molecular workup facilities available in your lab, you can put it as NOS, giving a histological diagnosis. Suppose you have done all the investigations and they do not allow you for a specific diagnosis, then you label these tumors as NEC, the not elsewhere classified. So this is a simplified flowchart that will help you to analyze the case and diagnose them. So suppose you have a glioma and it looks like an oligodendroglial tumor, morphologically or phenotypically. You do an IDH. If it is positive or it is mutant, then you do an 1p19q codeletion. So you do a 1p19q codeletion. Then if it is 1p19q codeleted and IDH mutant, it directly tells you that you're dealing with an oligodendroglioma, IDH mutant, 1p19q codeleted, either a grade 2 or 3. Then if the tumor looks like an astrocytic tumor, and if it is p53 mutant or p53 positive, that is an astrocytic lineage marker. If it is ATRX mutant, and if it is IDH mutant, then it tells you you're dealing with an astrocytoma, IDH mutant. And the further test that you can do is a cyclin D kinase, because you have to prove that these grade 2 or 3 tumors are really grade 2 or 3 and not grade 4 tumors. So if cyclin D, CDKN2AB are deleted, then it directly tells you that you are dealing with a grade 4 tumor. Now, if you have an IDH wild type tumor, that is IDH is not mutant, then you have to do EGFR amplification or TERT mutation, or you have to look for chromosome 7 gain or 10 loss. So either one of them you have to do to prove that this is a glioblastoma, IDH wild type or not. So MGMT promoter methylation. So MGMT promoter methylations are usually preserved for glioblastomas in the elderlies. So it is a useful marker for checking the prognosis, and it is also a predictive marker, because if there is methylation in the MGMT, then these patients are more sensitive to the temozolomide treatment. However, if MGMT is not methylated, you cannot withhold the treatment of temozolomide, because there is no literature, there is no other treatment available for these patients. So patients who are above 55 years, you have, and who is a glioblastoma, that is IDH wild type, you have to do an MGMT methylation study. So in a methylated tumor, there is the treatment is good with temozolomide, whereas with unmethylated tumors, you can give a hypofractionated radiotherapy alone. So the tests that have been mentioned in literature are many, and they have recommended some, like you have the RT-PCR and you have the methylation specific PCR. So these two tests are there to show the methylation. Now this is a flow chart, how to approach a glioma practically. So if you have a glial neoplasm, so if you have a glial neoplasm that is a grade 2 or 3, you have to see the IDH mutant, whether it's IDH positive or IDH negative. If it is IDH positive and ATRX retained, that is ATRX positive then not mutated, then you need to do a 1p19q codeletion by FISH. If it is co-deleted, then it is an oligodendroglioma. If it is non-co-deleted, then it is a not elsewhere classified, because it is IDH mutant and phenotypically you're seeing a oligodendroglial morphology. So you're not able to type this tumor. So you put it as NEC, that is not elsewhere classified. Now, if it is IDH positive or mutant and ATRX is positive and ATRX is lost, then it is an astrocytoma. So now astrocytoma, if can be either a grade 2 or 3, then you have to do a CDKN2 to look for this deletion. If it is deleted, it is a grade 4 tumor that you're dealing with. So it is an astrocytoma IDH mutant grade 4. Now looking into the IDH negative tumors, so if it is ATRX is retained, you directly go and do a 1p19q co-deletion by FISH. If it is co-deleted, then it is a oligodendroglioma. If it is non-co-deleted, then you have to again reevaluate the histopathological slide to see whether it could be an astrocytoma. If ATRX is lost, then it tells you that you're dealing with an astrocytoma. You have to do IDH sequencing because IDH by IHC was negative earlier. So IDH, if it is, it can be a wild type, that is IDH negative, and one is IDH positive. If it is IDH mutant, then you have to label this tumor as astrocytoma IDH mutant. Now, this IDH mutant astrocytoma, again, you have to do a cyclin D kinase 2A/B. If it is deleted, then you are dealing with the astrocytoma grade 4 IDH mutant. So now, if it is an IDH negative tumor by IHC as well as molecularly, you have to do an EGFR or a TERT or a gain of 7 to, or loss of 10 chromosome to prove that this is not a grade 4 tumor. So there are different variants of glioblastoma, which are wild type. So you can see the giant type glioblastoma and giant cell glioblastoma, epithelioid glioblastoma looking like epithelioid cells, which have the BRAF V600 mutation and which are also CDKN2 deleted. Gliosarcomas, in the gliosarcoma category, you can see the reticulin stain has been done and the sarcomatous component has taken up, whereas the glial component has taken up the GFAP. So this is a case workup for you. So you have a biopsy at the left side, so the H&E picture. So what are you seeing here is a glial neural parenchyma where there are some atypical cells. Why am I calling this tumor? Because it's all one cell type. It's not a polymorphous population. So it's a tumor definitely, and atypia is there, no mitosis. So this could be a grade 2 diffuse glioma. I'm calling it a glioma because I still don't know whether I'm dealing with an oligo or an astrocytoma. So now I put an IDH132H, that is the IHC, and it is positive. And then I check for the ATRX. ATRX is lost. So now I know I'm not dealing with a oligodendroglioma because by definition, IDH has to be positive. ATRX has to be retained in an oligodendroglial tumor. I've done a P53. The P53 is positive. It has to be positive in more than 10% of the cells to call it positive. And this tells you you're dealing with an astrocytic lineage. And Ki67 labeling index was a bit high. So probably taking to a grade 3. So our diagnosis is astrocytoma, WHO grade 3. And the further test that could be done in this is CDKN2A. If CDKN2A is deleted, it will directly take this tumor to a grade 4 tumor. It will become astrocytoma, IDH mutant, CNS WHO grade 4, if it is CDKN2A deleted. So we now come to one case. So this is a 40-year-old male presenting with a temporoparietal SOL. So in the left side picture, you can see the T1 weighted image where you can barely identify the lesion except for the compression of the ventricle. And so this is on the right side, the T2 weighted image where you can identify the confines of the lesion. But if you happen to take a biopsy on the other side or adjacent sites, you'll still find tumor there. So this tells you this tumor has spread beyond its confines. So this is the biopsy that we have. So it looks very bland, but it's all monotonous. It looks like oligo-like morphology where the cells are round, but not having a clear-cut perinuclear halo. So I'm dealing with a glial neoplasm. So in this picture, as you see, atypia is there. So minimum I can label this as a grade 2 lesion or grade 2 glioma. So atypia is there. I don't find any mitosis in this. So what are our differentials? Since it was monotonous, it was round, looking like oligodendroglioma. So that could be in the differential. Astrocytoma, however, also is in the differential. And it's not a glioblastoma, neither an astrocytoma grade 4, because it lacks vascular proliferation and necrosis. And it is not a reactive process because atypia is there. That minimum takes it to a grade 2 tumor. So the differential main is oligodendroglioma and astrocytoma grade 2. So IHC, what does it show? GFAP is positive, IDH is positive, ATRX is negative, that is mutated, and P53 is positive. So P53 is a marker of astrocytic lineage. So I'm dealing with an astrocytoma. On the left side, ATRX. So ATRX has to be positive in a oligodendroglioma, or it has to be retained in an oligodendroglioma. So what I'm seeing here is an astrocytic lineage tumor. And the Ki is a bit high. So this tumor is an astrocytoma because P53 is positive, ATRX is mutated, and it is a grade 2 tumor, and it is in the temporoparietal. So we have to label it like this. Finally, astrocytoma, IDH mutant, CNS, WHO grade 2, temporoparietal. So what next after this? So this is not the end. So you have to do molecular testing for CDKN2A. If it is deleted, then this tumor is astrocytoma IDH mutant, WHO grade 4. So this picture is very important. So this is basically you're seeing a glial tissue. So what basically you're seeing some clusters of cells. This is the pyre. Some clusters of cells here. These are the tumor cells, which have caused some subpyral condensation. And this is one neuron which has been surrounded by tumor cells. This is a blood vessel which is surrounded by tumor cells. So this is basically the adjacent brain tissue which has been infiltrated by the tumor. So if you see this area in a frozen section, or if you see in the permanent section also, so this minimum, it tells you that you're dealing with a grade 2 tumor, because by definition, the grade 2 tumor are diffuse gliomas, and they would have spread beyond its confines at the time of diagnosis. So this has spread to the adjacent brain tissue. The minimum diagnosis in this is a grade 2 tumor. So these are called the structures of Scherer. They are called the perineuronal satellitosis and perivascular cuffing of the tumor cells and subpyral condensation. This was first described by Dr. Scherer in 1940. And thereafter, now we have found the importance of this now, particularly in terms of frozen sections. Now go to the next case. This is an elderly male with a contrast enhancing lesion in the temporoparietal region. So you can see the lesion here. So what we find in this picture is a very cellular lesion. So we can see more blue than pink. So in the low power, nothing much. So again, we are seeing it's a very cellular lesion, and focally there is some proliferation of blood vessels. High power, we see the cells are pleomorphic. They look very atypical, and we do find an atypical mitosis here in the center, tripolar mitosis. So definitely we are dealing with a grade 4 tumor with this much of atypia, pleomorphism, and a mitosis, which is atypical. Further, we see a vascular proliferation, that is an endothelial proliferation. And focally, we see an area where there is a palisading necrosis. So always you might not get good palisading necrosis. There may be some subtle signs, so we have to pick up in that. Over here, we have everything. We have the pleomorphism, we have atypia, then atypical mitosis, necrosis, vascular proliferation. So this is definitely a grade 4 tumor. So is it a metastasis? No, because if you do a GFAP, the GFAP will be negative in a metastatic lesion. Astrocytoma, yes, it could be, but it has to be an IDH mutant to call it astrocytoma. Can it be a glioblastoma? Yes, if it is IDH negative or it is not mutated or wild type, then it could be labeled as a glioblastoma. Can it be a lymphoma? No, it doesn't look like that. Lymphomas usually have an angiocentric pattern, so that is not seen here. So we see the GFAP, it is positive, the Ki is very high, and IDH is negative. So we are dealing with a high grade, that is a grade 4 tumor, that is IDH wild type. So what is the next step? Do we do sequencing for CDKN2, or do we go for MGMT methylation studies? The answer is, if it was IDH mutant, we would have labeled this as an astrocytoma IDH mutant, CNS WHO grade 4. Now that it is IDH wild type in a 72-year-old that is above 55 years, there is no point in going for a IDH mutant by molecular testing, because the prognosis, whether it's negative or positive, remains the same. So the best thing is to go for MGMT promoter methylation studies to see the efficacy of temozolomide treatment. So here you see if it is IDH wild type, and if it is not looking like a glioblastoma, if it is looking like a grade 2 or 3, then you have to do a TERT, EGFR, gain of 7, a loss of 10. If it has all these features, microvascular proliferation and all, then directly you can label it as a glioblastoma IDH wild type, CNS WHO grade 4. If the patient is above 55 years, you need not do a IDH sequencing, because you need not prove that it is IDH positive or negative by doing sequencing studies, because it's expensive and the prognosis, whether it's negative or positive, remains the same. So the next case is a 40-year-old male with a temporoparietal SOL. So what we see here is a normal glial tissue in the surrounding, but over here we see some specks of calcification. So these calcifications and high power is prominent, and in between we find some tumor cells. So at high power in these areas, we find these tumor cells that are round, and there is some perinuclear halo. So phenotypically, it is looking like an oligodendroglioma, and it does have some vascular pattern in the background, the chicken wire-like pattern. And there is some nuclear atypia in them. So minimum a grade 2. If there is some mitosis which is popping up, it could turn up to be a grade 3. So by H&E, this diagnosis is oligodendroglioma, could be a grade 3 tumor. So IHC, let us see, P53 is negative. So P53 negative, P53 is a marker of astrocytic lineage. Now, when it is negative, it tells you you're not dealing with an astrocytoma, most probably. ATRX is retained, that means it should not be an astrocytoma. IDH is positive and ATRX is positive. So ATRX and IDH together is the definition for oligodendroglial tumor. And you see the Ki is less. So what we are thinking of a grade 3 tumor is now looking with a less proliferative index, and GFAP is positive here. So this could be a grade 2 tumor. So it is oligodendroglioma IDH mutant, CNS WHO grade 2. So again, I repeat, so to call it an oligodendroglioma, it has to be IDH mutant, and it has to be 1p19q co-deleted. But in a resource-poor setting, you need not do a 1p19q co-deletion study, which is a little expensive for the patient. So in these cases, you can go for a surrogate marker for ATRX. So ATRX adjunct with IDH, you can confer a diagnosis of oligodendroglioma. Now we come to pediatric type gliomas. Now this is a separate entity mentioned in the new WHO. Now the pediatric type gliomas are two types. There are low grade types and the high grade type. And the question is how to label them as low grade and high grade. So the conventional way of grading we will do in the H&E, what we used to do. So we will grade it as 1 or 2, and this grade 1 or 2 will fall in the low grade category. And in the high grade category, the grade 3 and 4 will fall. Okay. So now in the low grade category, we see they are the diffuse astrocytomas, which are basically MYB1 or MYB1 altered, L1 altered. And there are angiocentric gliomas. That is the plenty type of tumor, that is polymorphous low-grade neuroepithelial tumor of young. And we have the diffuse low-grade gliomas, that is MAP kinase altered gliomas. In the high-grade gliomas, basically, you can see it is quite different. It is histone altered. We have the H3K27 altered and H3G34 altered. So these are histone altered. And the third one is H3, that is histone 3 wild type, where you don't find the histone mutations. And the fourth one is molecularly defined. They are the infantile type hemispherical gliomas, which are found in children less than 1 year of age. So now what is important in pediatric type diffuse gliomas? Why do we call it pediatric type and not pediatric gliomas directly? Because these pediatric type gliomas are not confined to the pediatric age group alone. So these sort of tumors can be seen in adult type also. and vice versa. So they are only differentiated on the basis of molecular differences and behavioral change, behavior of the disease. And they may have a similar morphology to the adult counterparts. So there is some overlaps can be there. So that is the reason we call it a pediatric type and adult type diffuse gliomas. If you look at this picture, the predominant mutations that are present in adult type is IDH mutation, and you also have 1p19q codeletions in the adult type. Whereas in the pediatric type, you find the histone altered and you have the RAS and MAP kinase altered. So in the pediatric type gliomas, again, so it could be histone altered, TERT mutations. You can see the EGFR mutant ones and PTGFR and MYC amplified ones. Whereas in the pediatric low-grade gliomas, it could be the RAS and MAP kinase altered. Now, one of the important things to note in pediatric type gliomas is they do not progress from a low-grade to a high-grade lesions, unlike the adult category. So they are basically standalone de novo types of tumors and with a specific molecular phenotype. So that is why it's very important. Another important thing to note in this is they're all IDH negative or wild type tumors, unlike the adult types. So two things you have to have in mind. One is they do not progress. That is why they're different. And the next thing is they're IDH negative. So pediatric diffuse high-grade gliomas, what are they? They are the H3K27 altered. These are called the midline gliomas occurring in the midline locations. Then you have the hemispherical gliomas, that is H3G34 mutant. So you need to remember K27 and G34 in that manner. So these are both grade 4 tumors. You have the pediatric type diffuse glioma that are IDH wild type, that is not having this histone protein alterations. And you have the infantile type hemispherical gliomas, which are molecularly defined, although you have IHC surrogates like AL-cross to identify these tumors. And this pediatric diffuse type high-grade gliomas, which are histone wild type, it is totally molecularly classified. So you need to have a molecular testing to identify or diagnose this disease. So diffuse midline gliomas, we all know that it is usually the midline structures that are affected, like the brainstem, thalamus, spinal cord structures, and sometimes the cerebellum. And one important thing to note in this is this need not have a grade 4 feature on biopsy. It can have a very low grade morphology. It can sometimes look like an oligodendroglial tumor or a pattern. It can look like a PXA-like pattern. So you need not always have a high grade morphology to call this a grade 4. Because morphology is not important here. What is important is to show the deletion or alteration of H3K27. If H3K27 is altered in this tumor, it takes it to a grade 4 tumor. So here is a 20-year-old male complains of headache and vomiting for the past 2 weeks. So we have a diffuse midline glioma. We see it is H3K27 altered. It's a nuclear positive. If you look at the HNA, it's very bland looking. It looks like an oligodendroglial tumor. It looks like an astroglioma, which is a low-grade one, with some neurons entrapped in between. But H3K27 is positive, and this tells you it's a grade 4 tumor. And you can also see OLIC2 positive in this cases and ATRX mutant. That is, ATRX will be negative. Infant type hemispherical gliomas. These are usually seen in less than 1 year of age, and usually the frontal lobe is affected. And this is all RTK altered tumors. You do have surrogate IHC markers like ALK, TRK, ROSC, and MET. But these markers can only suggest a diagnosis. They cannot give you a confirmation regarding this diagnosis. For confirmation, you have to do a molecular testing like DNA sequencing or a FISH study. And officially, this tumor has not been graded yet. Now coming to the histone G34 mutant hemispherical glioma, not the midline. We have finished the midline. We have come to the hemispherical glioma. So if you see a hemispherical glioma in an adolescent or a young adult or a child, you can encounter a high-grade tumor, and which might be a giant cell glioblastoma-like, which can have peanut-like areas, and which can be a small cell GBM-like areas. So if you do a KI, you'll find the KI is very high. because it's a high-grade tumor. P53 is positive, showing an astrocytic lineage. And you have the histone 34R positive and OLIC2 is negative. So this is a diffuse hemispherical glioma, which is H3G34 mutant, and it is a grade 4 tumor. Now coming to the low-grade tumors. So low-grade tumors, we have the diffuse astrocytoma, that is NYB altered. We have the angiocentric gliomas. We have the PL plenty type of tumors, that is polymorphous low-grade neuroepithelial tumor of the young. These plenty tumors, the main differential is oligodendroglioma. And the fourth one is MAP kinase pathway altered. They are the diffuse low-grade gliomas. So if you look at these 4 tumors, so first, when you see these tumors, you have to first see whether you're dealing with a astrocytic tumor or a oligodendroglial-like tumor, or whether it's a high-grade or a low-grade type. The second thing you have to do is you have to first differentiate it from an adult astrocytic tumor, because as I told you, the adult tumors are IDH positive, and whether by dictum, the pediatric tumors are IDH negative. So that will help you differentiate them. These angiocentric gliomas are usually EMA positive, and they have an angiocentric pattern, and they are OLIC2 negative. You have the diffuse astrocytoma, MYB altered. These are also OLIC2 negative. Now, plenty is positive for OLIC2 and also diffuse low-grade glioma. Now, how do you differentiate plenty from diffuse low-grade glioma? Plenty exactly looks like a oligodendroglioma. It has that look, but it does not have the 1p19q co-deletion, and all it has the BRAF V600D mutation. It is positive for that. So that is how you identify. It is also CD34 positive. So it is CD34 positive. It is doesn't show any co-deletion for 1p19q co-deletion, and also it is BRAF V600 positive. So this is plenty. So you see a tumor which is looking like oligodendroglial tumor. So these tumors will have calcification, as you see in oligodendroglioma. It exactly looks like the same like the adult oligodendroglial tumor, but these are IDH negative, and these are 1p19q. These are not co-deleted. They are intact, and CD34 is positive in these tumors, and BRAF is positive. So these tumors are important to diagnose. The importance is that these tumors have an excellent prognosis. And if you're diagnosing these tumors as an adult oligodendroglial tumor by mistake, that confers a bad prognosis compared to these. Now, what are the circumscribed astrocytic gliomas? So these are pilocytic astrocytoma, pleomorphic xanthostrocytoma, grade 2 or 3, chordoid gliomas, grade 2, and we have high-grade astrocytoma with pyloid features, which has not been graded yet, and subependymal giant cell astrocytoma, grade 1, astroblastoma. It has to be MN1 altered to call it an astroblastoma. This also hasn't been graded yet by the WHO. Now coming to the meningiomas. So this is a 40-year-old male, history of headache and seizures, and this is an extraaxial lesion. So when I get this extraaxial word, it tells me that I'm dealing with a meningothelial tumor or maybe a mesenchymal tumor, non-meningothelial. So either of them. So we see tumor cells which are looking like meningothelial cells arranged in syncytial pattern, and some amount of nuclear degenerative atypia is seen, and not much mitosis in them. So the Ki is very low, and EMA is positive around the tumor cells. So this is a grade 1 tumor, meningioma. So these are the various subtypes of variants of grade 1 tumor you see on the left side: meningothelial, fibromatous, transitional. So what I want to say is, now the names are not important. What is important is grading the tumor. So your main concentration has to be there. When you get a meningioma, you have to grade the tumor. For grading the tumor, you have to look at the mitosis, whether there is any brain parenchymal invasion, and whether there is anaplastic features, rhabdoid features. Those are main important. So main aim is to grade these tumors. So this is a GFAP been done. So we can see some entrapped glial tissue in between to document that there is some glial invasion. So whenever there is infiltration of the adjacent glial tissue, it directly takes it to a grade 2 tumor, even though it doesn't have the ATPR and the required mitosis. So the WHO has the criteria for grade 2 tumors are if you get 4 mitosis and more up to 19, it is a grade 2 tumor. So moment you get a meningioma, it is an extraaxial lesion and you know it's a meningioma, you should count the mitosis. If the mitosis is less than 4, it's a grade 1 tumor without any anaplastic features, without any necrosis or so. But if the mitosis is 4 and above up to 19, then probably you're dealing with a grade 2 tumor. A grade 3 tumor can have anaplastic features, or it can be defined molecularly, like you can do a TERT promoter mutations, or you can also check for a CDKN2 deletions. So if it is deleted and the TERT promoter mutation is present, it may tell you that you're dealing with a grade 3 tumor. So the next case is a 35-year-old male frontal lesion. There is a frontal lesion which is abutting the neuroparenchyma, and it looks like an extraaxial lesion. So what I'm seeing is extraaxial, I'll have to think of a meningioma or meningothelial, non-meningothelial mesenchymal tumor. What I see here is a lot of spindled out cells in patternless pattern, and this could be a fibrous meningioma, probably. The nuclear chromatin, there is some amount of atypia, not much. So we see some blood vessels here and not many mitosis here. So what are the differentials? Our differentials is fibrous meningioma or an SFT or a synovial sarcoma. So immunohistochemistry will help us in this. We can do an EMA. If it is positive, it tells us we're dealing with a fibrous meningioma. SFT, we have to do a STAT6. And for synovial sarcoma, we have to look for the TLE1. So here, STAT6 was positive, and you see the KI labeling index was fairly low. So the diagnosis is solitary fibrous tumor, CNS WHO grade 1. Why WHO grade 1? Because the mitosis is less than 5. Grade 2 tumors and grade 3 tumors will have mitosis that are greater than 5, equal to 5. But along with that, if there is necrosis, it takes it to a grade 3 tumor. And grade 2 and 3 tumors are considered malignant. So we have to be careful in this. So because adjuvant radiotherapy has to be given in these patients, whereas in the grade 1 tumors, surgical resection alone is enough. Next case, we have a 6-year-old child presented with a cystic SOL in the posterior fossa. So we have a cystic lesion and possibly with a mural nodule. So when you have a cystic lesion, a child in the posterior fossa, you know the diagnosis, the site, the age. So it tells you the diagnosis. So you find some glial tissue here. Then you see this glial tissue, it's very rarefied, a lot of microcystic changes in the background. And you can see a lot of blood vessels. These blood vessels are showing some hyalinized change and a lot of microcystic changes in the background. The tumor cells in between are very bland, look like lymphocytes. And this microcystic change in the background actually is the clue to tell you that you're dealing with a neoplasm, but it is a low-grade neoplasm. So in the high power, you can see these Rosenthal fibers, these elongated Rosenthal fibers, and some eosinophilic granular bodies. So this is, you're dealing with a pilocytic astrocytoma, CNS WHO grade 1. So if you look at this, you see pilocytic astrocytoma BRAF fusion. They have BRAF fusion, whereas all the other grade 2 onwards gliomas, they are related with IDH mutations. They're related with 1p19 codeletion P53, which is not seen in pilocytic astrocytoma. It's just like a different tumor from grade 2, 3, and 4. This is a 9-year-old male with an SOL in the 4th ventricle. So this is a T1 weighted image, and it's looking like a midline cerebellar mass. So what could be your diagnosis? 9-year-old male, 4th ventricle. So what we see here is very cellular lesion, and we have some areas which are paucicellular and some very cellular areas forming nodules. So very cellular, and these cells are all blue, increased NC ratio, nuclear atypia is there. So this is a medulloblastoma, CNS WHO grade 4 by definition. So there are different morphological patterns. We have the classic medulloblastoma, desmoplastic nodular medulloblastoma with extensive nodularity, large cell anaplastic medulloblastoma. So this can be morphologically classified, and also it can be molecularly classified if you have options for doing molecular testing or IHC. So it is divided into 4 groups based on DNA copy number and mRNA expression profiling. So it is divided into SSH, WNT pathway, and group 3 and 4. So here is the flow chart. If you look at the flow chart, you have the 4 categories. You have the WNT activated, you have the SSH activated TP53 mutant, you have non-WNT, non-SSH pathway, but the TP53 is wild type, that is group 3, and you have the group 4, which is again non-WNT and non-SSH. So if you see the WNT activated type, you can do a marker that is beta-catenin. If it is showing nuclear positive, then it has an excellent prognosis, medulloblastoma with excellent prognosis, even if it has a TP53 mutation. And most of these medulloblastoma you see are the classic type. So a WNT pathway, whenever you get a medulloblastoma, you can do a beta-catenin. You can do other 2 markers, which are GAP and YAP proteins. The next one is SSH activated TP53 mutant. In this, you can the GAP and YAP will be positive in the internodular areas where it is the cellularity is less, and they have a very poor outcome even with TP53 mutation. The next one is group 3 and 4. So mainly the classic type can also come in this, and the large anaplastic variant can come in this. So over here you see the beta-catenin will be positive, but in the cytoplasm. So if you have a medulloblastoma and these sort of tumors which is showing nuclear positivity in with beta-catenin, then you can label it as a WNT activated. If it is not showing nuclear positivity, if the beta-catenin is in the cytoplasm, you have to label it as non-WNT, non-SSH activated. So this usually have a poor outcome with MYC overamplification. So I would like to summarize at the end, like what are the markers we usually use or encounter in dealing with gliomas and other tumors, meningiomas, and non-meningothelial mesenchymal tumors, medulloblastoma. So we can do ATRX. So ATRX, we can look for the expression. It is usually expressed in the nucleus. If it is positive, it is retained expression, it is not mutated. P53 has strong nucleus, it will show strong nuclear staining. H3K27, similarly, it will show nuclear staining. Then you have the H3G34, nuclear staining, BRAF V600, nuclear and cytoplasmic staining, IDH1, that is R132H, that will have nuclear as well as cytoplasmic staining. YAP and GAP will show strong nuclear staining. Beta-catenin will have both membrane staining and nuclear staining. So if it is nuclear staining, it will show that it is a WNT activated pathway. So now what are the molecular markers that you can utilize? So you can use FISH for doing 1p19q codeletion, CDKN2AB, and EGFR. Whereas for IDH1 and 2 and TERT mutations, you can do Sanger sequencing. So these are the methods that you can use to interpret. So the conclusion is to, we have to recognize the various molecular testing because it is important, because we have to know which test to order in which conditions. So looking at the morphology, phenotypically, it may look like something, but genotypically, molecularly, it may look like something else. So ultimately, molecular trumps over the H&E. So we have to rely on molecular testing. However, if technologies are not available, if the lab facilities are not there to provide immunohistochemistry or molecular testing, we can generously use the term NOS that is not otherwise specified, and we can put our HNE diagnosis and put as NOS, and we can put the grade according to the HNE so that it can be tested further. So thank you all. Any questions?
Dr. Lawrence?
Yes, ma'am.
It was a very, really very, I should say, detailed explanation of WHO classification. I hope our PGs, especially the exam going PGs, would have really understood it, because they all read now the latest 2021. Nobody is reading the old one now. So at least they know what are all the new entities, and of course they understand the importance of having IHC and molecular testing before signing out any report. And no reports are complete without these, obviously, in these days.
Yes.
And it was very detailed explanation, and the cases were also very good. Recently, we had a adult medulloblastoma. It was anaplastic. It was not a pediatric age group. It was an adult medulloblastoma, actually.
Adult type. It's rare to find this.
Yeah, it's very rare.
Rare.
I mean, the cases were also very good. The images were very good.
Yeah, these are all the cases that we usually receive.
I know.
We try to incorporate as a few of the IHC markers.
Yeah. I know you receive a lot of neuropaths slides there. Because from the beginning, your institute has been always receiving neuropath. Dr. Reginald was there, and from the beginning we used to get. Postgraduates, any doubts if you have?
Yeah, any questions from any basic questions like for exams or?
Yeah, exams definitely one of these tumors will be there, or at least two of these will be there in the exam.
Basically, we have to look for the history, intraaxial, extraaxial, the age of the patient. So these history will be there, which will be the factor which will allow you to make a diagnosis.
Yeah, unless it's straightforward and they give it a slide for diagnosis.
Yes, ma'am. Either a straightforward case or a nice history there.
Anyway, it was quite nice.
Now, again, it's integrated diagnosis, ma'am. So I think now they have to have a formatted case. So they have to also answer which IHCs they would like to prefer in this.
I mean, the slide is only for them. They have to answer the latest molecular testing and all the
molecular testing.
Definitely, because anywhere outside, even in small lab, if you report, you can't report a CNS tumor without any of these. It has to be a layered report, indefinitely.
Yes, ma'am. Yes, ma'am.
Because clinicians, I mean, neurosurgeons and neurologists cannot treat the patient without it.
Yes, ma'am.
It was very nice presentation. Thank you so much for all the effort.
Thank you, ma'am. Thank you for having me here. Thank you. Yes, ma'am.
Thank you so much.
Thank you.
Jane?
Yes, ma'am. Thank you, sir, for your enlightening session. Now, I request Dr. Kamal to introduce our next speaker, Chatura ma'am.
Thank you, ma'am. Good afternoon, everyone. Today, with great pleasure, I would like to introduce our next speaker, Dr. Chatura K.R., a highly respected pathologist and educator with an illustrious career spanning nearly 4 decades. Dr. Chatura completed her MBBS from Mysore Medical College in 1985, followed by an MD from KMC Manipal in 1989. After gaining valuable experience in gastrointestinal pathology at CMC Vellore, she joined the Department of Pathology at JJMMC Devanagari, where she served for 20 years, retiring as the professor in 2023. With over 70 publications to her name, including contributions to international and national journals, Dr. Chatura has also made significant academic contributions by co-authoring 5 chapters in the 10th edition of Boyd Textbook of Pathology. Her expertise spans various specialties, including gastrointestinal, salivary gland, oral, breast, bone, soft tissue, ophthalmic pathology, and cytology. Her contributions to academia and mentorship have made her a familiar and respected figure among pathologists and oral pathologists, particularly in Karnataka. Dr. Chatra has been an active member of key organizations like KCIAPM, KCIAC, IAC, and IAPM, and she has been invited to share her insights on numerous platforms across both state and national forums. She has had a long-standing association with our institute, where she has delivered 3 lectures and slide seminars over the past years. Dr. Chatra has also been a dedicated reviewer for multiple esteemed journals in our field, ensuring the continued growth and excellence of the pathology research. Please join me in welcoming Dr. Chatra KR, our esteemed speaker, as she shares her insights on the fascinating topic, dilemmas and delights in salivary gland pathology. Welcome, ma'am. The stage is yours.
Welcome, ma'am. Welcome. Welcome. How are you?
Hello, thank you. Good, nice. It's very cold here.
I know.
So, very really far away from Ireland. And I really wish to thank you all for giving me this chance. And I hope I take you through really delights and dilemmas in salivary gland. Thank you, Vijaya, and your team. I'm always indebted to you people.
No,
Can I share my... Yes, ma. Can I start now? Yes, I'll share my screen, ma. Can you see my screen?
Yes, we're able to see. Yeah, we're able to see.
Okay. Okay. And once again, thanks to the CARE-PARE team for giving me this opportunity. And I'm the last batsman in the first innings of the CARE-PARE 2024. I hope I'll not take too much of the time. And so let me speak to you on salivary gland cytology. And this flower is called Krishna Kamala. It's supposed to be telling you a lot of stories in Mahabharata, right? These are the Kauravas, the 5 Pandavas, Brahma, Vishnu, Maheshwara, and this is the Sudarshan Chakra. So I'm not telling that it's going to be difficult, but you could enjoy the rest of the seminar with a lot of thoughts in your minds, right? Let's start it. I'm having a problem. We all know the rationale for salivary gland cytology. One thing is it's an easy target and the superficial location of major salivary glands. And it's also a very useful alternative for surgical exploration of frozen section, which is seldom done in salivary glands. And the most important is it's very cost effective in a preoperative diagnosis. The other use is there's very minimal risk for infection, contamination of surgical planes, and there's very little risk of fistula formation or damage to facial nerves. And that is why salivary glands is one of our favorite organs in cytology. What are the indications for doing a fine needle aspiration? One is for a preoperative assessment of the swelling, right? We want to differentiate whether it's a salivary lesion in that location or a non-salivary swelling. And once we know it's salivary, we would like to know whether it's non-neoplastic or neoplastic. And sometimes for subclassification of neoplasms. Another indication is for confirmation of recurrent tumors and in high operative risk patients. So once you think it's salivary, you would want to know whether it's neoplastic or non-neoplastic. And if it's neoplastic, we would like to know if it is benign or malignant. Let me choose an. I have 5 options, right? Whether it's benign or malignant. But sometimes you will land up in this group where you don't know whether it is an epithelial lesion or a mesenchymal lesion. Non-salivary swellings in those locations or similar locations to salivary gland are lymph nodes which could be aspirated, bone swellings which are underlying the salivary gland, or sometimes in the upper part of the neck. So we need to remember there are chances that we could see non-salivary tissue in a salivary gland aspiration or thought to be a salivary gland swelling. Now the technique is standard and usually, as usual, in CIS we need to re-aspirate from residual solid areas. You can use a 23 or a 25 gauge needle, but salivary gland cytology is one where you could use all three stains, PAP stain, any Romanowski stain, and a H&D stain, which is available to you, because each one gives us a lot of insights into the diagnosis. Like Romanowski stain gives you a lot of idea about the background material. Now, what are the diagnostic considerations? We all know, as in surgical pathology, your knowledge and experience is very important, and it's going to be based on tissue architecture and the lesional patterns. Now, this knowledge is what we need to imply or apply even in interpretation of FNAC. So I always say fine needle aspiration cytology is a bridge between surgical pathology and cytopathology. So the knowledge you have gained from surgical pathology slides, you try to incorporate or apply when you are interpreting the cytology slides. That lets you come to a very near diagnosis. Now, in an FNAC specimen, how do you approach it? At low magnification, you look for overall cellularity, the relationship between the different components which are there, and you try and search for some tissue fragments which are there rather than a dispersed areas alone. Whereas when you go to high magnification, you look at individual cells and the nuclear features of individual cells, right? This is how you approach an FNAC specimen in any organ, right, for that matter. Now let's look at some delights in salivary gland cytology. I'm trying to tell you the morphological features first, right? So this would be that's why I'm saying, let's look at some of the delights when you do a salivary gland aspirate. This is, as you all know, is a tissue, salivary gland specimen, right, where you can see the serous acini and the related ducts, right? And there's a lot of adipose tissue which can be infiltrating between the lobules as the person ages. Now, how would this look to you in cytology? Right? Nearly identical if you're lucky. You get the serous acini like this and the duct where you can see the pavementing of the lining of the duct epithelial cells. Now, these serous acini are ball-like structures and there is maintenance of nuclear polarity. You find many of the nuclei are at the margins. So, this is how a normal salivary gland aspirate would look like. But as I said, we don't often aspirate normal salivary glands. So this is a chance when you have thought it is a non-salivary tissue and you aspirate, but you get a normal salivary gland tissue in your aspirate, right? That was a H&D stain and this is a PAP stain. So you can again see the small ball-like structures, right? Grape-like clusters as they are called of the acina structures. This is usually a parotid swelling. Now you can see some more in PAP, how it looks like. See, if you're lucky enough, you can identify these acina structures, right? Now, this is another area. Again, at the edge, you can make out the acina structure. So, this would be a normal salivary aspirate where you have acinar cells, ductal cells, and depending on the age of the patient, the adipose tissue. Now, coming to non-neoplastic lesions, are there chances of aspirating them? Yes, but they are quite rare to be aspirated, right? You have the various entities, acute and chronic sialadenitis, sialadenosis, cysts which are aspirated, and rarely you can come across crystals in an FNAC of salivary gland. Look at this tissue, it's full, or this smear, it's showing lot of neutrophils and some lymphocytes in the background, or they could be degenerating epithelial cells. Now, this would characterize an acute sialadenitis. But for our surprise, in an aspirate, we also saw these fluffy tissue or fluffy areas, right, which was nothing but an actinomycotic colony. So this patient had an underlying abscess in the molar region, maxillary molar, which had infiltrated into the parotid, and our aspirate gave us an acute sialadenitis features with actinomycotic colonies. When you look at a chronic sialadenitis, right, from a long time, so the acina structures have all atrophied on a biopsy, and you find only ductal structures remaining. So if you aspirate such an entity, right? What are we going to see? We're going to see a mixture of lymphoid population, right? Maybe scattered all over or in tight aggregates, and then residual ductal tissue. So this would characterize for a chronic sialadenitis. Very rarely could you identify this. We had a case where there were multiple granulomas, right, on a biopsy of the salivary gland. Actually, it was reported on the FNA, but the clinician went ahead and did a biopsy. Now, look at the aspirate of this case. We had the granuloma here, and we were lucky to get a multinucleated giant cell. But this is probably an extension of the tuberculous involvement of the mandible, right, which had extended into the overlying salivary gland tissue. Now, coming to this entity, you find there are a lot of acina structures, but compared to them, there's lots more of adipocytes. Now, if this is from a patient who has a bilateral swelling, then you would characterize this for sialadenosis, right, where there is lots of adipose tissue, no much inflammatory cells, and acina structures are present in plenty or equal amounts as the adipocytes. Now, coming to chances of aspirating a mucus cyst. You just get a mucoid material in the background with a lot of muciphages. But the only problem in such cases is if the patient has a residual swelling and you need to aspirate again, and you have to tell the clinician or correlate with the clinical features with the duration of the swelling, because this might be a false negative diagnosis of a mucus cyst in an underlying mucoepidermoid carcinoma of low grade. Now, so when you look at the fluid type that you can get a mucoid fluid or a watery proteinaceous fluid. Now, if it is a mucus fluid, what is the decision that you make? If it's associated with histiocytes and lymphocytes, then you would think of a mucus cyst or Warden's tumor here. Now, if there are papillary fragments with atypical cells, it could be a papillary cystadenocarcinoma. But if that mucoid material shows a myxoid or a chondroid appearance on the sections, on your smears, and with a lot of epithelial, myoepithelial clusters, it would favor a diagnosis of pleomorphic adenoma. And lot of mucin and intermediate cells, right? Then you think of mucoepidermoid carcinoma. Now, histiocytes and lymphocytes of variable amounts would be more in favor of a lymphoepithelial cyst or a mucus cyst. Now, if it's a watery and proteinaceous fluid, you have numerous lymphocytes and moderate to low epithelial cells, right? This would favor a Warden's tumor. Now, if it's scant to moderate lymphocytes and oncocytic epithelial cells, you would still be in doubt whether this could be a papillary cystadenoma or what is now called a Warden's tumor. Now, clusters of papillary atypical cells would go in favor of a papillary adenocarcinoma. Scant lymphocytes and bland columnar cells could favor a polycystic adenosis. Now, heavy lymphocytes plus moderate to very low epithelial would go in favor of a lymphoepithelial cyst. So, we can characterize the mucus and the proteinaceous fluid and decide upon what we need to call with the adjacent or other or tissue or cells that are present in your smear. Now, these are some of the crystals that can be found, tyrosine crystals in a salivary aspirate, but more often you may get an amylase crystals depending on how long the swelling your patient had in a chronic sialadenitis, right, where you could get a lot of amylase crystals. Now, moving on to neoplasms, because it's an salivary gland is an epithelial tissue, you get either adenomas or carcinomas. Now, the adenomas we know with the most common one, which all of us are familiar is pleomorphic, but the other entity we could just call them as monomorphic adenomas. And then you have basal cell adenomas. Now, the monomorphic adenomas would include your cellular pleomorphic adenomas and myoepitheliomas. Carcinomas, we all know, are adenoid cystic, mucoepidermoid, or acinic cell. Now, why I am trying to explain these are the most commonest salivary gland neoplasms. As it is, salivary gland tumors are very rare, but they are not rare on your exam table, right? You either get it as an aspirate or as a section. Though they are so rare to be seen, they are not rare in your exam material. Now, coming to pleomorphic adenoma, they would usually have a fibrillary chondromyxoid matrix, epithelial cells in singles and sheets. Spindle cells in the matrix are also important, but they are very regular nuclei with bland chromatin. The other adenomas, as I told you, monomorphic could be a myoepithelioma, cellular pleomorphic adenoma. The problem is we may not be able to pick up the carcinoma in a pleomorphic adenoma just on cytology, and we would have just called it a pleomorphic adenoma. This is how a pleomorphic adenoma on section looks to us, right? Lot of ducts with secretions inside, lot of stroma in between, right? And an occasional duct showing a squamous metaplasia. So on aspirate, something very similar to this you get, right? You get a lot of epithelial cells with the matrix behind. Now this is a HND where we may not be able to appreciate the magenta pink color, right? So you get to see now there is a close proximity of the epithelial clusters, the stromal cells and the epithelial cells that are scattered in the background. Another smear again, and now these are the spindle cells in the matrix, and you have the epithelial cells in the adjacent areas. So have a look at low magnification, look for these fragments, and then go into high power to look at their details. Now this is how the epithelial cells would look like, right? We may not be able to make out the ductal structures or glandular structures, but they are tightly cohesive. Now this is the magenta fibrillary matrix in a GIMSA stain, and this tint is picked up only in the GIMSA stain. Now this is a pap stain again, but you can pick out the single cells of the epithelium, and this is the matrix which is there, and the ductal or the epithelial cells forming duct-like structures. Now what happens if you have a lot of chondromyxoid areas, right? Then it would appear more background with lot of myxoid areas here, and the ductal cells are sparsely distributed in the background, right? So this would probably represent the chondromyxoid areas or the pseudocartilaginous areas we describe in pleomorphic adenoma. But the cellularity is extreme. The nuclei are very bland and regular. So we should remember that to merge the background material also when we make a diagnosis. Now this was a buccal mucosa swelling, and you can see the aspirate, but you could find the matrix material also. So this was a minor salivary gland pleomorphic adenoma. Now look at another patient who had a swelling below the angle of or at the angle of the mandible below the ear lobule. The matrix is fibrillary and magenta in the background. You have a lot of ductal epithelial cells and sheets, and the close association of the matrix with the ductal epithelial cells. So this would be a classical benign pleomorphic adenoma. Then you can sometimes concentrate or find in the isolated cells in the background which look like plasma cells, right? So these are your myoepithelial cells, right, which have a plasmacytoid appearance. You can get them in your aspirate, right? So this would define a myoepithelioma. Now, this was how this myoepithelioma looked like, lot of plasmacytoid cells in the section. Now, another aspirate, when you look at, it looks more uniform, right? Very cellular. I'm not able to make out the duct-like structures of elements, and the background is not showing me any matrix. So this would be a cellular pleomorphic adenoma, right? So the sections from this case was very similar to a cellular pleomorphic adenoma or a monomorphic adenoma. Other areas showed some duct-like structures. Then moving on to baseloid neoplasms, you have, if you are lucky, you get a lot of non-fibrillary stroma. But the important feature here is the baseloid cells, right? A definitive diagnosis may not be possible between an adenoma and a carcinoma, and because basal cell adenocarcinomas are usually diagnosed by infiltration. And an adenoid cystic carcinoma also comes in the differential if you do not get enough stroma. Now, this is a basal cell adenoma, which is again vaguely called a monomorphic adenoma, right? Because you have only one type of cells, but they are very small and basaloid. And then FNEC of this would look very cellular with tight basaloid cell clusters, right? But there's not much of the matrix in the background. You might see small cylinders, but not the huge ones that you see in an adenoid cystic carcinoma. And this is basaloid cells in tight clusters. This, all of you are familiar, would be an adenoid cystic carcinoma. Definitely an exam slide. But how do you think this would look on an aspirate? Right, this is another area of the adenoid cystic. You get a lot of basaloid cells separated by this basement membrane-like material. Now, on an aspirate, right, more areas where you get hollow cylinder-like areas here, right? And you're lucky, sometimes the material is retained in sections. So this would be an adenoid cystic carcinoma. So on an aspirate, you get to see the similar thing, right? You get tight clusters of basaloid cells with a lot of clear spaces, especially in PAP and H&D stain. These are your hyaline cylinders because they dissolve or become translucent in alcohol fixation, the material in them. And they are also called as cookie cutter appearance, right? You make cookies with a cutter once you have pressed out the dough, and that's how it looks like this. So these are your hyaline cylinders, which are transparent in PAP and H&D stain. See, again, even in H&D, you find them to be empty spaces or slightly stained. But when you look at a Giemsa stain, you will pick up the hyaline cylinders, right? They are dense, but they are not like your pleomorphic adenoma, where it is very fibrillary and spreading out in the background. Another case where you had plenty of basaloid cells, but numerous hollow spaces, right, which represent the hyaline globules. So if they are numerous, then it should be called an adenoid cystic carcinoma, because the basal cell adenoma will have very, very rarely an hyaline cylinder. Right now, this was from a scrape in a palatal ulcer we had seen, and you can find the hyaline globule, right? The duct-like arrangement, right? Like a tube it is there, and plenty of hyaline globules. So this was an adenoid cystic carcinoma, which is supposed to be a very common minor salivary gland malignancy. You can see the cylinder, it virtually is very well circumscribed and tight, right? It just doesn't spread in the background. Now, moving on from the basaloid neoplasms and the adenoid cystic carcinoma you already saw, we look at other carcinomas in the salivary gland. The mucoepidermoid carcinomas, right? You will have the mucus cells, epidermoid cells, intermediate cells, and a mucinous background. But the important differential would be a mucocele, and in a rare chance, it's a metastasis from a mucin secreting adenocarcinoma. Now, this would be a low-grade mucoepidermoid carcinoma with plenty of mucus areas and very few epithelial cells. Now, even an aspirate of this, right, hardly I can pick up the intact epithelial cells in this mucinous areas. Now, even the aspirate would look something like this. So that's why I told you there are chances we would have just called this mucus cyst, and the possibility of a low-grade mucoepidermoid carcinoma cannot be excluded. Right, so this virtually becomes, and you find occasional atypical cells, right? Then you would have called atypical cells of undetermined significance. So you have to be careful, correlate with the clinical findings, if possible, a radiological finding, and re-aspirate the patient as a follow-up to exclude low-grade mucoepidermoid carcinoma. Now, these are just the mucin secreting cells, right, or the mucus cells in the background, and there could be a lot of macrophages also, but this is the mucinous background that is present. Now, when you look at another type, or the intermediate grade of mucoepidermoid carcinoma, you will tend to find more of intermediate cells also, right? So this would be a low intermediate grade mucoepidermoid carcinoma. So how would this appear on an aspirate, right? This is again another view of this. You can see the mucus cells, you can see the intermediate cells, right? So here you're getting to see mucus cells, You're also seeing a lot more of these tighter cells, right, which could probably be the intermediate cells or the epidermoid cells. More areas of the same. There were a lot of mucous areas, but there were a lot of epithelial cells which were in clusters, right? So you can see the epithelial cells in clusters and a lot of mucus, and this came from a mucoepidermoid carcinoma. Now, there were mucus cells in other areas, and mucinous aspirate tends to retain your hematoxylin muck, which is there, even if it has been filtered. A mucinous background holds a lot of this hematoxylin muck. Now, see, you can see the intermediate cells, you can see the mucus cells, lot of the hematoxylin muck, and this would be a mucoepidermoid carcinoma. Now, more clusters here and the mucinous background. Again, right? So it's a rare chance to see mucoepidermoid carcinomas, right? More often we see a pleomorphic adenoma, and that is why I wanted to show you a lot more areas, right? Which from few of our cases that we have had, right? This was a young male patient and a parotid lower pole, right? One dictum you always learn, a young male patient, the first probability is a mucoepidermoid carcinoma than even a pleomorphic adenoma. On aspirate, we saw the intermediate cells and the mucus cells. Now, this is another mucoepidermoid. On aspirate, had a lot of mucinous background, and see the specimen. You could see the coagulated mucin, intermediate cells, and mucus secreting columnar cells. Now, in this aspirate, I'm not able to show you any mucus background or mucus cells, but they were tight aggregates of atypical cells, right? And right, with mild atypia, but the mucin here and there, the muck was sticking on. Now, this came from a high-grade mucoepidermoid carcinoma, so much so we could not separate it from a squamous cell carcinoma. But one thing you should remember, mucoepidermoid carcinomas will never show keratinization. They're just epidermoid cells. On repeated sections, we could find areas which had mucin secretion. So this was a high-grade mucoepidermoid carcinoma. Now, this was one of our recent cases. He was a known case of mucoepidermoid carcinoma who had been operated, but the healing was very, very slow. And they suspected a recurrence of the tumor, and the patient was sent, but we just did an imprint from the smear. Now, you can see the malignant cells, right? Epidermoid cells which are there. And because it had been exposed, there was a lot of inflammation and neutrophils, and we could also pick up some giant cells, probably to the reaction to the ointment and the gauze they were trying to put for this patient. So one other indication for FNAC is a recurrent tumors. Now, moving on to actinic cell carcinoma. This is the rarest of rare tumors of salivary gland, even to see it on a histopathology sections. The smears would be cellular, and they show a lot of serous acini. Now, these acini-like structures are in sheets or disc cohesive sheets, but there's loss of polarity. You cannot appreciate the acinar structures, right? There's a background naked nuclei can be seen, but there's absence of ductal cells or grape-like clusters and adipose tissue. So you know it's not a normal salivary gland aspirate. Now, this is an actinic cell tumor. They used to call it a blue cell tumor because the smear sections look blue. And this was another area high power. Now look at this aspirate, right? There's no definite ball-like clusters. There were no ductal epithelial cells. There was a lot of background cells which were scattered, right? And no adipose tissue. So this was an actinic cell carcinoma. Quite rare to see, and maybe you get to see one case in your lifetime. So the commoner things first, then and only problem or diagnostic help would be it's a solitary swelling on one side of the patient, slow growing tumor. And when you get an aspirate like this, then you can think of an actinic cell carcinoma. Now, you get a whole lot of entities, or your aspirates may show you a lot of lymphoid cells. It could be from a lymphoepithelial cyst I showed you, chronic sialadenitis, This a peculiar variety of chronic sialadenitis called lymphoepithelial sialadenitis. Warden's tumors will show you a lot of lymphoid cells and definitely in lymphoma. So when you look at your FNAC classification, then you would have the non-neoplastic lesions and neoplastic lesions and lesions yielding a lot of lymphoid cells. Now, this smear had only lymphocytes scattered all around in a fluid aspirate, right? And this came from a lymphoepithelial cyst. We had been aspirating the fluid from here and we picked up a lymphocytes on our way out, right? So this was a lymphoepithelial cyst. Now, look at this specimen, a large unilateral swelling our patient had, right? Definitely multinodular it was looking at. And this has been one of the largest tumors I have seen. And aspirate showed us a lot of lymphocytes in the background and cells which had abundant eosinophilic cytoplasm, right? More eosinophilic cytoplasm. And the section was a Warden's tumor. This has been one of our largest Warden's tumor we have seen, right? Patient was a smoker with a unilateral swelling and an aspirate. We had suggested a Warden's tumor. So look for this oncocytic cells in a fluidic aspirate with a lot of lymphocytes in the background would give you a diagnosis of Warden's tumor. Now, another case that we had recently and more clearly you can see the oncocytic cells, right? The background had a lot of lymphocytes. Now, this patient had been walking around with this unilateral parotid swelling and he was aspirated elsewhere and we got the specimen on resection. So very, very fleshy specimen. So I had to get back to the patient to find out where it was aspirated and we did get the slides later. Now this section showed you a duct which is paired here, very few acini in the margins and a lot of lymphoid infiltrate also forming nodules which was very, very monotonous. On aspirate, they had aspirated a lot of lymphoid cells and there were no epithelial cells, right? Lymphoid cells and lymphoid cells in the aspirate. And look at this. This was the GIMSA, right? At places we had a more heterogeneous population. And this was a case of lymphoma, a mild lymphoma. The patient probably had a chronic sialadenitis or a lymphoepithelial sialadenitis, which had transformed into a low-grade lymphoma, right? So pure lymphoid population, possibility of a lymphoma needs to be suggested. This is one place where you could re-aspirate and do a flow cytometry on your aspirate, right? Where it becomes an ancillary technique to confirm your diagnosis of lymphoma. This was a mild lymphoma of salivary gland. Now, those were all your delights. I hope you felt rejuvenated and thinking, I might get to see one of this. But are there dilemmas when we aspirate salivary gland? Definitely. No, you want to know whether you're right or you're wrong. Now, what is the reason for this? One is we tend to give false negative diagnosis because of interpretation errors, right? We might have interpreted the cells wrongly or the background, or the sampling is inadequate, right? We might have the cystic areas, or we got a lot of mucin. Inexperience, as it is, these salivary gland tumors are so rare, and the relative rarity will not have given us a lot of experience. And precise diagnosis may not also be possible because of the diverse morphology in salivary glands. And there's an overlap of features, cellular pleomorphic adenoma and pleomorphic adenoma, myoepithelioma and pleomorphic adenoma. So there are a lot of overlap features which lead to a false negative diagnosis. And these entities are the ones which often have diagnostic problems. Basaloid neoplasms, like I showed you, and if it's only oncocytes, right, without much of lymphoid background, I would have called it an oncocytoma. Mucus containing cysts, as I showed you cases, high-grade carcinomas right, will all just be called high grade, and we may not be able to subtype them. Clear cell neoplasms and spindle cell lesions, they may be native to the salivary gland, or they might have been the metastasis or the underlying tissue extending into a salivary gland. Now, what are the false positive diagnosis causes? Cystic lesions, right? We have missed the malignant area or the lesional area, and we would have just called it a cystic neoplasm or cystic change in a neoplasm. Squamous metaplasia occurs in plenty of salivary gland tumors, so we might overinterpret them as malignant. Subtyping of neoplasms, it may not be possible all the time to subtype. Hyaline globules may mislead us. An occasional hyaline globule may also be seen in pleomorphic adenoma, but you need to have numerous to call an adenoid cystic carcinoma. Look at this. This was the aspirate. We had just called it degenerating cells, and even either they were histiocytes or degenerating epithelial cells. We had only this much of material, and when it was excised, the tumor was in the wall. This was a basal cell adenoma in the wall of a cystic structure, right? Whereas our aspirate, we had only got the mucus cells or degenerating cells, and this was definitely a false negative diagnosis. Now, so there are pitfalls in salivary gland aspiration cytology. What are the common lesions that are mistaken, right? So if it's it could have been an adenoid cystic, but we have called it pleomorphic or monomorphic adenoma because we did not get the hyaline globules. Actinic cell carcinoma can be mistaken for normal salivary gland or sialadenosis. Mucoepidermoid carcinoma, low grade for a benign cyst. High grade might look like an oncocytoma. Then metastatic carcinomas, NOS, we would have just called them sialadenitis. Squamous cell carcinoma is mistaken for a Warden's tumor. Now, lymphomas might be called as a benign lymph node. So these are some of the areas where we most often give a false negative diagnosis, and it's a pitfall for salivary gland aspiration. Now, all of us are hearing a lot of synoptic reporting, newer systems for cytology. You all know the Bethesda system in cervical cytology, then for urine cytology, the Paris system, like that. This Milan system is being adapted for salivary gland cytology. Now, it was first edition came out in 2018. Now, why did we try to do this? The American Society of Cytopathologists and the International Academy of Cytologists decided to sponsor or make a system for reporting salivary gland fine needle aspiration. Now, this was a uniform reporting system that would provide more effective structure to convey useful information to the treating clinician. Right till now, I was showing you the morphology and how to identify different salivary gland lesions as we know, or by the term that we know. What is the use for the clinician? He needs to know what he needs to do next with our diagnosis. Now, this has been revised into, and we have the second edition released in 2023. Now, this second edition, right, was giving us a little more backup, right? Because they have looked at a lot of systematic reviews and meta-analysis and modified a few things, but the basic classification is still remaining into 6 categories. The only problem now is we have definitely more experience to identify the risk of malignancies. So as a result, what was there in the first edition has been slightly modified. Any problem? Can I continue?
Yes,
Okay.
ma'am. Somebody had unmuted themselves.
Okay, sorry, ma. Milan, we all know, is a metropolitan city in Italy. I always think it is Milana, not even Milan. In Kannada, Milana means you merge the features, So I always think in salivary gland cytology, we need to merge both the foreground and background. So that is why I use the term Milana, which is a merging of both the foreground and the background, which is very much necessary to interpret salivary gland cytology. Now, this was in 2018, the risk of malignancies right? ROM for the 6 categories. You had non-diagnostic, non-neoplastic, ATP of undetermined significance, and in neoplasm, you had 2 subtypes, benign and salivary neoplasm of undetermined malignant potential. The 5th category was suspicious for malignancy, and the 6th was malignant. Now, when you look at the 2023, or say you audit your cases, you will find the benign neoplasms are the more common ones. And the next you have malignant, and this is the non-neoplastic. The rest of the entities make up a small portion. Non-diagnostic, suspicious for malignancy, undetermined significance, and some. Right? So most often or most of your cases would fall into the benign category. Now, the revised or the second edition has revised the risk of malignancies. Now, non-diagnostic remains the same, but only modification is you do not need 60 cells of salivary gland origin to call it a diagnostic aspirate, right? That criteria has been removed. Now, non-neoplastic could be either inflammatory, reactive, right? And infectious conditions. Now, when it's a non-diagnostic aspirate, there's a 15% risk of malignancy. This is again because of inadequate sampling, right? This tumor might be elsewhere. And non-neoplastic, as you think, you call it a reactive condition or an inflammatory condition, and we might have missed the underlying malignancy, more so in mucus cysts and in sialadenitis, which could be misinterpreted from a lymphoma case. Now, ATP of undetermined significance. You have features which are not adequate qualitatively and quantitatively to call a neoplasm, but you're not happy calling it as non-neoplastic. Now, the risk of malignancy here is 30%. Now, in your lab, your AUS cases should usually be less than 3%. Do not try to dump your cases into AUS. Speak to the clinician and try to come to a diagnosis. But if you still can't, then these are the people who need to be followed up, right? Either with a reaspirate or a radiological consultation, and keep this patient on follow-up. Now, in neoplasm, the benign category. Now, once you call it benign, the risk of malignancy is very, very low in them. Now, undetermined malignant potential, you are not happy to call it malignant, again, because qualitative, just based on cytological features, right? So you have just got basaloid cells. I cannot say if it's an adenoma or an adenocarcinoma. So you are uncertain of the malignant potential. And now in this group, the chances of malignancy are 35%. Now, suspicious for malignancy. Now here, qualitatively and quantitatively, they are falling short for you to call it malignant, but you have a very high suspicion for malignancy. Now here, definitely the features are of high grade malignancy, whereas here the features are of low grade malignancy. Now, once you call it suspicious for malignancy, the chances or risk of ROM is 83%. The minute you call it malignant, the risk of malignancy is 98%. Now here, it could be the primary malignancy of the salivary glands or a metastasis from elsewhere. That would also come under this category. So the second edition has modified this risk of malignancy. It has added ancillary techniques, which is still in the development. I don't think many of us have worked with the ancillary techniques because as it is, the salivary gland tumors are very rare. I hope I've been able to convey some parts or the delights and dilemmas. We look at a case-based approach to few of her cases. This was a 50-year female, parotid swelling of 1 year, but she did not have lymphadenopathy. Look at this, definitely a very cellular aspirate. And my PGs were saying, ma'am, there are a lot of vacuoles, right? There were cells which had a lot of vacuoles. And here again, cell and cell appearance, vacuoles, and we could appreciate, right? So definitely vacuolated cells. And I think 1 or 2 of them looked a plasmacytoid here, right? And binucleate and multinucleate cells. So to summarize, what did I see? Right here, these were the binucleate cells, right? And plasmacytoid and the vacuoles were seen. Now, here, there was a multinucleate cell. background did not have a matrix or a mucin. See some more areas which were there. So there were no acinar pattern. I think definitely you all agree. There were naked nuclei in the fragment, papillary fragments. They were all like clusters, right, with vacuolated or histiocytic-like cells and granular. Some of them look granular. Now these histiocyte-like cells had an eccentrically placed nucleus, frequent binucleation. There was absence of mucinous background. I tell you, when we just saw this first, we had a lot of arguments as to what to call this. I think, and I'll tell you what we had called it. We had just called it probably to do a ATP of undetermined significance, but it's definitely very cellular. So a mucoepidermoid carcinoma cannot be excluded. The surgeon went ahead and resected, and it was really multicystic areas we got. Lot of hemorrhage had been there, and pigment was there. And this was the section. We had the salivary gland here and vacuolated areas on this side. No? And the pigment I was showing you, but there were a lot of vacuolated areas. When we, right, more of the vacuolated areas were seen in them. Now, see the papillary clusters which we had already also got, and degenerating cells and the vacuolated cells. I had showed you a lot of things. Would this call on the histopath? Would I still think of a mucoepidermoid carcinoma? And luckily, another 3 months later, we had another case like that. Now, look at the granularity, eccentric nucleus, right? No mucin in the background. And this was the sections. Again, we had lot of vacuolated cells, and this was more solid. The previous one was vacuolated, sorry, very cystic, but this is more solid tumor. So the differential diagnosis, as we thought on cytology, were degenerative changes in any adenocarcinoma, but more of us were in favor of a mucoepidermoid carcinoma. Then some of them started saying, ma'am, it's granular, so we should call actinic cell carcinoma. And I had not seen vacuolate cells in actinic cell carcinoma. In that time, there was a variant of actinic cell carcinoma called cystic papillary variant of actinic cell carcinoma. But in the present classification of WHO, this would characterize a secretory carcinoma of salivary gland. It used to be called mammary analog, and no more. Now it's just called secretory carcinoma of salivary gland, which is a very rare tumor. I don't know how we managed to see 2 cases of secretory carcinoma. Now you need to demonstrate a balanced translocation by probably the newer ancillary techniques, and they say a pan-tropomycin receptor kinase on IHC. Now, secretory carcinomas are one of the tumors now extensively being studied with ancillary techniques. That it's not unlikely that we might have also seen them, but we have called them something else because we didn't know the rarity. That's why I said interpretation errors and the rarity. But now in the present scenario, this case would definitely go for suspicious for malignancy, or I think even malignant. Right, the category Milan system would be 6 for this. Now look at this quell, 60-year male parotid swelling of 2 years duration. Really cellular, tight, and you can also appreciate some nucleoli in them, right? Very tight clusters again, and you already start seeing necrotic material in your aspirate. Other areas were more necrotic material. So one tumor they teach you in salivary gland is a salivary duct carcinoma, right? On an aspirate to be called as, right? If you find necrosis and cells with marked atypia, prominent nucleoli, would favor a diagnosis of salivary duct carcinoma. More areas that we got, right? So either mucoepidermoid high grade would still be in a differential, squamous cell carcinoma, carcinoma ex pleomorphic adenoma, because these are more commoner than a salivary duct carcinoma if you take the relative probability. Now, what happened when the patient was, so it would have been called in the Milan system a category 6. They went ahead and resected. This was the specimen. You had a lesion here and a circumscribed lesion here. You will not believe what we saw. The above lesion here was a squamous cell carcinoma. Whereas the below areas, this is a squamous cell carcinoma, was a salivary duct carcinoma with lot of papillae, right? Micropapillae and necrosis. This virtually looks like a breast carcinoma, right? You had Roman bridging, you had ATPR, anything which looked like a breast tumor, right? You had lot of papillae here, micropapillae, sheets of cells and necrosis. So this was a squamous cell carcinoma and a salivary duct carcinoma. The patient had had a persistent discharging sinus and he had developed a squamous cell carcinoma on the cheek overlying the salivary gland lesion, right? For a squamous cell carcinoma, differential would be a high-grade mucoepidermoid, and for a salivary duct carcinoma, it would be a metastatic breast carcinoma, right? Now, when you look at pitfalls in salivary duct carcinoma, many of in the literature also they say it has not been diagnosed, right, as a salivary duct carcinoma. The cytological diagnosis would be malignant neoplasm, adenocarcinoma and all that. But now with more cases being studied and literature showing us the diagnosis and illustrative examples, we could think of a salivary duct carcinoma. Now, look, coming on to the next case was a 51 female parotid swelling increasing in size since 1 year. So the increasing in size was what made her come. It was a very cellular aspirate, right? There were a few mucus secreting like cells, right? And lot of mitotic figures, right? Lot of mitotic figures. So I'm sure on Milan system, we would have called this category 6, but subtyping becomes a problem in aspirates. Right, lot and prominent nucleoli, right? See, the mitotic figures were numerous, and occasional mucin secreting or vacuolated cells were also there. So we thought a mucoepidermoid high grade, oncocytic carcinoma, squamous cell carcinoma, right? So I would have worded it out malignancy, but subtyping is a problem, right? Because of overlapping with so many things. This was the resected specimen that we received. And look at that, it had lot of duct-like structures, abundant eosinophilic cytoplasm, secretions here, lot of mitotic figures, there were secretions here, right? You can find the duct-like structures. So it would not fit in for a mucoepidermoid, it was not for a squamous cell carcinoma. Oncocytic carcinoma probably, but lot of duct-like structures were there. It was not in sheets, and we also see them. Right, you get to see the duct-like structures, right? An oncocytic appearance. So an oncocytic carcinoma, adenocarcinoma is a probability, right? Again, secretions here. But there is a salivary adenocarcinoma, NOS, when we are not very sure what is the differentiation. It's usually a collection of orphans, they say. We could find infiltration beyond the primary tumor into the adjacent salivary gland. So it was an adenocarcinoma, and only the subtyping was a problem, right? I think I've been able to share cases with you and showed you some dilemmas and delights. And it takes a lot of years to collect cases like this because salivary gland is very rare, right? And I hope I was able to share my enthusiasm with you. So that just not to disappoint you people, I thought let me do a rapid fire, right? You may start firing me at the end of this session. Let's look at our first case. I need another just 10 minutes, ma. What was this? This was the aspirate. Sure, any of you could identify this here and here. No? This looks like a verrucate body. Now, palisading can be a issue or can be seen even in pleomorphic adenoma of the myoepithelial cells. So it was from the parotid. So we suggested a pleomorphic adenoma. And this was the excised specimen, separate circumscribed lesion and a normal salivary gland. You will not believe it. It was a schwannoma, right? So that's why I told you salivary from non-salivary lesions. In that location is a chance for us to aspirate and get a non-salivary entity. So this was a schwannoma. Now this was from a 40-year male patient, and we aspirated, I think I remember 5 slides. All of them showed adipose tissue, right? It was just on the cheek and we kept aspirating. So I was in a fix. In the present scenario of Milan, I should have called it non-diagnostic because I had nothing to tell me. It is part of the salivary gland. I had only adipose tissue fragments virtually in my smear. And I then got to see the ultrasound which had been done. They did a buccal ultrasound, right? And this was the lesion. They said, ma'am, we can pick up the lesion and this is the parotid. I didn't know what to do. I said, probably I've aspirated buccal pad of fat, but you can palpate in the patient. And when we went ahead, they went ahead and did a resection. Look at this. This was a lipoma of the parotid gland, a very, very rare tumor. And this was what we had been aspirating, right? So I would have called it non-diagnostic, but the clinician was insistent and it turned out to be a lipoma, which are rarely found in parotid, right? I hope just on a rapid fire, other than a salivary gland, I'm sure you all would have said, ma'am, this is a lipoma, aspirate. Now, this was a 60-year male. Patient had Bell's palsy and a parotid swelling. The aspirate was necrotic, large, lots of atypical cells. I'm sure if I had told you this is not from salivary gland, you would have all told me, ma'am, this is squamous cell carcinoma. And because being here, I must also think of a high-grade mucoepidermoid carcinoma. They were not happy with what we said, and they went ahead. They said it's a lymph node and excised it, and it was a metastatic squamous cell carcinoma to the preparotid lymph nodes, right? The facial nerve palsy also was there, and he had a Bell's palsy. So a metastatic lesion in that area can mimic a salivary gland lesion. Now, this was a 55 female aspirated from the parotid. A lot of spindle cells, so which is again a huge diagnostic problem, and there were a lot of lymphocytes in the background. I remember scanning. I didn't get any other cells other than these two in the background, and spindle cells and inflammatory cells. You want to see, this was the patient. She had a discharging sinus. They went ahead and decided to resect. And this was where we had been aspirating. We had been aspirating here. We got a lot of necrotic material, spindle cells, and lymphocytes. And from the specimen, when we gave sections, I didn't know what to call it. I said it's an inflammatory non-neoplastic lesion, right? And maybe it's a chronic sialadenitis, and patient is having a discharging sinus also. And from the sections, we got to see spindle cells in whorls, in fascicles, right, with lot of inflammatory cells. And it was negative for S100 and the ALK1 also. So we called it an inflammatory pseudotumor for want of anything. Now, but this was in a salivary gland. We had a lot of salivary gland tissue also here. And for the patient really did well after the resection. And when you see a lot of spindle cells with inflammatory background, another entity is Mycobacterium spindle cell tumor, but she was not HIV seropositive, and AFB stain was negative. If it's a mycobacterial spindle cell tumor, it would be AFB strongly positive, right? So I hope that case also seemed interesting to you. Now, this is a 30-year female. Definitely, no. They would have thought it's a salivary gland lesion and they sent her for aspirate. She had the swelling for the last 5 to 7 years, and they had been trying to brand it with hot iron, thinking it'll disappear. It was a hyperpigmented lesion. And the aspirate gave us tight follicles like this, lymphoid follicles, plenty of multinucleate cells in the background, and a lot of eosinophils. So because it was in the salivary gland region and involved, I just suggested an inflammatory lesion, and I couldn't even say it's a salivary or as sialadenitis. They went ahead and did a resection. Huge for cosmetic reasons. The skin over it was very adherent. It was parotid gland was here, and this was the huge lesion. You can see multiple germinal centers, hyperplastic follicles, and these were the giant cells which were there. They're called as polykaryocytes. In between were a lot of eosinophils. A very, very, very unlikely diagnosis. Post-auricular, 10 years, firm pruritic swelling, hyperpigmented skin. Now, all those are a feature or diagnostic of Kimura's disease, right? The hyperpigmentation is because of IgE, and the pruritus was because of that. She had lot of eosinophils and polykaryocytes in her aspirate. So, just be aware that it could be in the salivary location, but you might get non-salivary entities in your aspirate. It need not always be a salivary gland lesion. This was a Kimura's disease. Now, last case of mine. This was a 30-year female swelling in front of the ear lobule since 2 years. We aspirated, we saw fragments like this, tight bluish fibrillary material and a lot of neutrophils in the background. We had just suggested non-specific inflammatory lesion. We were not aware of what it was. My only mistake was the patient had an excision and she came back for the report of the excision. She had never come back to collect her cytology report. I did not take a photograph of the patient. She had still a residual swelling, or maybe because post-surgery. And I had absolutely no clue what this was. It happens. We might not have seen them. I had absolutely no clue. And we really had to think out of the box if we had to make this diagnosis. I don't know if anybody could even think of it. None of my postgraduates agreed to it also. But in retrospect, I think we had missed something. This was the feature. And excision was this, what we got. They had sent a small piece and we were very lucky. Called the triple layer infoldings. And till today, I'm always wondering how come we had missed it, or were we justified in missing it. This was a case of
Cysticercosis
in the parotid. After
my
I've
God.
seen this, I think we can see anything under the earth. Just hold an umbrella and anything. You're trying to protect yourself by staying under an umbrella, but no. And I even go back every talk of mine, people. I believe this should have been the identifying feature. You can look up in literature. It's very difficult to identify cysticercosis on an FNAC. Honestly, you will not believe me. I don't have a photograph of the patient. I should have taken it because she came quite late in the evening and she wanted a report. And I was surprised that she had come back for her report. And I didn't feel like embarrassing her to take a photograph. This was a cysticercosis. I tried to share my cases and my enthusiasm with all of you. And this was a cysticercosis. So I feel you learn how to see, realize that everything connects to everything else. This was a statement by Leonardo da Vinci. And a surgical pathologist's approach to tissue diagnosis makes for a better prepared cytopathologist. So all PGs, first years, second years, see your histopath slides. Only then you can be a better cytopathologist. Don't try to become a cytopathologist first and then learn histopathology. Especially any case, anywhere, the more time you people spend on your histopath, and the better cytologists you are. That's what I tell my postgraduates when they pass out. Ma'am, we are poor at cytology. No, don't worry. Your histopathology knowledge will always stand you in good times, right? And I've tried to share my enthusiasm and my cases. I'm always thankful to Dr. Vijaya and her team for giving me a chance again to share my experience. Any of you have any cases, you can always send it to me by email. right? And if I have seen them, I will definitely share them, my experience with you. And I hope I was able to communicate at least something useful for your exams and for your practice. I'm just not bothered about exams. I'm more worried about what you people write out after passing your exams. Because we may not be working in high centers, and this has come from a place for the last 30 years where we are the first responders virtually. They just send the clinicians whatever they want. They will not wait to get another opinion or another thing because the patients disappear. And they ask us to aspirate anything and everything. They excise anything and everything. And we cannot refuse, and we are jack of all and master of none. So I'm sure you will have to put in more efforts, and you will. Once you finish your exams and that hurdle, you'll all also start enjoying the slides that you see. Thank you. Thank you once again, Vijaya and your team. I hope I
Thank you,
was
ma'am.
able to
Definitely.
given a good time to your students.
Definitely, ma'am. Ma'am, that was so stunning cases. And I think you were in a very advantageous position because the clinician sent everything to you for aspiration. That is how I think probably you picked up so many things. And it was the Sister Circuses was the feather. I mean, that was the final hitter, I think.
Because we have 2 dental colleges in our place, and all these oral surgeons wanted us to aspirate, and they would send it to the medical college, So especially salivary gland lesions, I picked up a lot from them. They sent it to us, but our surgeons also did give us a lot of chance. And I don't know why we come from a dry area. Chettinad, even Chennai is dry. Ours is absolutely dry, and so we in a year we get at least 50 salivary gland tumors. Maybe most of them are pleomorphic adenomas, but 10 to 15% are out of the way, and we have my students have seen a very good collection. And I usually try to show cases we have seen, so the younger generation knows how we approached or how did we make an approach to these cases. And see all your smears, even as postgraduates, don't go and pick up the most interesting ones. No, you need to see every day, every aspirate that's coming on your plate. That
So
will
true.
stand you later on. Yes. Thank you, Vijaya, and hope
Okay, ma'am.
I
Thank
have
you so
another
much.
session and didn't keep you all waiting for a long time.
No,
I
no,
hope
no.
I was within 1 hour.
You finished it,
Yes.
madam. Definitely finished within
Yes.
an hour. And it was so good because cytohisto correlation in salivary gland is the toughest. We always look only at that. How many times I got my pleomorphic adenoma right? That is most important thing.
How many times? Mucoepidermoid carcinoma. Mucoepidermoid is one we never make, We are always hesitant. It's
and
very
I have
hesitant diagnosis.
misdiagnosed a pleomorphic adenoma as adenoid cystic carcinoma itself in son. Thanks to Milan system, we are saving. But as you rightly said, that atypical category, recently we called one as atypical because I didn't know where to put. The next third day I got the surgical specimen. It was this simple mucoepidermoid, which I couldn't diagnose in the. It was and a silolipoma also we.
Yes. Right, that's what. Silolipoma, at least on an aspirate. I never expected a lipoma to land up. And that came from an oral surgeon.
And schwannoma is also another great thing, madam.
Oh, lipoma was courtesy an oral surgeon because the patient couldn't chew on the inner side. She was insistent that they get it excised. And I said, no, I'm only getting fat in the aspirate. I'm not making any weird diagnosis on that.
Exactly.
It turned out to be a lipoma of the parotid. Thank you,
Thank you so much, madam. See you again tomorrow.
Yes, ma. Thank
forward
you.
to your session again tomorrow. Thank you so
Yes,
much,
ma'am.
ma'am.
Thank you. Thank you. See you all tomorrow.
Yes, ma'am. Thank you.
Thank you, ma'am.
Thank you, ma'am.
Jane?
Yes, ma'am. Thank you, ma'am. Thank you, all the delegates, for being with us and being a part of the first day of CARE-PARE. Kindly log in tomorrow. We will start our first session at 8 a.m. See you all soon. Thank you.
Thank you.
Thank you.